Hello, my name is Marla Garino, and on behalf of the Buffalo Niagara Medical Campus, I would like to welcome everyone to the BNMC's inaugural Food as Medicine Symposium. Our health and well-being team has worked hard to put this conference together for you today, and we are glad you are here with us. I know some of us are from Buffalo, but we'll be having people join from all across the States and Canada. And we weren't anticipating this to be virtual, and the format has really let us reach the masses, which we're pretty happy with. The BNMC has expanded its work into the food as medicine space after nearly 2 decades of working in healthy food access, food systems, and food policy projects. Since 2002, the BNMC has received over $2 million in grant funding to increase access to healthy local foods through systems, policy, and environmental change-focused initiatives. It has become clear in our work that the best formula to fight disease in our population is through partnership. By working with our local food, farm, community, and healthcare partners, our work has grown and expanded in ways we could not have done alone, including in moving into this food as medicine space. We hope no matter what sector you represent today, and whether you are local to Buffalo or beyond, that you learn, engage, and take action in joining the local food as medicine movement in your community. The food as medicine movement is now a thing. You hear about it everywhere, and rightfully so. It really deserves our attention. Experts in the field have been working for decades, publishing research and advocating for policy change, starting and growing nonprofits to implement medically tailored meals, writing grants to fund food prescription programs, as well as attending to the larger focus of food justice and equity. We are fortunate today to have these pioneers with us who can share our journey and help guide our actions. What we know is that food is medicine. It can prepare a body for lifelong vitality, align our mental health, reverse disease, and aid in recovery. The evidence is clear, and health practitioners who expose themselves to the data are eager to implement. Unfortunately, there are still so many barriers in making this into the mainstream care. To change, we need to integrate networks, develop our partnerships, continue research, and advocate. We have hopes to build upon this first symposium together and continue this yearly. The field is so vast and so deep. I'd like to think in 5 years' time, we can look back at this moment and see today's visions becoming tomorrow's reality. How many more partners will we have? How many more successful intervention programs will there be? How many more lives will have been saved? Everyone should have access to healthy, culturally appropriate foods in their homes and in their care. It's a basic human right to be nourished. Diet-related disease is the leading cause of death and disability and is completely reversible and preventable through food. Let's affect change in our region's health by integrating nutrition into regular patient care. We have a packed day ahead. After our joint keynote address, we will have 2 panels on the importance of nutrition and medical education. Following this, our lunchtime session is a delightful look on the growing and preparing of a nutritious, delicious meal with a discussion on how to use food for your health and how to engage with your practitioner when making lifestyle changes. After lunch, we will have national and local experts discussing food as medicine interventions and food equity, followed by a panel on the importance of partnership and collaboration among healthcare and community organizations where you can learn about successful local programs. We finish the day with 2 engaging breakout rooms discussing future collaborations and transforming the food system for health and equity. Our job today is listen, learn, and interact, and then form plans and take action. Whether you are here for yourself and your family's health, or trying to make systematic changes in your organization and institution, we hope today will inspire you to take this movement and make it a goal. Magic happens when you join people together who care about making a difference. And we have a wonderful group here today. Before we begin, a bit of housekeeping. Please keep muted unless in a big breakout room. We would love to see your video, but we understand if this isn't possible. We will be monitoring the main chat for questions, so feel free to fire those away. Please make sure that your chat is set to reply everyone for those questions. To gain knowledge about what we can do in the future, we have set up a mural board, and the link will be shared in the chat box. Think of this as an open suggestion box available to you throughout the day. Here you can comment on who else needs to be here, what you have learned, and what we should do for future meetings and symposiums. We really welcome your input. And so now on to our keynote address. We are very honored to have Karen Pearl of God's Love Deliver in New York City and David Waters of Community Servings in Boston, Massachusetts, here to discuss the critical role of research and advocacy from practice to policy. I'm going to give you a little bio of these two wonderful people. Karen Pearl is the president and CEO of God's Love We Deliver, and she joined the organization in September 2006, bringing with her over 30 years of experience in nonprofit leadership. Since its founding in 1985, God's Love has responded to the urgent need for food and nutrition experienced by people who are too sick to shop or cook for themselves. People living with life-altering diseases such as HIV/AIDS, cancer, multiple sclerosis, Alzheimer's disease, and end-stage renal disease and advanced diabetes. During her tenure, Karen has expanded the organization's capacity, increasing meal numbers by 100% and growing its advocacy programs significantly to ensure access to services for those most in need. The number of volunteers have grown to over 17,000, and the number of meals cooked and delivered is at a new milestone of over 2.4 million in a single year. God's Love operates with an annual budget of over 25 million, which is 65% raised through private philanthropy. Under Karen's leadership, God's Love was the winner of New York Times Nonprofit Excellence Award in 2010 and winner of New York State Department of Health Social Determinants of Health Innovation Award in 2018. Karen is the chairperson of the Food is Medicine Coalition, a national association of nonprofit, medically tailored food and nutrition services providers seeking to integrate into healthcare for critically and/or chronically ill. In 2018, Karen received a City State Women's Leadership Award, and in 2019 was named one of Crane's notable women in healthcare. David Waters is the CEO over at Community Servings. He's been involved with Community Servings since its inception in 1918, moving from volunteer to board member, board chair, director of development, and eventually CEO in 1999. You know, it's so funny to hear 19 again. So 1999. Under David's leadership, Community Servings has evolved from small neighborhood meals programs delivering dinner to 30 people to a critical regional program providing 15 medically tailored meal plans to 2,300 people with acute life-threatening illnesses, their dependents and caregivers across Massachusetts. An advocate for integrating accessible medically tailored meals into the healthcare system, David has formed partnerships with leading healthcare payers and providers to better link clinical care and social services, designing some of the country's first health insurance contracts for prescription meals. With 25 plus years of experience in food service management, David also created the highly cost-effective fundraising event, Lifesaver and Pie in the Sky, a Thanksgiving pie sale duplicated in cities around the country. He is the former board chair of the Association of Nutrition Services Agencies and is a founding member of the National Food is Medicine Coalition. In recognition of his leadership and impact at Community Servings and within the greater Boston community, David was named a Barr Foundation Fellow in 2017. A resident of Cambridge, he holds graduate's degree from Middlebury College and Boston University. So Karen and David, we're so pleased to have you here, and we're going to let you take it away.
Thank you so much. Really appreciate the introduction, Marla, and it's a pleasure and an honor to be with all of you here today. Since you have so thoroughly introduced David and me, I think we're just going to jump in if that's okay. David, is that good with you?
Sure. Yep. That's great.
Okay. So just let me share my screen and we will be off and running. I don't know why it just told me that that's disabled. So give me a moment. Oh, you have to stop sharing yours, Marla, for me to do it. Sorry. There we go. Okay. Give me one more second just so I can put this into the slideshow and we're off and running. Okay. That's great, right, David? You can see that?
Yes, that's great.
Okay, so David
Thank
and I
you.
are going to be speaking to you today about the critical role of research and advocacy from practice to policy. And I read that whole title because I think it's important that some of what we're talking to is grounded in our practice. So we will be covering a variety of, just very lightly on what our practice is. But I'm going to start with a bold vision. And that vision is that we are never going to reach our healthcare goals of improving outcomes, lowering costs, and creating equitable access without fully integrating the medically tailored meal intervention into healthcare. And that's what we do together, David and myself and our colleagues in the Food is Medicine Coalition, where we have 4 important goals that we see as completely intertwined. So one is the providing of the evidence-based medically tailored food and nutrition intervention to people who are critically and chronically ill, to advance public policy that supports access to food and nutrition, to promote research on the efficacy of food and nutrition services on health outcomes and cost of care, and ultimately to share best practices that informs all of that, the giving of the service, the research, and the policy. And we spend a lot of our time together doing that. So I want to go the next step of defining food as medicine, because I think it's important that we have a shared understanding and a shared vision. And while David and I are going to talk a lot about the medically tailored meal intervention, we very much recognize that food as medicine is a spectrum of services. It is not only what we do. It includes prescription produce programs, potentially boxes for diabetes, and ultimately on the right, you will see medically tailored meal from community servings, actually. That's a real meal. So we like to think about this as the food pyramid. And the food pyramid starts with the base of the pyramid, which is, as Marla said, everybody in this country is entitled, I would say in the world, to healthy food for those who are food insecure or malnourished. That food has got to be quality food that nourishes people, not just fills their belly. And that is something that I know probably a lot of you on this symposium are, in fact, doing and thinking about. But as you go up the pyramid, and the reason we picked a pyramid is that the sides get smaller, so the populations get smaller, is those who are at risk for acute or chronic illness. And they may benefit from things like prescription RX, or they may benefit from food vouchers, or they may benefit from a variety of other interventions in the community. And as you go up, you then get to the medically tailored food for those with acute or chronic illness. These are people who really need specialized diets, but they're able to take food and cook it for themselves and make it into a meal. And those might be diabetes boxes, those might be other kind of grocery interventions. And then at the top of the pyramid, the smallest population, which is the one that David and I have devoted so much of our professional lives to, is the medically tailored meals for those who are living with serious illness or disability, who simply cannot shop or cook for themselves. They can't stand, they can't walk, they can't carry, they can't do all the things that you need to be able to do to get groceries and then to turn them into food. And that's why for these clients, the medically tailored meals delivered to their homes are essential for their health and well-being. Oh, I think I went the wrong way. I'm sorry about that. And we're not the only people, as Marla said in her introduction, who are thinking about this. We work in collaboration with many, many other organizations, both in our states and across the country, defining what it is for all of those different interventions within the pyramid, and then also hoping to set the standards, which we have done for medically tailored meals through the Food is Medicine Coalition, but to set the standards for what these different interventions are and what they are good populations they are good for, and how in fact we can support people as they potentially experience food insecurity all the way through very serious chronic and life-threatening illness. So with that, I'm going to turn this over to David for the next piece.
Great, thanks, Karen. Karen and I present a lot together, and it's always joyful to do it. So thanks, Karen. I think we can go to the next slide.
Great.
I think one of the things that Karen hit on that I want to reinforce is that medically tailored meals, there are, in that pyramid, there's also an upstream, downstream component. You know, if you're improving the health of a wide population in order to see improvements in health 10 years from now, or they don't develop an illness to prevent it, it's really a prevention model. But medically tailored meals is, I think, so exciting because it's really a treatment regimen. It's giving the doctors, the care team, another tool in their toolkit. It's not replacing healthcare regimens, nor is it replacing pharmaceuticals. It's a complement to those. And so with that, we, over the last maybe 10 years, have worked to develop the same level of rigor that you might see in other healthcare interventions. So, you know, that starts with HIPAA compliance and research and understanding the length of the intervention and the dosage, you might say, of food, all of those things. So the intervention, this is a graph from God's Love, but the intervention in both cases applies. It starts with a referral from a care manager, either at a hospital system, doctor's office, or oftentimes a health plan. And they're generally referring their high-cost, high-need patients, those who are the super utilizers. And I'll just tell a quick story of a client who was on food stamps on SNAP, and every month when her SNAP benefits ran out, her blood sugars went out of whack. She picked up the phone and dialed 911. The ambulance came, took her to the emergency room, stabilized her, and sent her home every month. She got on to Community Serving's medically tailored meal program, and in the first 6 months, never picked up the phone to dial 911. So huge savings in ambulance usage, in ER visits, in hospitalizations, et cetera. So that referral comes from a care manager and goes directly to our own registered dietitian nutritionists who have access not to a full EMR, but have access to the diagnosis, the scripts, the prescriptions that patients are on, their basic labs like A1C levels, that kind of thing, as well as activities of daily living that Karen referred to earlier. Can they walk to the store? Can they carry a bag of groceries? Can they stand at a stove for 15 minutes? And from that, we would determine whether they are sick enough to need our meals. The poverty question often comes up. These tend to be very poor populations, but that's not how they qualify for a medically tailored meal intervention. Any of us would qualify for this if we were unable to provide a complex diet for ourselves or someone we loved. From that, our kitchen gets going, and they're making meals, and the two key things to the intervention is that sick people have no appetite. So if we bring them mediocre food, they're not going to eat it. So the medically tailored meal model and the Food is Medicine Coalition embraces scratch cooking to really bring the foods that we grew up with, that our grandmothers made, that are free of sodium and chemical additives and preservatives, to really be a beautiful food intervention that motivates you to eat. But then we tailor it to the patient's particular needs, and you'll see that in a minute. But what I think is most important is that it's not as simple as a diabetic diet or a vegetarian diet or something like that. These are multi-layered diets, much like a prescription, to give the patient exactly what they need, because the majority of the patients have multiple comorbidities. These are very sick, expensive patients. And from then, those meals go out onto our delivery vans. Typically, it's a weekly delivery of chilled and flash frozen meals. For the patient, it can be an intervention anywhere from 10 meals a week to 21 meals a week. Oftentimes, we're feeding the whole family because we know that if you bring a single meal to a sick parent, they're going to give it to their child. If you bring one meal to an elderly, frail couple, they're going to split that meal. So if you want to have the impact on nutrients on the sick patient, you have to take a holistic viewpoint whenever possible, based on funding, to feed the whole family. From that, the clients are going to enjoy this meal. They're going to have access to our RDNs for nutrition coaching and counseling and education while they're on the service. Our team are communicating back to the healthcare team on did they get their meals? Is it the right diet? We're hearing if the meds changed and we need to change the diet. It's really a partnership between the medically tailored meal provider and the rest of the care team. And what's key for you all is that the research shows that we have proven that there are reductions in medical spending in as few as 12 weeks, improvement in outcomes and reduction in costs in just 12 weeks. Next slide.
Sorry, David. Yeah, there you go.
There you go. So 2 examples of how we do medical diets. This first slide is Boston, community servings, and the second is New York. Very similar, some subtle differences, but to give you a sense, in Boston, we do 15 or more different medical diets. We've just recently started moving into maternal health and pediatric patients. And so those diet plans are growing. Right now, you see on the slide, they're just a children's wellness, but we also have both a diet for weight gain and weight loss for pediatric patients. But you can see the range of diets, and what's important here is what's on the right, is the multiple layering of diets, because, you know, I always use the example of my best friend that I'm sure you would recognize this profile. He had out of control diabetes, significant, had always had significant weight. That led to blindness, kidney failure, neuropathy, heart disease, strokes, inability to work, inability to walk. He needed a diet that controlled for glucose, potassium, phosphorus, vitamin K, and sodium. And he was a talented cook. But how many of us could, you know, leave the conference today and go to Whole Foods and plan that kind of a menu? Unless you were a registered dietitian, the system sets you up to fail. A doctor might tell you to do that, but even they don't understand what's going on in your household and whether that's feasible. Can you get to the store? Do you understand what it is you have to cook? And that's really the role of MTM, is for people who can't do that for a short period or a long period. Next slide. And here's New York's version of the same. Oops.
I'm going back. Sorry about that, David.
No problem.
Very funky little thing today. Okay.
Here's New York's version of the same. You can see, allergies around shellfish, nuts, chocolate. What proteins can they have? What age group are they? Do they need high fiber, low fat? Do they need high calorie, high protein for wasting, which could be HIV or could be cancer? And in New York's case, they also do texture modifications. Whereas Boston would offer a soft diet, in New York, they have the ability to do a soft, a minced, a pureed, which is particularly important for patients with cancer and dementia. And you just start to see the complexity of food and the complexity that we can offer the healthcare team to bring exactly what you need to eat. We've all heard stories of, even in a hospital system, where a hospital kitchen can't necessarily do multi-tailoring. You can have a diabetic meal, or you can have a cardiac meal, but you can't have both. You can have a renal, but you can't have cardiac. It has too much sodium. So this intervention is really unique and really important to the care of high-cost, high-need patients. Next slide. So with that, we jump to the research. And just to give you a context, so programs like God's Love and Community Servings and others around the country in our coalition grew out of the HIV epidemic, and specifically funding through Ryan White Care Act, federal money that provided wraparound services for HIV patients that were really at the forefront of what we now think of social determinants of health, providing, thinking about housing and legal services and care management and case management and counseling, all of the things that you could offer in an HIV world, including food, that you couldn't in other disease groups. When we realized collectively that the same intervention was appropriate for people with other illnesses, the only payment mechanism for that was philanthropy. And we've, like New York, we've had tremendous support from generous donors. But in Boston's case, we were almost always carrying a waiting list, and we were serving only a part of Massachusetts. We were, at our largest, we were serving 25 cities out of 300 in Massachusetts. So there was always more need. And in Boston's case, in community servings, we held a healthcare summit just after the passage of the ACA, the Affordable Care Act, and said to healthcare colleagues from Blue Cross and big hospital systems like Partners, MGB, et cetera, that you ought to pay us to do what we do because we think we're part of healthcare. And they said, we understand the moral argument, we understand the clinical argument, but unless you can make the business argument, unless you can prove an ROI, we can't redirect funds towards this because we don't have enough resources to do what we're already doing. So many agencies like community serving set out to do important research, specifically early on that ROI. Next slide. So as you'll see in a minute, community servings research and colleagues around the country have done similar work, has been able to demonstrate a 16% reduction in monthly healthcare costs. And these aren't just our internal numbers. These are partnering with the state, partnering with Robert Wood Johnson Foundation, peer-reviewed journals, et cetera. 16% in 2 different studies, reduction in monthly healthcare costs. 72% reduction in admissions to skilled nursing facilities, and a 49% drop in hospitalizations. All expensive services, all directly relating to high-cost, high-need patients. In addition to that, ambulance usage, ER visits also saw major drops. Next slide. So the Food is Medicine Coalition has a fabulous research committee and collects a library of studies around the country, around the world, related to nutrition and healthcare. And here are just, I'm not going to read all of these, but first program is in Denver, the second one is in Philadelphia, the third one is in San Francisco, the fourth is in Boston. And you can see in their studies and where they were published, similar results to those I shared in Boston. 50% drop in medication adherence, a 50% drop in hospitalizations, really impressive attention-getting research results. I wanted to walk you through Community Serving's largest study, which often gets the most attention because it had a large N. Next slide. So some of you may have read our study in the Journal of the American Medical Association's Internal Medicine, which was published in April of 2019. It was a study that was funded by Robert Wood Johnson. It was done in partnership with our research team at the University of North Carolina, Dr. Seth Berkowitz, as well as Mass General Hospital and Community Servings. But it was also done in partnership with the State Department of Public Health because we needed to get access to the all-payer claims database if we were going to do serious research around this. So with them, we were able to look retrospectively at 800 patients that we had provided meals to, and to look at their claims data from the time before they were on our service and the time they were on our service. And what you saw was the number that we talked about, 16.4% drop in medical costs, significant drops in hospital admissions and nursing home admissions. And with this, Community Servings, like God's Love, now has 17 insurance contracts with different payer models. Next slide. And so where are we going from here? At community servings and our research team, again, Dr. Berkowitz and Mass General Hospital, we feel like we have sufficiently proven the argument for an ROI. And so the second piece of that is looking more at clinical outcomes, or, I don't have a degree in public health, but what I would say is like testing a pharmaceutical intervention, a new drug, you would look at what's the length of intervention, what's the dosage, which disease populations, are they the same across the board? And that's what we want to do with our clinical studies. So community servings was incredibly lucky and privileged to get 2 NIH R01 research studies last year that are 5-year studies from the National Institute of Diabetes and Digestive and Kidney Disease. $6 million to look over 5 years at patients in one study for type 2 diabetes and in the second for patients with HIV and diabetes. They're RCT studies. They're going to, there's a control group in each case that are receiving other food interventions. And we're really excited that we are now recruiting patients for those and starting to collect data. And there, I'm going to pass it back to Karen.
Thanks, David. So the research, as David said, was absolutely essential for making the policy case that the medically tailored meal intervention is a low-cost, high-impact intervention that should be seen by policymakers at state levels, sometimes city levels, and federal, as something that they should be supporting and should be integrating into the healthcare landscape in their different jurisdictions. And we learned this kind of the hard way among our colleagues in the Food as Medicine Coalition. And this is the hard lesson back to the last time Ryan White was reauthorized. Ryan White is literally the only funding stream in the country, federal funding stream, that supports food and nutrition services for people with any illness, and that is for people living with HIV. And what we learned is when that was reauthorized in 2005, Congress cut food out. Why did Congress cut food out? Because the food and nutrition people weren't part of the policy landscape. Oh, sorry. They weren't in the halls of Congress. They weren't writing letters. They weren't making phone calls. They weren't doing visits. And we very quickly pulled together as organizations all of our efforts and some money, got together with a lobbying firm who did all those things that I just said we weren't doing. And what happens? Food was put back into Ryan White. And that was an enormous wake-up call that said, we can't ignore the policy side of our work. We're so busy cooking and delivering, we don't have time to think about the policy, but we must. If we don't, we do it at our own peril. So we started working together on building the capacity to do advocacy among all of our organizations, and then really investigating the different landscapes in different states, because healthcare is often federally funded, but implemented at the state level. And so we looked at the landscape, and many of us have made progress, which I will tell you about. So our overall goal after all of this work and the capacity building that we've been doing is really to have a vision that says, in the United States, anyone in need of the medically tailored meal intervention should have access to it, regardless of their ability to pay or where they live. And that has become even more important as we have focused more and more on the health equity lens, or through a health equity lens, that we can't have two systems, one that you can get access to if you have a lot of money, or if you happen to live in a big city like New York City or Boston, but we've got to start to close those gaps. The other thing is that anyone who's at risk of or in early stages of nutrition sensitive disease should also have access to tailored health promoting food through the medically tailored food assistance that many of our members are engaged in. And those two things guide our work and guide our policy agenda and guide the work that we are doing at the state levels and at the federal level, and for some of us at the city level. God's Love has been involved with healthcare from the very beginning, because as David said, all of our clients come to us with some kind of healthcare referral that says this person really needs medically tailored meals. But we've also been involved on the payer side since 2005. And now we have over 25 contracts. It's a growing number as New York City and New York State continue to innovate with different opportunities that are available. So we have our longest term contracts are in the Medicaid managed long-term care space. And of course, not surprisingly, why is that? Because New York State did a waiver to the federal government that said, we want to pay for home delivered meals for people who are in long-term care, because we believe it keeps them in their home where they're safe and happy. And so it is a reimbursable service. And so it is used a lot in New York to ensure that people have the nutrition they need to stay as healthy as they can and to be in their homes. And that has been ever more important as we look now toward COVID, where our clients who are already the sickest of the sick, as we sometimes say, are most vulnerable. They're the ones, if they got COVID and got hospitalized, probably would not have very good outcomes. So we are very conscious of making sure that we do as much as we can to keep people at home. That has evolved to opportunities in mainstream managed care for Medicaid, and then in the Medicaid Advantage programs and the Medicare Advantage programs now, which I'll talk about a little bit more in detail in a moment. New York State has a HARP program, which is Health and Recovery Plan, and that is for people with behavioral health issues, which we are now branching out into. We have a new program for veterans living with PTSD. We have a lot of programs with HIV. We're in the Child Health Plus market. And most recently, we have had our first application for in lieu of services approved by the New York State Department of Health, which I'm happy to tell you about. But basically it says, if you take medically tailored meals, if you give that to one of your members instead of a traditional service that is paid for by Medicaid, then you will still be reimbursed for this new thing, as long as you can prove that it's cost effective. So through the application, we were able to prove that it was cost effective. And now we have plans referring to medically tailored meals in lieu of some other kinds of home assistance that people were getting to cook food for their members. The food really, truthfully, wasn't really the right food for that person. So it's a wonderful trade-off. They're getting the right food. The plan is also getting reimbursed. And those of you who are in New York, many of you are, because I know you're based in Buffalo, value-based payment is like the hot thing. And so because of that, we have many, many, many value-based payment programs. So in our last year, as you can see here, we provided over 600,000 meals to over 3,000 clients, and that part of our work continues to grow. David has a different story in Massachusetts, which I will let him tell you, and then I'll come back to say more about advocacy and policy.
Thanks, Karen. You know, I think because most of you are in the Buffalo area, you probably recognize that New York and Massachusetts are both two leading the field as innovations in healthcare and healthcare payment models. So I just want to share what's happening in Massachusetts. I said that we have 17 contracts, and I should say that with those 17 contracts, we expanded just a month before the pandemic started to serve statewide. So we serve the entire state of Massachusetts, and as of next month, we will start serving Rhode Island as well with a new ACO contract down there. A Medicaid contract. But what's really exciting about the Massachusetts model that I don't know if it is on your radar screen is that the state Medicaid organization, we call it Mass Health, went and got an 1115 waiver from CMS, from the federal government, to put all Medicaid patients in Massachusetts into, or almost all, into 17 different ACOs around the state. But what they also did that is relevant to this conversation is that they created the Flexible Services Program. It was originally a 3-year program. They're now asking for a 5-year extension. And it was $149 million that wasn't part of other healthcare dollars and could only be spent by the ACOs on either housing interventions or nutrition interventions, partnering with what they call SSOs or social service organizations like community servings. There are a number of exciting programs working with individual ACOs, but community servings and the medically tailored meal model is exceptional in that we have contracts with 11 of the 17. There's no other SSO that has more than 1 or 2 contracts. So it suggests the adoption and the recognition of the importance of MTM as an intervention. So we're getting reimbursed. We negotiate a contract. We work out our data agreements. We built a bi-directional referral portal where the care managers can refer directly into our database, but they can also pull the data back out when they need to report to the state. It's the largest test, I believe, it's the largest test of medically tailored meals anywhere in the country because it's running across 11 different healthcare platforms, 11 different plans. And so each of those has responsibility to give data back to the state. And we have developed a coalition with the state and with the Tufts Friedman School of Nutrition to do an evaluation on the specific data. And in this case, we'll have access to both clinical and cost data, which is really exciting, but is a major model, I think, for around the country. Karen?
Thank you, David. So for the remainder of our time together, I'm going to focus on the call to action that Marla asked us to make sure we included. So I'm going to get a little bit into the weeds about some of the opportunities. But the one thing I did want to clarify, because I just looked at the chat for a moment, is there's a lot of federal money around food and or nutrition. It's not there for people who are sick. And that's a different issue for us because that is the integration with healthcare. And I just wanted to make it clear that I wasn't trying to say that there's no money for food. It's just that the money that's out there is really not targeted to helping sick people stop that cycle of going into the hospital, coming home, going back, coming home, going back, going to the emergency department, because that is in fact what is so costly. And that is what the research is showing is being reduced through the intervention of medically tailored meals. So if I start at the bottom of the slide and work our way up, I've already mentioned that Ryan White is the only source of comprehensive funding. We're working to change that. And that coverage in Medicaid is really very state specific. And that's why I just told you about some of the things in New York State. David told you other things about what's going on in Massachusetts. There are a lot of opportunities for states after the very basic Medicaid program to then make decisions about either waivers, about expanding. So it's not surprising that the states that have the greatest innovation in Medicaid are the ones that expanded Medicaid under the Affordable Care Act. And so it's very hard to work together as a coalition across the country on Medicaid. We're all doing that in our own states, which brings us to Medicare, which is a federal program, as you know, for the elderly and disabled in this country. And in traditional Medicare, there is no coverage for meals or home delivered meals for 2/3 of the Medicare beneficiaries. Those are the regular Medicare beneficiaries. The other 1/3 have chosen to be part of Medicare Advantage programs. And those programs offer their Medicare members a number of different services. Each of the Medicare programs at the on the ground level through the plans puts together a different kind of portrait or array of different services. So they can, in the Medicare Advantage program, they can opt to include meals as a supplemental benefit for certain beneficiaries, often under very narrow circumstances. So that's an option for 1/3. So it doesn't even cover 1/3 because many of those programs don't opt to do that. So when in fact there is a model that achieves savings and maintains or improves quality, CMS is then able to authorize the expansion of this to the full Medicare program. So we have been working very, very hard to create the opportunity to demonstrate that medically tailored meals do in fact improve quality, lower costs, and save money for the whole system. And we've done that through a lot of work with many of our elected representatives. One of our greatest champion comes out of David's state, Representative McGovern, and he has just put out the Medically Tailored Home Delivered Meals Demonstration Pilot Act of 2021. And through that demonstration pilot, we're hoping to meet that goal of demonstrating to Medicare that that's in fact, that this intervention is worthy of much broader expansion. So the demonstration will operate in 10 states over 3 years. The states and the sites have not been chosen. It will run through the hospital systems, partnering with a social determinant of health, medically tailored meal provider, and that it will affect only certain conditions. And you can see those on the right: CHF, diabetes, COPD, you can read them all. And people will members will receive a minimum of 12 weeks of at least 2 medically tailored meals a day, as well as one-to-one nutritional counseling, medical nutrition therapy. So it's a very comprehensive intervention. It does mirror the medically tailored meal intervention that is already being done by many programs. David's and mine is just 2 examples. We are very, very excited that Representative McGovern is going forward with this and has a bipartisan group of House members who are supporting that. So this is where you all come in for the call to action. So you can ask your member of Congress to support the Medically Tailored Home Delivered Meal Pilot Act of 2021. And we do have materials, if you need them, that we can make available to you that lay out, basically, it's the slide beforehand that describes what the act is and why they should support it. And then Representative McGovern, who also chairs the Rules Committee, worked with his colleagues who chair all of the House committees to submit a letter. All 25 chairs signed on to President Biden asking for a White House conference on food, nutrition, hunger, and health. It will be only the 2nd conference ever on food and hunger and nutrition, and the first since 1969. And we are delighted that it will include health. So it will not just be focusing on the food supply and what foods are available for food insecure people, but it is a recognition of how far we have come to now be looking at the whole pyramid, if I may go back to that, from prevention to treatment, and the critical importance of food and nutrition in not only dealing with the crisis of food insecurity in our country, but dealing with the crisis of out of control healthcare costs for relatively not stellar health outcomes. And we believe we've got a solution that will change that and that will ensure that people over time, through the expansion of Medicare and ultimately Medicaid, which is mostly for the poor people in our communities, through the expansion of both of those streams, as well as private insurance, which often follows Medicare, we will in fact be able to create much healthier communities and create longer and more sustained lives for people who are living with severe and chronic illness. And we really do hope that you will join us in that effort. So with that, David and I are both open to any questions or comments you might have.
Thanks, Karen.
Thank you, Karen and David. I'm going to look through the chat here.
Mm-hmm.
They've been, you've been kind of answering them through, which is great. I've been seeing a lot through the chat, kind of a back and forth. I do have somebody here. Do you have Allison's?
Yes, giving more detail as to why the program will operate through the hospital system.
Can you give more detail on why the program will be operating through the healthcare system? That was our hospital system.
Yeah, I can start with that because I just typed it while Karen was speaking, and then
Okay.
Karen can chime in. I think that, Allison, the reason what I said in my note was it depends on what you mean by through the hospital system, but most critically ill patients are getting their care through a hospital and not through a community health center when they've reached that level. So referrals through the hospital system as well as community health centers and private practice is incredibly important, but the sickest patients are probably tied to a hospital. Just one other point, which is that hospitals nowadays are getting dinged for rehospitalization rates. Food and poor nutrition is one of the largest, it has one of the largest impacts on those rehospitalization rates. So we're now seeing a lot of referrals for post-surgery patients or partnering directly with home hospitals to provide meals while the patient is in the home hospital model, et cetera. Karen?
The only other thing I would add is that it is not necessarily the choice that we would have made, but it is the way to move the legislation. So the food will be done by a community provider, not the hospital system. It's this that the hospital will be doing, finding a lot of the clients and helping with the referrals and to some degree helping with the research, because all of this will be greatly studied.
We do have a couple more minutes. If anybody wants to ask a question, you can hold your hand up or unmute yourself at this time. We probably have enough time for 1 or 2 questions.
I would just like to say thank you. It's incredible, exciting work, and appreciate you sharing this information and the reference and resources so that we can learn from what you've done, model what you've done, not reinvent the wheel, start building a hub here in Buffalo and use you as a support structure in advancing our community. So thank you.
Quite welcome.
I should also put in a plug that as we move out of large urban areas and we look to a national model, we're looking to both spawn more medically tailored meal programs, but also we've developed a really effective shipping model where a large kitchen like God's Love in New York can ship to a much larger area, particularly with rural or suburban patients where it might be hard to get a delivery truck out there. In Massachusetts case, we can serve the western edge of Massachusetts, eastern border of New York, because we have a strong shipping model as well.
Yeah, and David, you just answered about the rural, but there was another question from Dr. Cappuccino asking, do you work with farmers in here?
Yes.
If you could speak to that.
Yeah, I would say Karen can answer this too, but in Boston, we have a really large food reclamation program where we're taking farm seconds, or what they sometimes call, ugly vegetables, the quality product that isn't able to be sold comes into our kitchen, and we have large volunteer teams that can clean and chop and process all that. We also work with farmers markets at the end of the day in a similar way. And I should just say in Boston, we, in addition to doing medically tailored meals, nutrition education, and counseling, we also have a job training program where we take people with barriers to employment, mostly coming out of prison, or recovery programs, and teach them how to work in the food business, but they help us make our meals for sick patients at the same time. So it's a really beautiful extension of the work that we do.
Wonderful. We had a comment. Thank you for sharing. I'm joining from Canada and would love to mirror this with indigenous communities, especially with traditional meals. I just love that. I'm sure that Karen and David do as well. there is one more question that I can take.
I
And
can comment on that.
yeah,
Definitely from Canada, drop me an email because our colleagues in LA are doing just that with an indigenous population out in Los Angeles. And it's just what they did, an amazing presentation on our symposium, and they're doing really beautiful work together. And I'm sure we can connect you.
excellent. So the last question, do you ever experience opposition from processed food industry in your advocacy work or Cattlemen's Association, some of the bigger lobbies?
I can
stop against them.
Yeah, no, we don't really, but I don't think that is, I want to say meaningful, but give me a moment to describe what I mean by that. I think they're doing a lot of work lobbying to keep their position. So they're not going after us per se, but they are making sure that their stream is not really interrupted. But having said that, we also know that there are many food companies that are developing healthier alternatives because they also see the trend. People want to eat better food and they want to eat more nourishing food. And I think the greatest challenge around that will be cost, because obviously one of the reasons our food supply is so, in my view, inadequate is because that's how you get cheap food. I did also want to comment, if I may, Marla, about another comment in here about medical school and what doctors learn. I couldn't agree more with, again, whoever wrote that comment. It's up a little ways. One of the things we do at God's Love is we partner with some of the medical schools in New York City to train their residents about food and nutrition. Now, obviously, it's not an RDN degree. They don't have that much time, but currently, I think people spend in their 4 years of medical school about literally 20 minutes on food and nutrition. So this puts them through a whole program where they learn a lot about food and nutrition. And I have to believe that their growing appreciation for food and nutrition as we're minting new physicians will result in much easier referrals for quality medically tailored meals and other interventions as well. Because I think for so long, medical, particularly physicians, thought food was something like other people had to take care of. And I think they're beginning to understand the food and health connection very, very strongly. Many already do, of course. And the more we can put that forward, the stronger the whole opportunity will be for people who are living with illness or at risk of illness.
Can I just add one more thing about the conversation about big food and cattlemen? I think this sort of informs the rest of your conversation for the day as Karen and I exit stage left, which is, as Marla said, food as medicine is sort of a hot concept, but that means that a lot of people are going to co-opt it. And particularly big food, speaking generally, is already trying to co-opt it because they use words like healthy and organic and things all the time, very loosely. I think it's important that we, and in healthcare, and those of us close to healthcare, are really careful about what it is we mean, because it's important to offer a diabetic diet, but a diabetic diet is not a medically tailored meal. A medically tailored meal is customized to the patient's needs with multiple layering, understanding that most high-cost, high-need patients have very complex health needs and therefore dietary needs. So I think it's important that the terminology is correct, and that there's some degree of skepticism. I'm sure you have skepticism towards our work before you heard it. In general, I think it's important to really look at what it is that's being provided and how it mimics the rigor that you provide in healthcare.
Absolutely, David. I couldn't agree more. And wow, just a wonderful presentation, which I knew it was going to be. And I love the fact that this community is now being able to be linked to the work that you're doing. So one of the things that I just want to add very quickly is that if we are worried about, big food and lobbies and all that, that means that we have to step up and make ourselves a lobby as well. So the call to action that I have for everybody here is to join the Food as Medicine Coalition that Karen and David are in, and that our voice becomes bigger and more powerful with more people. Karen and David are a wonderful source of information and passion, and they're very helpful. If you go into the Food as Medicine Coalition meeting, you're going to learn about things like that are happening like real time. So please take that. It's a great resource. So thank you very, very much, Karen and David. We so appreciate you being here. We're going to move right into medical curriculum now. So this is a perfect way after what Karen was saying. So thank you. And
best of luck for the rest of the day.
Thank you very much. Have a great day.
Let us know if we can be helpful in other ways. Thank you.
Anyway.
Excellent. Thanks. Okay, so right now we're going on to, I'm trying to pull him up here. Dr. Mike, I'm going to spotlight you. All right, so we have another presentation that's going to be equally dynamic, and anytime you bring a chef on board, it's going to, it's that superstar element, like, yay, a chef's here. But he's a cardiologist as well. I'm going to read just a quick bio and then let him get into his presentation. So Professor Michael Fenster, MD, is better known as Chef Dr. Mike. He's one of a handful of physicians worldwide to hold both culinary and medical degrees, and is the only interventional cardiologist and professional chef to do so. He is also the only cardiologist with joint academic appointments in both the medical and culinary arts. Through his culinary medicine university courses, speaking events, articles, books, personal outreach, and television and other media appearances, Chef Dr. Mike empowers people to take control of their health, wellness, and happiness through a positive relationship with food. His mission is to help each of us re-engage, reforge, and reconnect our personal relationship with the food we eat. In the quality of our own food experiences lie the keys to our own health, wellness, and happiness. Dr. Mike is an adjunct professor of culinary medicine at the Kansas Health Science Center and is on the faculty of the Missoula College Culinary Arts Program at the University of Montana and the College of Health School of Public Health at the University of Montana. He's an editor-in-chief, culinary medicine section of the Journal of Integrated Healthcare. So Dr. Mike, thank you for being here. I'm gonna let you take it away.
Thank you so much, Marla. Can you hear me okay?
Absolutely.
Okay.
So if you can start sharing your slides, it's gonna.
Yeah, if somebody could, let's see. Oh, let me see if I can share my screen here. There we go. And let me know if you can see that. And I'm going to.
You're all set, Chef.
Okay, give me 1 second there. Okay, and you can see my screen, correct?
Yep.
Okay, great. Well, hello everyone. A pleasure to be here today, albeit virtually, with you at this inaugural Food as Medicine conference. I'd like to start the program this morning by inviting you to join me on a journey. It is an exploration, a tale as simple and straightforward on its surface as the story of our food and us. In 1825, 2 months before his death, Jean-Alphème Brelat-Savarin wrote in his posthumously published best-selling book, The Physiology of Taste, or Meditations on Transcendental Gastronomy, "Tell me what you eat, and I will tell you who you are." It is a beautifully succinct and powerful formula to decipher the mystery between what we eat, our health, and our happiness. It is a course so direct and simple that it has served as a compass star for the science of nutrition. The science of nutrition ostensibly launched just over 100 years after The Physiology of Taste was published with the discovery of vital amines, or vitamins as we know them today, by Dr. Casimir Funk in 1912. Within just 50 years, the majority of deficiency diseases associated with vitamin-poor diets had been identified and in many cases eradicated around the globe. The success of this focused, one variable, one effect tactic was nothing short of revolutionary. It seemed as if we stood on the precipice of understanding all that we needed to know to realize the connection between what we ate and who we are, between our food and our health. But reality has a habit of being inconvenient. When we dig deeper, the truth, and thus the reality, is often much more complex than it seems on the surface. Once, we looked to the horizon and saw that the earth appeared flat. And with the coming dawn each day from that same horizon, we watched the sun move through the sky until it again dipped below the horizon and ushered in the night. All that we saw and all that we experienced made sense when viewing our world as a little flat island that stood in the center of a universe that revolved around us. Except, as we now know, that was never the case. The Earth is a planetary sphere, just one of several that spins like a top as it circles a rather average star in the outer portions of the Milky Way. The relationships that govern the universe, from the largest heavenly bodies to the very fabric of reality, are complicated. In just such a way, we humans in our relationships, particularly those that surround food, are also complicated. This universe that you experience as it experiences you is a collection of events that we refer to as our lives. Every so often, we engage particular events that, as a storm appearing to a ship at sea, cause us to change our course. I'd like to share just such a happenstance with you, something that changed my trajectory some years ago. I was on call in a rather prestigious hospital in the Pacific Northwest on a Friday evening. The hospital was located in a pretty hip city, known for its cutting-edge cuisine and a long tradition of fantastic local product, including delicious and fresh seafood. At 2 a.m., I get a phone call from the emergency room physician. Hey, Mike, I got a young lady down here with classic chest pain, and the ECG is a little bit abnormal. I was wondering if you wouldn't mind taking a look at it because she's only 24 years old, and it's probably nothing, but it's definitely a little bit worrisome. I took a look at the ECG and called him back. Yeah, I agree. Statistically, given her age, it's a near zero probability, and ECG is not 100% definitive, but it sounds like she's got classic chest pain that's not getting better. And if it wasn't for her age, we'd already have her in a cath lab. Let's just take her down there and be sure. And if it's nothing cardiac, we can all sleep a little easier. The next morning, as I was doing rounds, I stopped by the room to chat since we'd have put a stent in her diagonal artery for an acute myocardial infarction. At 24, she had a heart attack and would be on medications and suffer the sequelae of this for the rest of her life. We started to talk about her risk factors and the choices she had made. She didn't smoke or do drugs and didn't have a significant family history. However, she was morbidly obese and clearly had that type 2 diabetes precursor, metabolic syndrome. We spoke for about 45 minutes regarding her dietary choices. She broke down and actually cried several times, saying she wanted to eat better, tried to eat better, but it's all so confusing. And since in her mind, there wasn't any clear consensus on what or how to eat, she confessed that she did the easiest thing possible. She ate fast food, went to drive-thrus, snacked at home on junk food, and things pre-prepared because it was easy and often cheap. As I'd been there a bit, I managed to be present for a lunchtime delivery. And what did the hospital send in? What kind of message, what kind of instruction, what kind of example were we going to impart upon her? After all, when she leaves the hospital, what she will remember is that after her heart attack, this is what the experts gave her to eat. Some deli turkey and American processed cheese-like food substance on white bread. Piled high on the plate next to the sandwich were a number of condiments in little squeegee packets. The ubiquitous green jello was actually on her tray. The final component was a salad. It consisted of iceberg lettuce and cherry tomatoes that had clearly never seen a ray of sunshine. They were so hard you could have played ping pong with them. This was, by obvious design, to be topped off with the processed omega-6 rich vegetable oil loaded with artificial preservatives, flavors, and other bits. As I looked at that, I thought to myself, my God, what have we done? To understand where we are, as George Santayana advised, we must understand where we began. And where we began as human beings is arguably with our first meal. As social primates, the ritual of food has become as interwoven in our DNA as our blood type. This occurred the moment the first chefs crafted the first Macedon burgers, and we all gathered around the fire to listen to the first stories. There, under the deep velvet night of the African savanna sky, we felt the warmth and protection of fire and fellowship and food, and snug with our full bellies, there was no going back. For the human species, eating is an all-encompassing food experience. Sharing the food experience is social currency and mating ritual. Eating is fun. Eating is about pleasure. Eating is play. We are the only species on the planet that takes the time to prepare and cook our food. As Homo sapiens sapiens, we live to eat. Now, I'd like you to recall a moment when you were forced to eat something because you were told it was good for you. Maybe it was broccoli or Brussels sprouts and your mom told you you had to eat your veg. Maybe it was endless bowls of plain white rice as part of an elimination diet. Whatever it was, think about how you felt when you had to eat specifically for purpose. It became work. And although I'm not a gambling man, I bet the whole experience was less than pleasant. This is how we dictate to people to eat for health and wellness. We admonish them they must eat to live. But chefs are keen to an obvious something that has escaped those of us wearing scientific blinders. Most people don't consider eating an act of work. Never have, never will. There is a consequence to the physiology and biology of our food experience being processed in the same areas of the brain as sex. A pizza Napolitano made with organic wheat, fresh buffalo mozzarella from grass-fed cattle, heirloom organic tomatoes just harvested from their sun-drenched vines and topped with verdant basil from our own windowsill garden. These are the real ingredients we and our gut microbiome have evolved over millennia to thrive upon. So how'd we lose our way? To answer that, let us rejoin our quest several hundred thousands of years later in our own modern times. Following World War II, the industrial production of foodstuffs led to fundamental changes in our food and food pathways. These influences manifested in the cultural zeitgeist of the times, from which the principles of McDonaldization, efficiency, calculability, predictability, and control arose, and from which we are still bearing scars and repercussions. One of these fundamental food pathway changes came at the end of the war with a surplus of munitions and manufacturing still geared towards such production. Subsequently, a use for these nitrogen and phosphorus-based compounds as chemical fertilizers was introduced. Industrial and particularly monocrop agriculture became widespread and secured a foothold with government support in the form of incentives and subsidies that still exist today. The practice became entrenched worldwide when Norman Borlaug launched the Green Revolution in the 1960s, a revolution that was as much about defeating communism as it was about feeding anyone. Chemicals in the form of fertilizers and pesticides became the new faith. They replaced established schemas that worked in concert with natural ecosystems. These are actions that echo today in the aisles of every supermarket and on the shelves of every pantry. At the same time, crop agriculture was undergoing its transformation, animal husbandry became animal science. Easy access to things like manufactured vitamin D and antibiotics, which also speed up the animal's growth rate, made it feasible and profitable for the first time in history to concentrate animals inside and confine them there all year long. In 2011, the U.S. Food and Drug Administration reported that 80% of all antibiotics used in the United States every year go to America's livestock and poultry. Of that 80%, the FDA reported, over 90% is given to animals that are not sick. Up to 75% of the treated animals pass active drug into their feces and urine, entering the environment in full force and effect. Pharmaceutical residues generally pass unmeasured through wastewater treatment facilities that have not been designed to deal with them. A typical confinement hog effluent contains hundreds of distinct contaminants, including heavy metals, hormones, pesticides, and pathogens. Such operations are the main mechanism of manufacturing commodity meat and poultry, and increasingly fish and seafood are being produced in this fashion as well. All of these processes are incredibly dependent on energy-intensive, particularly fossil fuel-intensive feed production. In the United States, approximately 55% of grains grown are utilized in concentrated animal feeding operations. Destruction of nature's complex systems is another marker of alteration to our native food pathways. Agriculture has become much, much too simplified. The solution, according to Jonathan Lundgren, a former USDA entomologist and farmer, is creating farming systems that are more like nature, with variety and complexity. Nature abhors monoculture. Biodiversity is life. We see that truth reflected in the health of our own gut microbiome and its relation to our own health and wellness, or disability and disease. Network systems like those used in regenerative agriculture are more akin to the complexity found in nature. These ecosystems produce organic, real, and authentic foods in a fashion that renders them in the state from which we and our gut microbiome co-evolved to bring us pleasure, health, sustenance, and wellness, all the while addressing in a positive fashion issues of sustainability and planetary health. We need only direct ourselves to a basic question. Do you really want to get your food from a place you would never want to visit? In the post-war decades, the focus was less on questions of origin and manufacture and more on leisure time. Leisure time became synonymous with wealth, success, and prosperity. Advertisers jumped on board and quickly admonished us to embrace the modern miracles of food production and escape the drudgery of kitchen preparation and cookery. Pre-prepared foods and quick, reliable, and constant fast foods satiated us at a pace commensurate with a population that had exploded onto the new national highway system in a torrid love affair with the automobile and all things speed. Convenience culture was born, and we embraced it. Boy, did we ever. We became enamored of the constancy that let us have a hamburger in New York City taste exactly the same as a hamburger in Los Angeles and everywhere in between. And this consistent food became safe food, which became predictable food, which became reproducible food. And reproducible food requires reproducible ingredients, which is why a chicken nugget, something that from a culinary perspective should be no more than a handful of ingredients, requires 40 different components to manufacture. But today we must give pause and ask, is consistent food the best food? And whilst we contemplate the question, we hold onto our delivered everything lover slice with an ever tightening death grip. A slice of industrially produced pizza is recognized fairly universally as one of the top 10 most potentially self-destructive things we can and do eat. It is a veritable poster child for our modern Western diet, also known as the standard American diet, or most appropriately, quite simply, as the SAD. At the heart of the SAD approach is convenience masquerading as efficiency, and ultra-processed manufactured foods masquerading as their authentic forebears, deceiving us with false direction and promise. In 1905, the average American consumed 71 pounds of beef per person per year. In 2010, they ate just 60 pounds. During the same time, veal consumption decreased from 7 pounds to less than half a pound. Lamb consumption decreased from 6 pounds to 1 pound. Pork decreased from 62 pounds to 48 pounds. Egg consumption likewise decreased from 284 eggs per person per year to 243. All of these decreases are statistically significant. From 1970 to 2005, butter consumption declined 15%, lard consumption declined 47%, and whole milk consumption decreased by 73%. Over the course of the 20th century, Americans' overall consumption of saturated fats has decreased by 21%. Conversely, the consumption of vegetable fats has more than doubled in the 100 years from 1909 to 2009, increasing from 36 pounds to 80 pounds, and by 63% alone from 1970 to 2000. From 1910 to 1970, vegetable fat consumption, primarily in the form of oils, has increased by over 400%. In 1909, Americans consumed 15 pounds of chicken per person per year, and in 2009, that had increased to 80 pounds. Turkey consumption increased from 2 pounds in 1935 to 9 pounds in 2009. From 1910 to 1999, per capita consumption of fish rose from 11.2 to 15.3 pounds per person. These are the results of recommendations based on a one variable, one effect narrative, based on a historically derived viewpoint that no longer applies to the modern table. These are recommendations that Americans were told to follow. And they did. These are the latest obesity statistics from the CDC through 2018, published just a few weeks ago. The average for all states is 42.4% up from 30.5%, a roughly 40% increase. Severe obesity nearly doubled, going from 4.7 to 9.2%, and represents amongst the fastest growing segments. You can go ahead and superimpose type 2 diabetes and all the disability and disease associated with it on this map. The singular truth is that not one of the 195 countries on this planet that is seeing this rise in obesity and type 2 diabetes has been able to reverse it. And they all have one thing in common: ever increasing consumption of ultra-processed foods. From age 5, yes, 5 onwards, the majority of the US diet consists of ultra-processed food. It now makes up almost 70% of the energy we consume each day, and 15% of that comes from added sweeteners alone. 4 of the 5 leading causes of US deaths are chronic disease. These chronic diseases can be prevented and significantly addressed by lifestyle changes like diet. Diets that abound with flavor and texture and deliciousness of real wholesome food. It is clear that the consumption of real foods that have fueled our rise as a dominant species on the planet are not the cause of our current condition. A single can of soda a day increases your risk of cardiovascular disease by approximately 30%. The average American now drinks over 50 gallons of soda per year. Over the past 3 decades, the consumption of high fructose corn syrup has increased by 10,000%. You heard that right, 10,000%. As Dr. Mazzaferin of Tufts University notes, the evidence linking chronic disability and disease now strongly points to these ultra-processed foods. Research published in 2020 suggests that diets high in ultra-processed foods contribute to accelerated physiologic aging at the cellular level, as evidenced by shorter telomere length. The evidence is also clear that these ultra-processed foods alter in a negative way our symbiotic organ, our gut microbiome. Ultra-processed foods are unique. They are constructed to be hyperpalatable and addictive. They are designed for profit and long shelf life. Their characteristic ingredients are either food-like substances of no or rare culinary use, or else classes of additives whose function is to disguise the use and flavor of such substances and make them resemble the real foods which they aim to replace. The NOVA classification, developed over a decade ago at the University of Sao Paulo in Brazil, sheds a light on the dilemma. Here, an authentic pizza napolitano that we described earlier is a group 3 food. The aforementioned industrial pizza is a group 4 or ultra-processed food. When a pizza is no longer a pizza, we must make a shift. The solution is not easy, but it is not complicated beyond our reach. It requires that we examine ourselves, our ecosystem within a larger ecosystem of nature. We are all well aware of the concept of survival of the fittest, of competition for survival in the wild. But both ancient wisdom and modern research reveal that natural systems are at least, if not more, as much about cooperation. There is a universality of the natural world that reveals that everything is connected and functions from systems within systems. Nature regenerates itself with diversity. Culinary medicine is born from this quantum change in our perspective regarding what we eat and who we are. Culinary medicine, as we define it and teach it at the University of Montana, is the multidisciplinary application of evidence-based decision-making in the selection of ingredients and techniques used in preparing foodstuffs with a goal of achieving and maintaining health and wellness through an optimized food experience. The goal of culinary medicine is to change our individual relationship to the food experience. The goal of culinary medicine is to empower the individual to positively reestablish, reconnect, and reforge their relationship to their food experience, because this food relationship, from the moment we bond with our mothers over breast or bottle, is a cornerstone for all the other relationships in our lives. The point of this is to emphasize the power of our positive connections. When we equate people to machines, we quickly lose our way. People are not cars. Food is not fuel. People are part of nature, and nature is a complex, dynamic system in which plants, animals, and fungi are all connected. Within this system, we can find both pleasure and healing, health and happiness. And in the end, is this not the answer we seek? So we come back to our original query and update it for our contemporary times. Tell me, how much ultra-processed food do you eat? And for each ingredient you choose, how is it bred? What was it fed? Where was it led? And even with that information, I still cannot tell you who you are. For that unique being is composed not only of the above interrogatories, but also the how, why, where, when, and with whom you eat. It is all those aspects of your food experience that defines who you are. But what I can tell you from those answers is a pretty good idea of your health risk. And I think that's a damn fine place to start. Industrial agribusiness, big pharma, big food, soda and snack, and international ultra-processed food conglomerates have a lot of political clout. They are heavily invested in maintaining the status quo. They relegated Professor John Yudkin to a closet of ignominy, quite literally a closet at the end of his career. But unlike the professor who had to wait on history to validate his observations and conclusions, we have a moment through collaboration and cooperation at events and conferences like this to create our own positive healing network. Colleagues, friends, today I've had the great honor to share with you some small, tasty bits regarding our practice of culinary medicine, its source, how we assemble it, and why we serve it as we do. But this is a conference about food as medicine. Food is a powerful healing experience, as all true, real, and authentic foods are. But if we only use food as a therapeutic spear, we miss an opportunity. We run the risk of disconnecting ourselves even further from our food, from our very roots. We run the risk of not awakening to the undeniable truth that all life, our life, is connected. We miss the opportunity to repair our broken covenant with this good earth. So I invite you to join me at the culinary medicine table. It is a feast far richer than you can possibly imagine. Thank you so much for your attention.
Thank you, Dr. Mike. We're really excited. That was a wonderful presentation. And as far as questions and everything, he's going to be on our next panel. So I'm going to be spotlighting our next panel and then introducing our moderator, Dr. Roseanne Berger. Let's see here. Let me just get everybody. Hello. Let me just get everyone here. Okay. Just give me 1 second, please. Sorry about this. Okay, spotlight and Arthur Johnson. We are getting all of our great panelists up and loaded here. All right. Okay, so our panel coming up is called Building the Healthcare Team of the Future, Interdisciplinary Approaches. And moderating our panel today is Dr. Roseanne Berger, and she is the Senior Associate Dean for Graduate Medical Education at the Jacobs School of Medicine and Biomedical Sciences. She earned her medical degree at New York Medical College and completed residency training in family medicine at the University of California, San Diego, and fellowship training in geriatrics at the University of Buffalo. Dr. Berger directs the UB's Mini Medical School that targets individuals in the community with curiosity and interest in learning about medicine, healthcare, and health sciences. The 4-part virtual lecture series is devoted to nutrition for the fall 2021 semester. So it's great that we have her here in fall 2021 to do this wonderful panel. So Dr. Berger, please take it away.
Okay, thank you so much, Marla. And thank you to everyone. I could tell you that the chat has just been lighting up with comments from people who are interested in changing the future of healthcare through this Food as Medicine conference. So it's off to a great start. So I'm not going to completely reintroduce Dr. Chef Mike, but for those of you who may have just joined, I will remind everyone that he is an interventional cardiologist and a gourmet chef who is known as Chef Dr. Mike. He is, in addition to being a professor, he is an author of multiple books, including some like this one, if you could, well, you may not be able to see it, but it is called Eating Well, Living Better, the Grassroots Gourmet to Good Health and Great Food, and another book that I enjoy called Food Shaman, The Art of Quantum Food, So this is these are just two books that he has published and are available. But let me introduce the rest of our panel, who are really experts and impressive individuals in this space here in our community. Dorothy Johnston has been involved in the hospitality industry in Buffalo for a number of years. She earned a BA from Damon and a master's in education from the State University College at Buffalo with the intention of teaching history. So that kind of links to Chef Dr. Mike's interests as well. Her employment in a fine restaurant resulted in some mentorship that completely redirected her career. She studied at the Culinary Institute of America and the Center for Entrepreneurial Leadership at UB. She's certified as an executive chef and culinary educator by the American Culinary Federation and is a certified evaluator and member of the Federation's Accreditation Committee. Dorothy operated the Cafe in the Square that many of you may remember for 25 years before joining the faculty at SUNY Erie, where she served as department chair. And in that role, she and her colleague, Kristen Goss, introduced culinary medicine into the curriculum and helped with a collaborative program that exists between the University of Buffalo, Jacobs School of Medicine, and the UB Nutrition Department. What a good way to start influencing the future through education. Ms. Johnson is a commandeur at the local Chaîne des Rôtisseurs, a certified sommelier and specialist of wine in the Society of Wine Educators. Dr. Helen Cappuccino. Dr. Cappuccino is a surgical oncologist. So like Chef Dr. Mike, a physician and interested party in food. She specializes in breast cancer at Roswell Park since 1999 and is an associate professor at the Jacobs School and the University of Rochester. She earned her medical degree at UB, and now she did her residency in New Jersey and Memorial Sloan Kettering in New York. Dr. Cappuccino has been recognized for her humanistic approaches to medicine, her team-based approach, and her interest in nutrition along with cancer care. She's authored several chapters in surgical textbooks, and along with Dorothy Johnston and Nikki Clem, was instrumental in launching the collaborative interprofessional culinary medicine elective here at the Jacobs School of Medicine. She also is a member of the Confrérie de la Chaîne des Rôtisseurs, the world's oldest, largest, and most prestigious food and wine society. That was a new piece of information that I learned. And Nicole Clem is a registered dietitian nutritionist. She's certified in New York State and program director of the Dietetic Internship Program. Ms. Clem earned a bachelor's degree at Hobart William Smith, a master's at Duville College, and a certificate as a culinary medicine specialist from Tulane University. Nikki, as she is often called, integrates immersive culinary education across interdisciplinary professional training programs at the University of Buffalo School of Public Health and Health Professions. She is positioning the Registered Dietitian Nutrition Program as partners in the kitchen with student health professionals, exploring the link between diet, disease, and the role food plays in prevention. So I am impressed and frankly wowed by the expertise of this entire panel. And we will get started with our focus, which is on changing the healthcare team of the future, with a question that simply asks, why does the healthcare team need to change? And what can we do to create change if you think it's necessary? So perhaps we should start with some comments from a traditional healthcare team member, Chef Dr. Mike.
Could you repeat the first part of that question, Roseanne? And I'll just start it off very briefly.
Why does the healthcare team, the current healthcare team, traditionally in hospitals, that's physicians, nurse practitioners, nurses, possibly physician's assistants, and maybe the occasional pharmacist thrown in every now and then. Does that healthcare team need to change?
Absolutely. I mean, we just need to look at some of these statistics, right? So let's take type 2 diabetes. In the presentation, I put up the slide of obesity. As I said, you could superimpose type 2 diabetes. We're obviously all in the middle of a pandemic and COVID obsessed in the medical community, and rightly so. But type 2 diabetes is an epidemic, a pandemic all of its own. And when we look at the fact that really 90% of cases of type 2 diabetes, by estimations from various experts, can be prevented with dietary interventions. And at least 60%, as some published data from in the BMJ last year, maybe up to 80% of all cases of type 2 diabetes can be reversed with dietary interventions. We don't need another pharmaceutical. We need to get back to connecting to our food and to our roots. And there's just been there's just, as somebody said, from a medical perspective, as a physician, I just wasn't trained in that. And in fact, when talking with patients about how to employ, dietary strategies, I really go back to my culinary training, and that's where it comes from. So there has been a huge disconnect over the last 50, 75 years between food and health. We've just moved away and become dependent on pharmaceuticals and surgeries. And again, to go back to the history of medicine and the history of food, the first cookbooks were written by physicians. So that gives you an idea how tightly it was tied on in the past. And so in our theme of culinary medicine, I think that we need to get back to that a little bit.
Thank you. That's an interesting point. I didn't realize the link. I'm wondering if our other panelists have some opinions on how that healthcare team could change.
Well, you talk a little bit about how the team needs to change. It needs to change potentially in terms of the composition of the team or the information that's shared with patients, so that we really get the information to them about how they can be active in playing a role in getting the proper nutrition and diets. So either, and ideally both, medical doctors need to be better educated in terms of nutrition and culinary medicine, or we need to really include dietitians, nutritionists on the teams more. And I think it's really important to include the culinary piece so that they learn the proper way to prepare their food. And I'm a big fan of also teaching patients about growing vegetables so that it's even more affordable to them.
Thank you.
I'd add that our patients are complicated. There are a lot of barriers to implementing nutrition therapy, even when they do receive education and counseling. Income, their own education, food insecurity issues are all barriers that can be managed or assisted by a lot of other care providers on the team. And so nutrition therapy and counseling is a two-way street for a lot of the conversations that providers are having with these patients. And these patients do have chronic conditions that can benefit from lifestyle and diet interventions. And so if we have folks like social work and the pharmacist and nursing and dietitians and the physician all having a similar conversation about managing some of those barriers, it becomes a synchronized conversation across that intervention. And true management of chronic disease really does take that 360-degree approach that includes exercise. So physical therapists or others, including lifestyle medicine, lifestyle habits, and of course, nutrition. So our patients are complicated and they value their providers' recommendations. And so we need to have all the providers trained, hopefully, in an interprofessional setting to understand the role each other can play in the care of that patient. And so certainly starting with Nutrition education during their education is important. That's where culinary medicine classes can really come in, but bringing in that interprofessional piece and focusing on collaboration, communication, knowing how to reach out to each other and knowing how to read, review, and reciprocate some of the conversations that they're having with patients. So there's not conflicting information that patients are receiving from different providers that can seem like nutrition is this huge insurmountable challenge, and rather making it where the, listen to the patient, where they're at, what they can do with what they have today, small changes.
It seems to me when we're talking about this, because I approach it from such a different angle, I listen to all of it and I think, gee, we're the missing link. The chefs are the missing link in all of this. It doesn't really work without somebody making recipes that are delicious. Okay, nobody is going to eat food that doesn't interest them. And if we don't find a way, if we don't find a way to make food more delicious, we're never going to sell any of this. And my approach is that the chefs in these situations have to be included in that team. I cannot tell you how much time we spent when we did the UB program, how much time we at ECC spent redoing all the recipes because they weren't delicious. They weren't even palatable. And we spent hours working on just making sure that what we were teaching our doctors was good. And we were very successful. We got great reviews, but it took a really long time. The chefs have to be included in that.
Mm-hmm. So I know that Dr. Cappuccino and Nikki Clem and Dorothy, as you just referenced, you were all involved in this interprofessional elective. Could one of you describe that elective, and so we understand exactly what was involved? How were the chefs involved? What did the students learn? How did the interaction go between the students from different schools?
Well, it was primarily medical students with 2 dietitian students. So there were 10 medical students and 2 dietetic students, as I recall, right, Nikki? Were those the numbers you recall? Yeah. Yes. At any rate, it was an elective, which had very comprehensive online modules that the students would complete in advance of the classes. And then we had several experiences during the week. We called them labs, where we would go to the kitchen with Nikki and her team and Dorothy and her team. And we would execute several recipes, variations on recipes with varying degrees of healthiness as opposed to traditional preparations, so that the students learn the skills. And then we would do a journal club, consume the meals at a communal table so that we could have a discussion between all of the professionals from the different fields. And then we had some additional experiences that dealt with things such as food insecurity, counseling patients, et cetera. What would you 2 like to add to that? And it lasted a semester.
I'll add that it qualified all of the participating students for one segment of what UB calls their micro-credential in interprofessional communication and collaboration. So UB is huge. We've got 14 health professions student programs, and we're really focused on having all of them work together. And so there's a 3-step digital badge micro-credential where we've each in our programs curated experiences that are intentionally interprofessional. And so we qualified the culinary medicine because, again, it was inherently interprofessional with our different disciplines participating together. We qualified that as something that would contribute to the progression of developing this interprofessional collaboration savviness. And so it was a nice opportunity to show them the benefits of not only learning how to cook together, working through cases together, reviewing, nutrition literature together, and really synchronizing the messages that they take from that literature, but also that referral network and how to communicate and collaborate together across all of these different ways of patient care. And so that's an actual notation on their transcript that they are an interprofessional communication and collaboration professional.
Nikki, could you also elaborate on the results that your students put together? Because that was really interesting.
The change in self-efficacy around frequency of cooking, comfort in cooking, ability to read and implement a recipe, ability to shop and understand that patient point of view, and the experience again of counseling and education and communicating to the future care team, to each other, but also again to the patient themselves. So really enhanced communication, personal self-efficacy, and understanding, enhanced nutrition literacy around food and health and wellness, and again, the team participating in that.
And I'm wondering, Chef Dr. Mike, do you have any suggestions based on any experience you've had in Montana in your role as a clinician and a chef?
Yeah, I echo what everyone has said. It's absolutely brilliant and spot on. And the one thing I'd add, as Dorothy was saying, absolutely we need to include the chefs as an interface. And I think somebody mentioned, helping patients maybe grow some food, even if it's just a window box of herbs, but connecting them back to the roots of the food so that they can understand, the difference between, an ultra processed, frozen, chicken dinner and getting a fresh chicken. And so in Montana, we are a little spoiled. You can see Big Sky behind me. We have some space, and we are able to, connect people. We have some programs at the university. And as we've learned, you can't just give somebody, a box of carrots and send them home. And I think that's another role where the chefs come in is you got to teach them, all those things and how to cook it, but how to cook it in a way that they love it, that it's palatable for them. So I think beyond just education in terms of knowledge, there has to be that practical aspect. And I think it is important for them to get a connection back to the roots of the food. There's just a difference we see in folks when they appreciate where it comes from. So, it's somebody here is a sommelier, and Dorothy's a sommelier, and she can speak to this. But there's just a different level that you get when you know about the wine, you appreciate where it comes from, and also the sort of the difference in taste, right? So, the chicken the eggs that I get here from my guy Noah. I will say they're the best anywhere I've ever had, but they're different from some eggs I'll get somewhere else. And that's okay. We need to get away from this homogenization. Yeah, go ahead, Dorothy.
Terroir. They're different.
Yes.
So, your comments reminded me of a question that one of our mini medical students raises frequently, and that is, when you are teaching people how to cook, is there a way to cook wonderful food with a kind of a sparsely equipped kitchen, a kitchen that may just rely on a microwave, or a kitchen that may just have a single burner? Is that part of the strategy?
Absolutely. So I've actually I have a column on Psychology Today. Folks can go there and see it. I call it Tales of the One Pot Doc. So when I'm not at the university, I travel around and I do cardiology work. And I bring a one pot, one pan, and one burner that I can plug in a convection set. And I cook in my hotel room because when I'm there for a week or two, I can't physically do the job I have to do at my age, which is ancient, and suffer that the crap food that's out there. It just doesn't work when you're on call 24/7. So absolutely, I cook all the time on the road with one pot, one pan, one burner in a hotel room.
But to answer your question, we did incorporate that into the class. The one night that they had to shop, they were limited with funds. They had to take public transportation, and they got a note that said, okay, in your home, you don't have any gas. It was turned off. Okay, how are you going to prepare this?
Right, they role played,
Right.
you know, families and did meal preparation. Perhaps they had a diabetic grandmother living with them, or a child with a gluten allergy. Some other ones, they didn't have a refrigerator, and we would give them a mock family. They would have to go to the food bank and use the equivalent of food stamps to get the rest of the food, using public transportation, just to see, you know, how difficult it is for some patients with their own personal challenges to get the necessary ingredients and create a meal with challenges that we can't even imagine. Really difficult challenges.
Roseanne, that makes me think of two things. Canned goods and frozen vegetables are your friends. They're easy, the prep is done, they work in a microwave, they work in a, you know, a rice cooker, they work in a slow cooker. You know, it takes some skill out of it, and they've been stigmatized as lesser nutrition, but they're often flash frozen or processed as soon as they're picked. So they're probably more flavorful than eating out of season, and often quite affordable. And what I've liked now, since we pivoted to the online culinary medicine elective, is we are cooking with our students in their own homes. And so the diversity of kitchen tools and skill and things available, we've had students who are cooking on a single burner with one mixing bowl and one spoon and a microwave. And they're getting through, and, you know, with the help of, you know, everyone else on the line, modifying the recipes to make do with what they have. And so they're completing their own grocery shopping. They're feeling that role of the patient because they're comparing prices. They're trying to source their foods. They're, you know, sort of talking about what it takes to really procure the ingredients for these recipes. And it's driving empathy for how hard that patient has to work to execute things, especially, again, if they have, you know, a limited culinary setting, you know, particularly grad students who might be in a student apartment or using a shared kitchen in their suite. So we've experienced that, and we find, you know, Mediterranean style recipes don't have to be complicated, don't have to have a lot of recipes, don't have to have a lot of, you know, amped up culinary skill to make it taste good, nourish you, and be satiating. So we've really managed that and then those who have a full kitchen are able to watch others who are going through some, you know, less extensive culinary abilities, and are really kind of learning from them as they see what they're doing to make that recipe that they're cooking as well work. So the experience of cooking online has brought us into people's homes, similar as our patient will inevitably be cooking for their family in their own homes.
Yeah, I'm so glad you mentioned that, because bringing this teaching kitchen into people's homes, it meets them where they are, which is so important. It also emphasizes how important it is to strive to get everybody access to these online resources. You know, so everybody has a computer so they can take advantage of this, particularly for the patients who are shut in and can't travel to a clinic or someplace else. And of course, during COVID, this was really a big problem. You know, I want to invite people to put questions in the chat. We will be able to ask our panelists this. There was a comment in the chat that was essentially saying that we have lots of immigrants coming to this country, and it is a challenge to support their cultures on a very low budget. How do we support maintaining these food traditions from these immigrant cultures without, you know, kind of being overpowered by the corporatization of the food system? I think there was some comment in our keynote about the fact that we know that in terms of policy changes, even though there may not be contradictory efforts against this food as medicine approach. There are very avid and articulate and vocal and moneyed support for maintaining some of the same food traditions that may not be so healthy. So how do we support the immigrant populations and maintaining their traditions?
That's a good question. You know, I think there are some local ethnic grocers, which I think are really helpful. And I think independent grocers are really critical because they can often end up in neighborhoods where you might not get larger supermarkets. And I think it's really important to patronize them. But that particular problem, getting those, the flavors, the spices, the vegetables that they're used to cooking with, I think probably is a significant challenge, and more broadly, unless you're lucky enough to have one of those ethnic grocers. Or to grow your own vegetables.
Yeah, and I think you know, that's an area where chefs come in again, right? Because chefs are often creating, you know, classic cuisines from other cultures, but utilizing what's available locally. And really, that's how food grows. We look at, you know, I think Nikki was speaking about, you know, Mediterranean diet, but then you look at that transition that's become the Italian American sort of standard, you know, particularly as those immigrants came over, brought their traditions, and but then developed, you know, sort of an offshoot of that cuisine. So there's nothing wrong, I think, with welcoming these people, and certainly we as chefs, as food people, can learn brilliant flavor combinations and learn their cuisines, and then also help them with the ingredients in terms of what we have locally. I mean, that's really how we push our version of culinary medicine, is to use what is sustainable and local, because again, you know, we want to, you know, our brand of culinary medicine is something that needs to be sustainable for the planet. So we don't want to be importing, you know, spices from halfway around the world that have these huge carbon footprints, when we can grow something pretty similar right at home. So I think that's one strategy.
Yeah, SUNY Erie has their community garden. Dorothy, I don't know if you wanted to talk about that at all, which is really, really terrific. And I know there's a local medical practice that also has a garden that they use for their patients as well. Really critically important.
You know, when we started, it was because Kristen was a cancer survivor, and she wanted to change the way she was living. And she also wanted to change the way we were teaching nutrition in our culinary program. So we started the garden, and we really had no idea when we started it how receptive students would be. It's a summer program, obviously, and it's difficult because the way financial aid works, nobody pays for it. We had to get scholarships for them to be able to take it. So, but anyway, they were allowed to bring their children. It's on the waterfront. It's a beautiful garden. It became such a nice respite for them. The children could play there safely. It just kind of changed people's lives. And it was just really heartwarming to see what we were doing. We had no expectation of that kind of change in people. They all now, those that finished the program have all let us know that they have gardens in their backyards, or they've started a community garden in their neighborhood. So it's really fun to see.
And the medical students as well. There's a club at the medical school that year to year has varying degrees of participation, but usually very enthusiastically. They call it Sprouts, and they have their own garden and they grow their own food as well, independent of culinary medicine. So, and I think, Dorothy, talking about parents who are students educating their children about gardening and food and nutrition, it's really important that when you teach a parent, you create generational change and really impact on the health of not just one person, but an entire family in the following generations.
And that's why it's so important to start with learners when they're young. And so it's very inspiring to see people teaching our students about these ideas. In these community gardens, are they seasonal gardens? Or are there ways to keep the garden going? You know, in Buffalo, we have long winter months like you do in Montana. So what happens to these gardens during the winter months? And perhaps there's something that can be done to make them sustainable throughout the year.
My understanding is they're just summer only. Dorothy, yours?
Ours is summer only. We do have a grow tower in our atrium at school, and we do most of our herbs there. But what we do incorporate in the very beginning of Pantry Garde Manger is pickling, preserving, canning, so that we do have some of these fresh things available throughout the year. Of course, because we're working with a pretty big volume and we don't produce that much, they don't last us as long as they might in a home situation. But we do put on all of our menus that in as much as possible, we're using produce from our garden.
Right. Are there greenhouses attached to these gardens that could at least extend the growing season?
We have a small greenhouse, but no, we really can't extend it because it's on the waterfront. We don't really have any way. We have very limited ways to water, and we're very limited in, we have to carry the water during the summer, so you understand. We're on the waterfront, but we can't get to the water.
But there are businesses locally that grow year round. They use old carts that go on the back of semi trucks, the old ones, and then they pipe them, plumb them, use light so that they can grow fresh vegetables year round. There's a mushroom in an old factory building, a mushroom grower that does a great job. So there are definitely, there's a movement towards having year round growing locally, which is terrific.
Right. Well, perhaps that suggests another way for us to try to advocate for figuring out ways to support extending the season in some way. So support is always an issue. We talked earlier about a business model for helping to make change, and we saw some interesting statistics. I wanted to circle back to the notion of the healthcare team, because we've already heard that in order to really have a good healthcare team for the future, we should not only have registered dietitians, but we should have social workers, and we should have physical therapists, because exercise is a big piece of it. And of course, we should have chefs, because it's not just saying eat this, but showing how to prepare these foods. So oftentimes in the hospital, we have a food service team. And frankly, in my experience, that team is kind of invisible. They walk around and somebody gives a little sheet of paper so the patient can choose their grilled cheese and, if it's cheese, sandwich and green Jell-O. But how can we make a business case to expand these teams within our current systems? Is it possible to do that, kind of on the local level? How do we make a business case for this?
Well, I'll share what we've done in cardiology. So again, belying my age, back in the day when I started as an interventional cardiologist, I would have a patient. We do, I'd see the patient, we do a cath, and then I decide, am I going to stent this patient? Am I going to send him to surgery? And that was pretty much it. And what we've learned over the years in cardiology is really taken, I think, a lesson from Helen's profession, which is we now do a heart team approach. So I discuss it with a surgeon, and we come to a decision together that also involves all those ancillary people that you mentioned. And the hospitals have seen this as good business because it's good for patients and outcomes are better. And I think, using that model that really, I think, was first developed really in oncology, and applying it to what we do in interventional cardiology has made a huge difference. And now that's the standard. So I think, as that philosophy grows and gets entrenched in other places, then you have the competition factor, where if one hospital and one system's utilizing that approach, having better outcomes, patients are doing better, then the other ones are forced to adopt it, much like in the old days when cardiac rehab first came out.
Mm-hmm.
Yeah, the whole multidisciplinary concept is critically important, but I think it's especially important not only in the hospital, but for outpatients. And one of the reasons I think it's so critical to have culinary medicine education that is multidisciplinary is because doctors are often the point of first contact. We see the patients either in the emergency room or the clinic or the office, and we do that. Maybe it's weekly, maybe it's monthly, maybe it's yearly, maybe it's urgently. But doctors need to be aware of what our colleagues in other specialties can do. And I think that was the great piece of the interdisciplinary education that we did with the medical students, is they really got to see how much they could learn from their colleagues in culinary and the culinary arts, and also in dietetics. But they have to be conversant about that. They have to be prepared to answer the basic questions and then make the appropriate referral. So it's not as easy in an office to have all of that available all the time, but they have to have the knowledge and the ability to make those referrals so that patients can get the proper education. And at the very least, have a basic conversation with them.
Yeah, I couldn't.
But sorry, go ahead, Roseanne.
Go ahead.
I would like to plug shared medical appointments. So they're a setting where 8 to 10 patients with an interprofessional team of nursing, medicine, dietitians, culinary folks come in with patients. They do see them individually, but then they do some peer support, professional support for a team, and measure the outcomes. So it's starting a lot in the Northeast. I see it in Boston, Massachusetts. I've seen it in some larger hospitals. Again, a lot of patients are facing chronic conditions that are nutrition related, so they have some similar concerns. It's time positive for the physician who might not have time to see 10 people individually to talk about nutrition. And it shows that team approach, and the outcomes can be tracked for labs and weight and metrics in a way that proves, again, the efficacy of that team-based approach. So big proponent of shared medical appointments, again, across the team providers, particularly involving some of our exercise specialized focused people who, again, then can share tips for a group who again can share challenges and barriers that they're experiencing and troubleshoot them together. Some of that peer support can actually go a long way when in front of a physician who's prompting them with thoughts about how to manage these nutrition interventions. And food prescriptions, having a doctor be able to write something that then they take to a grocery store and see a dietitian or see a chef and have a conversation about that point of purchase as far as implementing nutrition strategy. And we need law on our team. We need food policy to change. We need folks who are in public health who are writing some larger trend analysis, communication briefs, research on our side. I think proving the efficacy goes beyond just measuring a single patient's outcome, and getting some policy changes for, reimbursement, for shared medical appointments, for access to patients across, the needs of all these medically tailored meals, dietitians visits, seeing again the healthcare team more regularly and being, walking alongside the patient, making it a little easier. Telehealth, I think, will change access for patients significantly as long as reimbursement keeps up with telehealth appointments. I think we'll start to see some maybe interesting patient outcomes as a result of being able to meet the patient where they're at, literally, and bring the team into their home and really be a supportive message for them.
Thank you for bringing up that team approach. We see it in with diabetes educators often holding team meetings, but I don't think they are as interprofessional as you described, and that sounds like it would be the future gold standard. So thank you for raising that. What? Yeah.
Oh, just said let's go.
Yes, and of course, again, the importance of expanding broadband access to all the people is going to be so important for this. So that's a policy issue that we could all get behind. Other comments on this notion of the team and who should be on the team and how to make the business case or the policy changes for creating this team?
One thing that might be interesting to talk about is, having the opportunity to do Zoom conferences and how to really optimally use those to disseminate information. I think COVID's really presented us with some interesting opportunities to evaluate how things like that work and for students or people trying to learn about various things. And I think one of the more positive things that we had with the culinary medicine course was the ability for everybody to get together and interact. And I think Zoom really helps us to go and greet people where they are. But I think it's also really important, once COVID has passed, that to the extent possible that we do sort of rub elbows together and sort of toil through experiences like that together. And there's a lot of data to suggest that being together and that communal aspect of this sort of education is actually really important, more educational, better for the mental health of the students, and that there's a more lasting educational impact when it's in person. I certainly think it's great to be able to do this remotely, especially during COVID or when patients have challenges, though. It's good that we have both tools.
And one thing that I would add in terms of a team is we need to also remember the patient has a team. And they have family members, et cetera. And so when we look at success of these types of interventions, just lifestyle interventions in general, people need that community around them. Sort of what I think what Helen was saying. So when you're teaching them how to cook, again, it's about food that they can then share in that meal with their significant others, with their family, with their friends, et cetera. So the patient has their own team as well. And I think we need to be able to incorporate that, have some flexibility to incorporate that into the equation, because we're doing a lifestyle intervention, and those are the things that make the lifestyle intervention successful, and thus, from a business perspective, cost effective.
Yes, thank you you described some of those things, the importance of the social interactions around food in your books. There was a comment in the chat that said, hospitals really aren't paid to keep people healthy. Anybody want to comment on that? You could think of hospitals as the place where our failures accumulate. But any comments on the way hospitals are reimbursed in terms of keeping people healthy?
Well, yeah, I mean, that is a good point. And that's a true point. Unfortunately, I don't know that we'll be able to, go back to the ancient Chinese method where physicians were paid regularly. And then if your patient got sick, you didn't get paid anymore. So there was a big incentive to keep people well. I don't know that we'll be able to change it to that policy, but certainly when you look at some of the things, for example, one center that we worked with showed that reducing the hemoglobin A1C by 1 percentage point saved $27,000 for the institution. So there are some changes in terms of readmission penalties, pay for performance, and I don't want to get too much into the weeds, but there are some incentives out there. And so what we have to do is frame the argument in terms that hospital administrators understand. And at least in my experience with hospital administrators, they say all the right things, but at the end of the day, when the doors are closed, it's all about that bottom line, because it is a business. They have to keep their doors open. They have to balance a budget. It's not always an easy thing to do, especially in declining reimbursement. So we have to respect where they're coming from in terms of their expenses to keep things open. But we have to show cost effectiveness. And I think Nikki touched on that by saying, when we do these endpoints, we have to make them clinically relevant in terms of dollars to the hospital. So when we said, hey, we dropped the hemoglobin A1C, hospital's like, who cares? What do I care? Well, that means you just saved $27,000, or the insurance company saved $27,000. Then they're going to get behind these sorts of things.
Yeah, length of stay and readmission is very expensive for hospitals. Dr. Ken Snyder, who's in the chat, he's one of our neurosurgeons, one of our esteemed local neurosurgeons, made a really great comment about direct contracting and risk sharing. And the practice that I alluded to previously is a very large practice that is part of a pilot program, and they manage a number of thousands and thousands of lives. And that's why they're taking these innovative approaches with the gardens, with education about nutrition as an intervention for health. So I think those are the kind of creative approaches that we need to take if we're going to see patients more healthy using food.
Yes, I think that we're kind of in a transition of different payment models, they're certainly in the ambulatory setting. There already is reimbursement based on health outcomes, like lowering hemoglobin A1Cs and immunizations and things like that. The other thing that comes to mind is, you all have talked about engaging patients in the cooking experience and understanding nutrition and pulling chefs in and pulling family members in. And that could increase patient satisfaction within the hospital. And one of the things that does affect reimbursement is patient satisfaction scores. So we can navigate that way.
And I was going to give a plug for the veterans hospitals. They have a program called the Healthy Teaching Kitchen that focuses on teaching veterans and their families, because that can be a struggle when they're coming back home and getting back into normal life, teaching them culinary skills, nutrition skills. They measure their outcomes. It's a program that's available at I would say almost all veterans hospitals, and out in the community as well. So a niche population, but there are models out there that do recognize that hands-on experiential learning for their patients can benefit ultimately like the bottom line for the hospital. There can be some wellness and resiliency built into getting these hands-on experiences for the hospital, which can reduce some of the mental health crises that patients can experience. And so I think they see some multifaceted benefits for their population that could be replicated and some similar outcomes thought of for some of our other hospital systems. And I like the comment about community centers with simple cooking classes. So linking some of our hospitals with our wide network of community centers and being able to meet people right in the immediate zip code, and using the community health worker model where there's peer support for hands-on nutrition education that might not necessarily be coming from a provider, but from one neighbor to another in a community center, really kind of uplifting each in their own immediate neighborhood. So, two thoughts on, battling some of the challenges that hospitals have about not seeing nutrition as a bottom line outcome.
Thank you for that. I think that's important. I think you've also raised the emotional connection with food, and that also suggests having the people on the team that can also pick up and are cued into that emotional connection. I have some specific questions for you, Chef Dr. Mike, that were intriguing and are just kind of related in general to this topic. So you said in one of your books that great chefs put some of their own essence or chi into each culinary creation. What chi do you put into your cooking?
Love. You know, I go back and I didn't realize it at the time. But I'll share a quick story. When I was growing up, we moved around a lot. And again, belonging my age, this was way before the internet. And so I was always the new kid there. And as you know, kids can be kind of cruel to other kids, especially the new kids that come in. And at one place, you know, even the teacher, you know, joined in, and she didn't even call me by my name. She just called me new boy. You know, and that really egged everyone else on to join in. And you know, as sort of a social outcast, the kitchen was a place where I could go because my mom was always there when I came home after school cooking something. And the worst day that I had in second grade, you know, I went home, you know, basically, you know, just crushed and in tears. And somehow when I'd been sick, my mom would always make her homemade chicken soup. And, you know, when I got home that day, somehow like my mom knew, like mom ESP or whatever, you know, and she gave me that bowl of that chicken soup, and it healed me in ways that are way beyond the nutrient, you know, content of that soup. And, you know, I make a pretty good chicken soup today, but it'll never be my mom's chicken soup, and it'll never hear like her chicken soup. And so, yeah, I just try to put in, you know, that good feeling, and make sure that when people eat the food, they eat it with good feeling. I don't want to get too woo-woo, but there is evidence, you know, from looking at mindfulness, the mindfulness aspect of what we eat, that how we eat can produce measurable effects in terms of both inflammatory markers and looking at things even like cellular aging. So differences in telomere length when we use that as a gauge of physiologic or cellular aging. So there's a lot of components that go in beyond just the chemical composition. And to me, that makes a lot of sense because, you know, as human beings, we're about like $6 worth of chemicals and a lot of salt water. But I like to think our lives are a lot more valuable, and we're put together a whole lot more complicated, you know, than stirring us up in a cauldron. So yeah, so I try to put love into everything I cook.
I think that is just a wonderful message to end on, frankly. I don't know if I could come up with anything better. But I invite the panel for some parting words, and given us lots to think about.
I think the future is now, right? Like we can all start where we're at now and consider some creative ways with the ideas we're learning today. Thank you, Marla and BNMC. I think this is a catalyst for change, and the future doesn't have to be something that we're still you know, hoping we get to, but that we can make some strides on getting there now, especially, you know, networking and finding out what we have in our own communities. But there are best practices emerging across the entire nation. This is not the only place a conversation like this is occurring. And it's thrilling to think that there are dietitians and chefs and nurses and social workers and doctors who are having this conversation in cities across America. Our patients will be better off because of all of these conversations. So the future is now. It can be now.
Thank you, Nikki.
I love that, Nikki. That's a really great way to like wrap up this. And I do want to just do a little plug. BNMC, as I said before, wants to have continuing symposiums, and we're hoping to have a local food as medicine coalition here to align with the national one, where we can all get together and have these discussions on a regular basis. So this was our first panel, and it was fantastic. Thank you all so much. You all are just fabulous people, as well as being great in your field. And I love the passion and the curiosity. So we are now going to take a 5-minute break just to kind of, you know, get a little bit of a breath, and then we're going to come back. We're going to delve a little bit more into the nutrition education, more on more curricular edge, and then we go into our lunch fun segment too. So there's lots of great stuff to come, but we're going to take a 5-minute break, and thank you all so much. Thanks to everybody on the panel.
Thank you.
Thank you.
Okay.
So, I mean, I can't call Suburban. It's not like I can schedule an appointment for today and go back in.
No, you're done.
The phlebotomist gave me a fax in her name, so if I wanted to call them and get a script, but.
Yeah, but they're not there today even.
Yeah.
Marla? Marla? Is Dorothy Johnston talking to you? Here I am.
Yes, Dorothy.
I just wanted to tell you what a nice experience this was and how much I appreciate being part of it. It was lovely.
Excellent. We loved having you on. We're very excited that I love to connect with you too. This is the first time.
Great. Hopefully I'll see you tonight.
Yeah, absolutely.
Okay. Take care.
All right, so we have everybody up, and I am just going to introduce right now Dr. Gary Giovanni, and he is the SUNY Distinguished Professor Emeritus in the Department of Community Health and Health Behavior, School of Public Health and Health Professions at the University of Buffalo. Dr. Gary Giovanni is a behavioral epidemiologist, whose research focuses on tobacco, food, and health promotion in general. He has served as the chair of the Department of Community Health and Health Behavior and is Associate Dean for Faculty Affairs in the School of Public Health and Health Professions. He has taught family medicine residents how to counsel their patients to quit smoking, and currently serves as the faculty advisor for the Jacobs School of Medicine Preventative and Lifestyle Medicine Student Interest Group. Recently retired, he plans to continue to conduct research, teach, and volunteer in ways that promote health throughout the community. We're very happy to have him. He's going to introduce the rest of our panel. Take it away, Dr. Giovanni.
Thank you, Marla. Can you hear me okay?
I can.
Great, and people are nodding. Thank you, and it's such a joy and a privilege to be here to facilitate this session. My interest in nutrition goes back to 1976 when I heard one of my first lectures in cancer epidemiology and indicating that lack of fiber and high levels of red meat could contribute to colon cancer. And I was very upset learning that, because I thought I ate the best diet in the world, the standard American diet, as Chef Dr. Mike talked about. And while most of my work has been on tobacco over the years, and while I've helped a lot of doctors help their patients quit smoking, my work on nutrition has been on my own time. And it's only recently that I've actually started publishing on it and working on it. And I've had the privilege the last 4 years of teaching lifestyle and health to incoming medical students, to first-year medical students. And the reception has been very positive, but I was relating back to Dr. DeVries' survey data that when they first come in, they're very excited. And by year 4, the level of excitement has been toned down. And some of my MPH students, Master of Public Health students, who have gone on to medical school have by their 3rd and 4th years just said, you know, there's no support for what you taught us about lifestyle and health. And I would really like to, I wish it changes. Well, I've learned recently, to my great pleasure, that it is changing. And the people on this panel are leaders in that change, have been leaders, and are experts in that. So I want to introduce them now. First member of the panel I will introduce is Dr. Jill Tirabassi. Jill is a dually board certified physician in both family medicine and preventive medicine and public health, and is fellowship trained in primary care sports medicine. She currently has an NIH K-12 research grant in implementation science, so important here, focusing on how to improve food and physical activity environments. She also practices clinically at the ECMC Family Medicine Center and spends time teaching and precepting family medicine residents and students. She has published several articles and chapters related to primary care and sports medicine topics, and she is excited to be a content expert on lifestyle, the medicine aspect of the new curriculum for the UB medical students. So welcome, Jill. The second panel member is Dr. Daniel Sheehan of the Jacobs School of Medicine and Biomedical Sciences. Dr. Sheehan received his PhD in physiology from the University of Buffalo in 1989 and earned his MD from Johns Hopkins University in 1997. He completed his pediatrics residency and pediatric pulmonology fellowship at the Children's Hospital of Pittsburgh of the University of Pittsburgh Medical Center. He was an attending physician at Nationwide Children's Hospital in Columbus, Ohio from 2002 to 2004, and has been back in Western New York at UB and Oishei Children's Hospital since 2004. He's been Associate Dean of the Medical Curriculum at the Jacobs School of Medicine and Biomedical Sciences since 2015, and he is currently co-leading an interprofessional team of educators that is developing a 4-year preventive and lifestyle medicine curriculum that will train UB medical students to promote health and wellness and to prevent and address chronic diseases that are caused by or impacted by unhealthy diets and sedentary lifestyles. Welcome, Dan. Dr. Catherine Levine Mager is at the Roswell Park Comprehensive Cancer Center. She is a gynecologic oncologist at Roswell Park, and she's originally from New York City, where she attended college at Columbia University, followed by medical training in Philadelphia at the Sidney Kimmel Medical College of Jefferson University. She did her residence training at the NYU Medical Center and fellowship training at Memorial Sloan Kettering Cancer Center. Her area of clinical interest is the treatment of gynecologic malignancies. And here's the connection. Her research focuses on both clinical and translational research in the area of nutrition, obesity, and physical activity in cancer care and outcomes, particularly in endometrial cancer. Welcome, Katie. And fourth is Matthew Zahn. Matthew Zahn is a second-year medical student in the School of Medicine and Biomedical Sciences. He earned his Bachelor of Science degree from Alfred University in athletic training. Matt is a member of the Preventive and Lifestyle Medicine Student Interest Group, one of the leaders, and he's passionate about lifestyle medicine and believes in the importance of utilizing lifestyle and preventive medicine measures to treat patients with chronic diseases, such as diabetes and heart disease. He currently serves as co-president of the Student Interest Group and also of Sprouts that Dr. Cappuccino mentioned previously, a local community garden initiative. And interestingly, Matt is also working to expand a community walking program called Walk with a Future Doc. It's so cool. Walk with a Doc is spread throughout medical institutions in the country. I didn't know that Walk with a Future Doc existed, but welcome, Matt. So we have until 12:20, almost an hour, and I have several questions, very interesting questions to pose to the panelists. I'll ask our panelists to speak up if they wish on these questions, and I might even call on one or two. And the first question is, Nikki said the time is now, and really, the lack of education in medical school is a big gap. And so where do you all see the main opportunities and responsibilities in food in medicine, food is medicine, as lying?
So I would say, as we heard from Dr. DeVries, it really is across all levels of training, from medical student to resident to fellow to CME as well. And I think it's very important to think about how we train individuals, what they learn, how they critically review the old and the new research on diets and nutrition and nutrients, because there's a lot of misinformation out there. In addition, they need the opportunities to actually practice some of that beginning counseling and motivational interviewing. As Dr. Cappuccino mentioned, the physician often is that first point of contact. And when you talk about opportunities, I think the real opportunity is really this focus within the healthcare system about wellness throughout the healthcare system of the trainees, the physicians, and the healthcare providers, along the lines of, healthy trainee, healthy physician, healthy healthcare provider. And that will lead to that healthy patient, so that there's role modeling across the levels.
That's terrific, Dan. And I'd just like, they're all crucial at every level. And I'd just like to follow up briefly before I give the floor to Jill. But in my research with doctors, this is back in the 1980s. So some doctors, some of the residents smoked. And the doctors who smoked were by far the least likely to counsel their patients about quitting smoking for very understandable reasons. And I love what you said about the doctors also assuming a role of personal health and personal wellness, and how that will facilitate teaching and the educational component of medical practice. And will that be emphasized throughout the curriculum, do you think?
I think it can, and I think it will be. As we move towards our new curriculum in 2023, in 2022, we're introducing learning communities, where students of groups of 6 will have faculty and team and neighborhood mentors. And that's a great place for them to learn things along the lines of culinary medicine, as well as really look inward first to look at their diets, their nutrition, and their lifestyle.
Great. And they'll be able to understand their patient's behavior change if they end up doing it themselves. Does anybody else have any follow-up to this? What do you see as the opportunities and responsibilities in food as medicine? Dan covered it. Oh, go ahead, Jill.
Yeah, no, I think he covered it really well. As Dr. DeVries highlighted, well, there's a lot of opportunity because as of right now, there's not much there. I studied nutrition in my undergrad at Cornell, and in my residency, I was the expert on nutrition. So I actually gave the lectures to my co-residents on nutrition because no one in the faculty felt qualified to do so, along with another one of my co-residents who's very interested in nutrition. She studied at Tufts, so they'd had a little more, they're a little ahead of the game in terms of nutrition education. And so I think we have to recognize where we're at right now. We have to recognize, as Dan was highlighting, like provider issues, provider burnout. We have to recognize we're in the middle of a pandemic, and all these challenges really all work together as we move forward. And so I think part of this really is helping our students learn how to take care of themselves, helping our faculty learn how to take care of themselves and modeling that. Because you're right, we're not going to be able to help our patients if we're not there ourselves. And so I think, through this conference so far, we've seen really good examples of, where we're going, where we need to go. And I would say most providers, aren't aware of this yet. So just broadly, getting this out there, this is important. This is evidence-based, are some of the biggest first steps we have to do. And if our faculty, if providers out in the community who students work with don't know about this, then yeah, they will fall off. That education will fall off, and that passion for it will fall off over time. So there's a lot of challenges and a lot of opportunities.
For sure. Dan, you mentioned misinformation and how it's kind of prevalent out there, or Dan or anyone, with many people with an MD who have minimal training in nutrition, telling the world that certain diets are better and not to believe the experts. So why do you think that's happened, and how do you think training in nutrition in medical school can help solve that problem? Katie, you're next.
So I'll go real quick. I think we see this with everything, and where everything within society is very polarizing, and people have their own opinions and their thoughts and so forth. And I think it really is just incredibly important to teach them how to critically look at the research that is out there in the past, as well as what is currently there and coming forward. We often in medicine will practice mean and standard deviation medicine, or something that we've read in an abstract, where I think we really need to really dive a little bit deeper and actually look, just like if food is a medicine, well, there are responders to medicines and non-responders. And some of those are inherent within that person, but there's also the structural and societal determinants of health that need to be considered as well. I think we all like the idea of lifestyle medicine. The word style makes us a little uncomfortable because that suggests choice. And I think we have to keep in mind preventive medicine as well as access to resources as well.
Great points. Katie, I think you had wanted to speak as well.
Yeah, sorry, if I could just jump in here.
Of course.
I think such an important topic. And in the world, obviously, I'm perhaps a little myopic here just because I'm in the world of oncology, but these nutritional approaches to cancer care and things like that are very, very, very common in sort of popular culture. And I can tell you that probably more than 50% of my patients at some point have asked me, should I stop eating sugar because it feeds the cancer? Things like that, right? These nutritional approaches to, nutritional approaches to medicine. And I think this all goes back to how important it is that we take some control of this narrative, right? That there isn't this dichotomy between Western medicine and sort of the medicine we practice here in the US and using nutrition and food and as part of that. And as of yet, in medical education, we always learn about the endpoint, right? Obesity is bad. It causes these things. Eating this is bad. It causes these things. But just as everyone has brought up, we don't get education on how to actually talk to people about nutrition before we get to those endpoints, right? And how to intervene and what the good interventions are. So I think this just brings up such an important point, that it's really important that in standard practice, we are taking control of this area and providing good information. And it's not, you know, us against these other experts. It's that this is what we learn, and this is what we talk about, and that we're part of this narrative.
That's brilliant, Katie. And I'm thinking back to Karen Pearl's pyramid slide, and, you know, just talking with people on a general visit or will reach, you know, will reach more people than just addressing the people who are seriously ill. So all great points. There's very good evidence that if the doctor doesn't bring up smoking, some people who smoke will think that that's tacit approval. And for doctors to bring up nutrition, it's hard if they don't feel skilled in it. If you're trained like Jill is, or like our future medical students or our graduates will be, it's much easier. So, okay. Anything else on that question? Opportunities and responsibilities. So here's the next thing I'd like to bring up. How can we begin to change the mindset around food and medicine for the doctor-patient relationships, as well as for clinicians and even the curriculum board? You know, what are the challenges? How can we begin to address these challenges of changing the mindset? Dan? Can I put you on the spot?
You can put me on the spot. You know, I think as we talk about the challenges, I think the challenges is in undergraduate medical education and resident education as well, is ironically, we say the refrigerator for curriculum is full. You know, there's really not a lot of room to add things. And you know, and in addition, we already have so much emphasis on repair that we have to look at those opportunities where we can talk about prevention, where we can talk about where nutrition can either prevent or reverse disease. And it's hard. And I think that's because we're working in a system where the outside forces of licensing exams are focused on repair. So we don't have we have exam questions with respect to nutritional deficiencies, but not necessarily how we can use nutrition and food otherwise. And so those are kind of the bigger challenges there within the system. And I think the other thing is as a pediatrician, looking at things developmentally, you just don't want to open the hose. You really want to be intentional where you provide that information so that the trainee can either use it personally or professionally within 1 to 2 weeks in order to help make that information stick.
So how can we get clinically relevant nutrition questions on some of these standard exams that trainees need to take to get to complete medical school and then to become certified?
I'm going to tell you, I don't exactly know, but what I've seen more recently is things along the lines of health system science, now that they're starting to have health system science. And so there was some way to get an expert on health system science, and Ken Snyder may have a sense about that, onto the board exam writing questions. So.
Okay, thank you. Jill, do you have any thoughts about the challenges, especially with the doctor-patient relationships?
Right. I mean, I assume all of us have been patients at one time, especially in like an outpatient setting, and we obviously know time is a barrier. And so I think, you know, in family medicine, especially, we have these longitudinal relationships for the most part, unless people change insurances or have to see other physicians. And so, you know, I think we have to recognize that behavior change, especially, isn't something that happens quickly. And so small incremental changes over time matter, especially when it comes to, you know, nutrition habits, right? So I think we have to, incorporate it in a way that works in our system while still advocating for change. I think we have to model it, and we also have to recognize that, like, when we're meeting patients where they're at, they might not be at that phase yet. They really might be coming in after hospitalization, and we have to like problem solve what's important then. So there's not an easy answer to it, and obviously this, if it was easy, we would have done it by now. I think starting with the next generation of physicians and working through a nutrition course with them will be a good change, and that's where we got to go. But I think it's complex.
Ken Snyder makes a couple of good points. HSS, I'm not sure what he's referring to, but can easily be the vehicle to deliver some of this work. But the entire curriculum design gives us all great opportunity. Health system science, right, of course. And bringing health and wellness into the basic sciences is just as critical as the clinical science. Boy, I couldn't agree more with that. Let's see, Matt, might you have any thoughts as a second year medical student who's really, really invested in looking at lifestyle, and I suspect in your future, you'll really want to help your patients in this way of, what the challenges might be.
Yeah, absolutely. So as a second year, some things I noticed too is just that the curriculum is, full of a lot of information, important information that we're learning. So the addition of additional things like lifestyle medicine or nutrition can be challenging. Most of my education or the things I've learned have been kind of like outside, whether it's reading books or just finding other educational resources. And it does sometimes cut into study time, which I think is personally for me useful. But yeah, I think it's definitely a challenge. And there's also competing interests with students trying to figure out the specialties or the areas they want to pursue, and to put that into the clinical education is worthwhile. And I think it's something that's very valuable, but it's definitely a challenge, something I hope to be useful or helpful in the future.
So you're willing to take some of your own quote unquote spare time as a busy medical student to study this, and you've been doing that for a long time, is my understanding.
Yeah, right. Yep. So I find it valuable, and it's something that's important to me, and I think it'll be important for my future patients and just the population in general. I think it's something that's really important because we talk about food, and it's such a food is, just the stuff that you put into your body every day, how it has such an impact on what you eat, or what you, basically the diseases you can develop or how healthy you can be. So yeah, for me personally, I enjoy learning about it in my spare time.
Cool. And you will be in a practice someday, either on your own or with several other physicians. And we learned one model that in one of the preventive lifestyle medicine evening sessions, which is in some practices, there might be 5 or 6 specialists, one of whom is a lifestyle medicine expert, and they can refer patients as needed to that expert. So you could play that role in the future.
Absolutely.
Okay, so I wonder how one might be an advocate for change within your practice or facility. Catherine, this seems like something that might have interest to you, and I wonder if you'd like to comment.
Absolutely. I think the first step in advocacy about this is just talking about it, right? Bringing it to everyone's attention. But I'll tell you that so in gynecologic oncology, there is a very specific connection to nutrition, and then obviously obesity and nutrition being 2 separate things to some, not to say connected, but right, we talk about the 2. But obesity being a very big problem within our endometrial patient or endometrial cancer cohort. So it's an area of very specific interest in the world of gynecologic oncology. But I have found that at least for for my practice, one of the most effective means of advocacy is really through research. And I know we've all been talking about this, the importance of research, the importance of funding, but I think doing a lot more to elucidate with research the real problems, and then you can argue to address them, right? But we have, in my opinion, despite what seems like almost overwhelming research regarding nutrition and health endpoints, on some levels, they're not specific enough to allow you to really take intervention. So I think talking about it, making it, bringing it up within your group, within meetings, taking the initiative to try to do research, even within your own practice, quality improvement projects, right? Where you're looking at what's going on in your own practice, and then using that to directly advocate for funding to address those issues. I think that's a big part of, that's to me, what's been most effective in my own practice.
And that sounds terrific. That sounds great. It's been argued that, we have, 13 institutes in the National Institutes of Health. And some have argued that there should be a National Institute of Nutrition, where the nutrition projects wouldn't just get put in a corner for each of the, but they would be given priority, and that could facilitate the funding for what you want. Although there are decent funding sources, I would think, in NCI for this. Has that been your experience, or is that?
Yes, there are some clear funding sources.
And by NCI, I meant National Cancer Institute, sorry.
Right, yep. No, there are absolutely specific funding sources for this. And so exactly, I think continuing to advocate and produce good research around this, right, to show its importance. And then frankly, we've touched on this already, that patients are motivated towards wanting these kinds of intervention, this kind of education. And this can be a great resource you can offer to patients to make it appealing to be a part of your practice, right? And there's a line to walk here, because I think on the one hand, and everyone who's a clinician has probably experienced this, there can be a degree of alienation of patients in talking about weight and obesity and lifestyle choices, right? And this, I'm sure, comes up in smoking as well, right? There's sometimes they don't want to hear, but if presented in the right way, there's huge, in my experience, huge motivation towards wanting to do these wellness interventions. And frequently patients will come to me talking about supplements and, these things that are sort of outside of diet. But this could be a huge draw for patients. And I think, again, producing research where we say, hey, I've had 75% of my patients have come in looking for nutritional resources. Then you can go back to your hospital administration or practice administration and say, this is a huge draw for patients. Let's establish something, let's have a nutritionist embedded in our clinic, or let's have, and use metrics like that. So, but what's needed is a lot more data. And I found that coming with good data, specifically data that's specific to your practice, has been a great source of being able to make change.
Wonderful points. I appreciate that. Jill, did you have any other thoughts on this?
Yeah, I can speak to a few different places where I've worked over the years. I've practiced in 4 different states now, so I've seen a few different models. I've seen, and someone mentioned this earlier, like group-based visits as a way to incorporate this, right? So I've worked with different wellness groups, and we would bring in patients together, and rather than young female white patient blabbing about nutrition at people, we worked on fostering growth of, and knowledge about nutrition from patients within themselves. And I think that that's a great way to get this done. And so that was well supported by clinics I've worked at. And I think that, there's a good amount of research now on group visits for this sort of thing. I think, advocating to like have health coaches or dietitians in the office, as was just mentioned, is huge. I worked with a small private practice out in rural Colorado where referring to a dietitian was not an option. Although thank goodness, telehealth has now become a thing, and I think that that's something that we could be utilizing more, especially for things like dietitians. But having a health coach, so I would leave, this patient hypertension. They wanted to learn more about the DASH diet, right? A evidence-based practice that lowers our blood pressure. And the health coach would work with them on that. How do they lower sodium? How do they read food labels? How do they, make sure to check? There's like the canned versus frozen food debate earlier. And so making sure if they are buying canned foods that they're low in sodium. And so I think, there's many different ways to approach it, and working with your system, with your resources will be different for everyone and a different challenge for everyone. But there's a lot of partnerships and there's a lot of ways to make it happen.
Excellent, thank you. So regarding the research, Dr. Snyder on the chat suggested that we centralize and share funding sources within the group. So that could be something to build on. And I suspect he'll talk about that later. Forming a combined coalition. And Dr. Morales points out that there's NIH money from the Diabetes Institute and Heart, Lung, and Blood, diabetes and digestive disorders. And the question came up earlier about the role and the interactions with dietitians. And have any of you interacted with dietitians, and how has that gone, and what kind of bits of wisdom might you have gained from those interactions? I'm wondering, Catherine, given your experience, is this something you might address?
Yeah, absolutely. So I already said this. In my perfect world, I would have a dietitian right in clinic with me and they would be, they would be seeing the patients right after I did. Every time someone's sitting for a chemo chair, I would have a dietitian going down and chatting with them during that. I think having dietitians as a resource is invaluable. The way I see the relationship or in my practice, and of course it can take different forms, but the way I see the relationship is that the clinician needs to start the conversation and really emphasize the importance of nutrition, both in preventative medicine and once you've been diagnosed with a serious illness, right? It's the whole spectrum. And so we need to introduce the conversation and keep the motivation there, right? Bring it up at every visit, be mentioning what's, how are things with diet, talking about healthy lifestyle. And of course we can be available to answer, sort of specific questions that may come up, but really, I think with the way most of our practices are set up at this point, it's a time issue, right? And I would say probably number one, it's a time issue that I think to be really effective, it takes a little bit of time, and most of us are not budgeted for that, unfortunately, in the way our visits are set up. So I think having the dietitian available to really take that time to go through specifics of that patient's current diet and then where they should be going with their nutrition, that's where I see them as being invaluable. And I work with the nutritionists, the dietitians at Roswell quite a bit. Of course, being a comprehensive cancer center, we have a lot of resources in that way. And I have found it invaluable to follow up these conversations with a referral, with a nutrition referral. And the patients really find it very helpful to have somebody who's going through in such detail. And I think something I've really picked up from working with them is also when I'm trying to talk to patients about nutrition, taking a moment to be a little bit detailed. And I think for anyone who's done this, sometimes you're completely shocked at what you hear, right? That you realize that you're on a totally different wavelength when you're talking about nutrition. You're saying, oh, increase your protein, lean proteins, increase vegetable intake. But then when you actually talk about what that means to that patient, they are interpreting it completely differently from how you think. So I think that's something that's been a takeaway, to be really sort of detailed in your approach, and then detailed in your advice. But I think that's the relationship, and it's invaluable. And there's overlaps, but such incredible space for everyone to be working in their own way towards the patient's nutritional health.
Yeah, and we talked about that's really, really interesting, Catherine. Thank you. We talked about challenges in the systems, and this challenge of discussion time not being reimbursed has traditionally been a challenge. I'm understanding that that's changing to some extent, which I think is a real positive development, and that taking the time to spend with your patients will be reimbursed appropriately. So that's great. Jill, I know you said you've had some experiences. Do you have any? Would you agree essentially with what Katie has said, or maybe or expand upon it, or disagree with it? What are your thoughts?
No, I think everything she said holds true for my experience. I think that, for example, I saw one of our community health, I think maybe it was one of our community gardens people leave a message about, patients come to us saying that doctors say that we can't have fruits because there's sugar in fruits, right? And I read that, and I just, so there's such a vast issue here, right? And so sometimes I worry a little too much about if we don't have the proper training, then we can't be giving much food advice at all, because if doctors are saying that to the patients, or at least how patients are interpreting what their doctors are saying, is that wrong, we're in trouble. So I think ultimately, I completely agree. The model should be the doctor needs to start the visit, try to get an understanding of the patient's resources. Is this someone who needs SNAP? Is this a mom who needs WIC? And making sure, we have these kind of things going, as well as understanding what are their skills, with food preparation. And I think there's such a wide base here that it takes a lot of work to be able to do it well. And so, I think ultimately I would love for all my patients that preventatively, right? So getting, if I see a food pattern of highly processed foods, inability to prep, that I get those patients to dietitians before, we see that chronic disease develop, or especially for kids, right? That their parents know how to prepare foods for them. With the pandemic, unfortunately, the growth charts for children have just really been bad over the past year. Most of the kids I see now are in the obese range at my clinic. And so there's a lot of work to be done with how to make this more smooth, and to make sure that we're getting people to the right place and trying to catch things early before we see that end stage.
Absolutely. So let's talk about education. The question came up in the chat, and I was planning to ask this, is how can we better address siloing in clinician education? Maybe that is a problem, maybe it isn't, but perhaps nutrition shouldn't be siloed in education, with doctors and dietitians together from the start, perhaps with some classes where doctors and RDs attend together. Do you agree or disagree with such an idea? Maybe Dan, I'll put you on.
Yeah, I always think of how to operationalize things, and we are training. We have interprofessional forums where our 800 health science students get together around a case with small tables and a faculty facilitator. We've done this with the opioid epidemic. We've done this for our third years with around a video of a patient who has multiple health problems. And so at that table, you will have a dietary science, nutrition student, you'll have a medical student, you'll have a nurse, you'll have a pharmacy, you'll have somebody from the School of Management, and some others as well starting to discuss that. And I think that's incredibly effective to have them start to understand what they're learning. It's a different depth as far as currently where our curriculum is at. And there's always that wonderful mechanics of the timing of getting people to be able to work together. You know, one of the things we're going to be doing within the next couple of weeks is replanning how we teach our third year students motivational interviewing.
Yeah.
So we're actually going to use the Gaples 4-hour course to kind of reboot what they know about nutrition, and then go from there and do something we did a couple of years ago with Nikki's dietary science, nutrition science students, where our students would practice motivational interviewing around diets, learn about diets, and have her students there help us facilitate that wonderfully large group of 180 students in our active learning room. So I think there's opportunities where they can learn with each other, as well as important, learn from each other. So what I would love to actually hear from Matt is any ideas from the medical student, and as far as where that might occur, having gone through our curriculum the first year and into the second year. So opportunities where other professional students could learn about nutrition and exercise science, opportunities that you might have seen.
That's a good question. I definitely think with each of the blocks, there could have been like opportunities to bring them in. So I guess at the end of the blocks, that's a good question. I have to think about
a block is like a section on a body system. Is that right? Just for the listeners. Okay.
Yeah. So we have organ systems based.
Right.
And I've kind of thought about this a little bit too. And it would be important to kind of include like RDs and MDs together in some sort of like a session, whether like if it's on maybe like endocrinology, like diabetes, having the dietary students learn a little bit more about kind of the disease process, and then having like a class where we learn about the nutrition aspects of it. So kind of combining classes in that aspect, and we could do that for other organ systems like cardiology or different things like that. They kind of have like a big lifestyle factor into them. But there's to think about specific times, I'd like to think about that a little bit more, and I actually can get back to you on that too.
Yeah.
Anyone? No. The Preventive Lifestyle Medicine Interest Group works to try to bring in clinicians to speak about lifestyle medicine at the end of some of your sessions. So I think it was last year at the end of the nephrology section on kidney disease, you guys brought in a nephrologist from New York City who incorporates diet heavily into his practice. And he had a lot of interesting thoughts to share, but that should be done routinely, I think, if I'm hearing your suggestion correctly.
Yeah, and that's one of the things we're trying to do with our group is bring in different clinicians that focus on lifestyle management within the specific organ system that we learned about. So for example, we just finished up cardiology. So we're trying to connect with a cardiologist who be willing to speak on how they utilize lifestyle management within their practice regarding cardiology patients or hypertension, things like that.
Sure.
And that would be useful across all the different organ systems that we use. And that's kind of one of our goals with our group is to bring in those type of speakers and talkers.
That's wonderful. Yeah. And everything, Dan, I think as a follow-up, to me, this is wonderfully optimistic. This is, Nikki said the time is now, the wave is breaking, and I'm just absolutely thrilled to see it breaking. But Dan, you had something else?
Actually, I had another question for Matt. I think what we tend to think of our students as just coming to us as empty vessels. And they come to us with their own experiences, their own knowledge, there's their own anecdotes. And so I actually would like to ask Matt, as you've met your classmates in a limited way in the past couple of years with COVID, what are you seeing as far as what they're doing with their own personal diet, their own personal lifestyle, and the range of that must really exist within 180 individuals?
Yeah, so that's an interesting question. So going back to one of the questions we talked about before was being like an advocate. And so for me, where I am, being an advocate means like living healthily, eating a good diet, predominantly plant-based, and exercising, trying to get as much sleep as I can. But within the student body, I think it's And I feel the pressures too. Like it's difficult to be able to balance that in addition to trying to keep up on everything, all the information that you're learning. I thought about it'd be interesting to do some sort of like a study to determine the health of the students coming in versus like going out like second year. But as far as like diet, I don't see too many people. There is more than I expected to, that would be interested in lifestyle medicine and have the knowledge of it and like and nutrition. But I don't know if it's across broadly. And I think it is difficult to keep up with a healthy diet in addition to the curriculum and not prioritizing it as much as you prioritize, your studying and doing passing the boards and things like that.
Great. Go ahead, Katie. Yeah.
Yeah. So I just wanted to circle back to sort of the question of educating sort of different disciplines together, right? Yeah. And this divide between RDs and MDs or DOs, and I keep bringing this up only because it's something that's really on my mind, that I think there's two components to nutrition and lifestyle counseling in general, and it's the actual nuts and bolts, right? So the recommendations: you should have this many active minutes a day. This is what your nutritional your calorie intake, blah blah blah, right? But then there's just communication about this as a component of your health in general, right? And I think that we can argue that maybe the divergence in sort of where a doctor's education goes and where an RD's education goes is in some of those sort of specific interventions and how deeply we go into that. But I feel like every healthcare professional, let alone not just RDs, should be getting education on how to talk to patients about lifestyle.
Absolutely.
And I think that this would have two really great benefits. One, that we learn how to be effective in communicating this stuff. I have it on the mind all the time because I'm still trying to figure out how best to speak with my patients about it, especially working with all women. So all my patients are female. And I'm sorry, this comment's going to be a little bit sort of talking about sort of my cisgendered patients and acknowledging there's an entire world, outside of that. But, women have so much societal baggage that goes along with weight and things like that, and diets and nutrition. And it's really hard to navigate the conversation. And I have really worked to try to find resources how to best do this without finding them. And I'm running some protocols now to try to look at how we can intervene and talk about this. But more data behind that, and then having it be part of education, how we talk to patients. So that would be really useful just in terms of introducing these interventions, again, not alienating patients. And that should be every healthcare practitioner. And we could all be in a class together, right? We could all be looking at it together. And then also, frankly, there is a lot of bias against obese patients, unhealthy patients. And we always see this come out in the media, right? Where someone left their cell phone on and they recorded, all the doctors saying bad things about their weight. But we do hear this. And even if we're trying to confront that bias is there. And so I think also education around all that would be helpful, both for communication and then also just for compassion and understanding and knowing what goes into, people not having healthy lifestyles. So I think every single healthcare practitioner should be getting that education, and we could all do it together. And I think it would be hugely beneficial.
We could stop right there. That was fantastic. But I think there is, Dan mentioned motivational interviewing, and that is, probably state of the art right now, but, that science will grow as well. And you brought up the issue of different kinds of patients and how best to keep a patient-centered focus, maintaining individual respect and autonomy. And so that's all good. That's all excellent. Well, we have about 10 more minutes, and I want to transition to ask if you've experienced any roadblocks in addressing food as medicine Could it be funding or individual hospitals or hospital systems, payer buying? How did you overcome them or not? And what challenges throughout the entire medical education, be it undergrad, medical school, residency, or beyond? Jill, is that something I could
you could throw my way?
Yeah.
Yeah, I think we've broached a lot of them. I think I could list the roadblocks forever. But highlighting maybe some of the ways that we can overcome them. I think as a systems issue, if we look at like hospitals, for example, are we modeling there? So does our cafeteria have nutritious foods that help providers as well as patients be happy? How many times can I say Happy Nurses Week and bring in pizza for everyone? Like that's, there's subtle things, right? And so, I think we need to be healthier ourselves in that respect. I think, it can't all be done in the healthcare system. I think we need to recognize that we can help train community health workers. So I was part of training what they were called block captains, and we taught them basic health, nutrition, wellness stuff so they go back to their communities and teach. And I think that that's one system. I see people popping up here about nutrition education, and that I had written that down. We have all these prerequisites for medical school, biochem, organic chemistry. Well, my nutrition background prepped me most for being a doctor than any of those other courses did. So we need to have nutrition education, not only in undergrad, I think as part of a pre-med curriculum, but even earlier, like people are saying. I think
that is quite a comment. I'm sorry to interrupt, but my nutrition education prepped me more for being a doctor than any of the others. That is mind-boggling to me. And I mean, great to learn. So I'm sorry, keep going.
No, that's exactly it. Like Dr. DeVries talked about, diet is the number one reason we see some of these, chronic conditions, right? And so we have to understand it, and all the nuances around it, the culture around it, and whatnot. I think we need to understand the food industry and how there is some confusion created on purpose, and the choice being the option that confuses people, and being a little better about that. I think we can even look at what children are fed in schools as a problem that leads to misinformation about what's a healthy, nutritious. Ketchup doesn't count as a vegetable in my book, but apparently, tomato sauce on pizza counts as a vegetable. So there's a whole aspect of our culture that we need to understand that influences our nutrition. And so there's systems in healthcare, but there's just our food system as a whole that we also need to work on too.
Yeah, one of my philosophies as an educator and a public health person is to create environments in which the healthy choice is an easy choice.
Yep.
And so good food needs to be made attractive, easily accessible, and affordable. And right now the system is not set up to support that. The same situation existed with tobacco back in the early 80s when I was talking about it. Now things are different with smoke-free air laws and counter marketing. But when I taught the doctors, I said, you are in such a pivotal role because you have the credibility of a doctor, and your one voice can shine a light that can overcome a lot of darkness out there. I didn't say it quite as poetically as that, but that's how I think about it now. So. A colleague of mine, a friend, was a third-year medical student at UB, and he was on the floors in the hospitals, and he told me a story of a patient in severe metabolic distress with heart disease and diabetes, and the patient looked to the resident and said, "Is there anything I can eat to help myself?" And this is 15 years ago, and the resident said, "Diet has absolutely nothing to do with what you're experiencing." And my friend just didn't say anything because he was concerned. But I like to think that the training that's going on in the hospitals will keep up with the training that's going on in the medical students, so our students will feel more comfortable bringing these things up. So One last question. Are there continuing medical education opportunities or courses for physicians to learn more about food as medicine? What's being offered presently or in the near future? Matt, do you want to talk about College of Lifestyle Medicine or the preventive medicine programs, Jill?
Yeah, so for the American College of Lifestyle Medicine, I feel it's a great resource for physicians and students to look into. There's lots of, there's continuing education courses on there. There's also like the Lifestyle Medicine Interest Group, so that's a fantastic way to get involved as a student. There's also a bunch of member interest groups for physicians to meet like-minded individuals. And that's kind of the biggest one that I have really relied on to get a lot of my information from.
Great.
Yeah, that's it.
Good. And American College of Preventive Medicine, Jill?
Yeah, and they actually partnered with the American College of Lifestyle Medicine for some of their core competencies, including nutrition education. And I think that that's a great resource. Obviously, Dr. DeVries talked about the Gables Institute, and a few of us here, did that course. And I think that that was a really good primer, and especially focused on like what doctors are going to deal with, questions about certain diets, the evidence base for some of them. I think, I did a quick Google when I was trying to think about this, and, most of some of the more advanced programs, Harvard, Tufts, they all have nutrition education, and CME, which is important, right? Doctors and other healthcare professionals have to continually demonstrate that they are learning as through time. And so that 1-2 punch of getting some CME credit and learning this, I think is huge. I think the Mayo Clinic hosted a Nutrition, Wellness, and Health Symposium last month that is supposed to be really good. So I think there's more than enough opportunity out there.
Thank you. It's really happening. And just there's so many good comments on the chat, but I really, in the last couple of minutes, do any of you have any points you'd like to add in closing?
So I have a question for Jill. Jill, you've been with us for 7, 8, 9 months now. Is that right?
1 year.
1 year. Okay. So what I would love to hear is you've learned a lot of bright spots today, but what are the bright spots that you see in our healthcare system, at our school, and throughout the area, whether it be out in the community as well, with respect to lifestyle and food as medicine?
Yeah, so my research really is partnered with the School of Public Health. And so I've been learning a lot about the community resources, and, we have grassroots gardens, we have the Massachusetts Avenue Project. I'm sorry for everyone who's here that I'm not naming, but we have a lot of great community resources that are there to help and assist us with this. And so that's why I'm saying, we need to connect the healthcare world and these community worlds better. And I know that's what BMC is trying to do today. And so I'm very grateful. And I think this push from UB itself, this push from the medical students who have created this group, I mean, these are all the things we need to do to change. And I think there are some top-down measures, some of these ACOs, some of these healthcare metrics, we can't meet that just based on repair. We have to meet that, proactively too. So I think I agree with what was said earlier. The time is right. We're getting a lot of these pieces of the puzzle to help get us to where we want to go, and help, get food as medicine as an important part of our healthcare system. So I see a lot of bright spots.
And on that note, I want to thank you all. There was one comment in the chat that I want to address, which is, what about food and mental health? And that is a newly emerging field, and researchers in Australia are actually leading that work, and they're developing a field called nutritional psychiatry. Felice Jacka, J-A-C-K-A, for the person who asked, wrote a book on it for the lay public, and has published the results of her trial. I mean, it's work that's still very in the early preliminary form, but the basic finding is very consistent, that a diet that can help prevent diabetes and prevent heart disease, prevent cancer, prevent hypertension, also appears to be a diet that can help prevent mental illness. And even, the treat is, I think the research still needs to be done, but it's such an exciting area for listen, you all, you did great. Thank you for taking the time to do this. You contributed to my knowledge enormously, and I hope and trust for the people on this session. So Marla, with that in mind, I'll turn this back over to you.
What a wonderful panel. And Gary, thank you so much for taking on the moderator role, just being able to, you know, have that discussion flow. And I'm just so thrilled of what I just heard. And again, we'll just continue that collaboration. I'm actually going to bring up Jill's remark on all the different community groups that are out there that are so inspiring. And as we go into the afternoon, you're going to meet some of them, including our lunch session. Allison Dehoney from Urban Fruits and Veggies has a wonderful, two wonderful organizations. And she's going to be, first off, we're going to have a video of her and her farm, and then preparing a meal with her good friend and entrepreneur, Patty Green. So that's gonna be really fun. We encourage everybody to grab some lunch and have lunch with them. That's gonna be a very interactive panel where everybody can take their speakers or their muting off and just talk with them about how they feel about interacting with their practitioner, how to make healthy choices themselves. So we're really excited about that. And then we're going to finish lunch and go right into an amazing panel about food equity. And that's with 3 national voices and our own Rita Hubbard Robinson, who is such a valuable member of this community. So we have got great experts on that subject. So we're taking a 10-minute break right now, so everybody can stretch their legs, go grab some lunch, and then come back in 10 minutes to see this beautiful video of Allison's wonderful urban farm. So thank you so much, panel. We really appreciate it. And we'll see you in 10.
I'm sorry, you're on mute.
Thank you, Rita. Okay, so we're starting to trickle back in. Patty and Allison, if you could, yep, I see you're on now. Fantastic. Just gonna spotlight you. Gotta get Allison in. And where's Allison at? Oh, sorry. Okay, so there's Allison. Allison, if you could just turn your video on. There we go. Okay, so now we're on to a wonderful lunchtime interactive farm to food preparation hour. I'm going to introduce these 2 wonderful ladies. First, we have Allison Dehoney, and I consider her one of my favorite partners and a friend. Allison is the executive director over at Urban Fruits and Veggies and Buffalo Go Green. Allison has 20 years of professional service in key areas of executive leadership, project management, and business development. She has spearheaded 4 business endeavors, the latest of which is Urban Fruits and Veggies and Buffalo Go Green. Both of them are nonprofit organizations. Urban Fruits and Veggies have been in operation for 5 years and is involved in several projects throughout the city of Buffalo and in Erie County. Urban Fruits and Veggies have an urban farm, a mobile produce market that serves food apartheid areas and underserved communities, bringing access to healthy fruits and vegetables and nutrition education. They sell at local farmers markets weekly from June to October and have corporate wellness division where they embed services into local companies. They also partner with organizations on wellness initiatives and offer programming for elementary and high school students where they teach nutrition education and urban farming. She's the chair of the Buffalo and Erie County Food Policy Council, on the board of the Erie County Farm Bureau, and holds memberships in the pilot community of Black Farmer Fund and Black Farms United States, New York State. Joining her is another friend of mine, Patty Green. Patty Green is the founder of Healthy Living with Patty Green. She is a successful entrepreneur, holistic lifestyle coach, speaker, and upcoming TV host. She earned her BS or Bachelor of Science degree from Northeastern University in Boston, Massachusetts, and her CHC AADP from Institute of Integrative Nutrition through SUNY Purchase, New York. Since then, her career and entrepreneurial adventures have centered around new product development, food, health, beauty, and wellness. Early on, Patty's entrepreneurial skills led her to create a line of children's consumer products. In addition to her product development, she opened a children's cooking school in Western New York and conducted hundreds of healthy cooking classes and workshops nationwide. She's hosted the noon cooking segment at her local NBC Channel 2. And upon completing her certificate of holistic health, she began her health coaching business, motivating, guiding, and inspiring individuals to lead healthier, happier lives. Recognizing the need to promote health, wellness, and lifestyle balance, Patty Green designed this multifaceted wellness broadcast program in the form of multicultural cooking show. The integrative learning experience emphasizes the importance of self-care and self-sufficiency and encourages an appreciation of other people and their cultures. So we're super happy to have them here. And what we're going to do is we're going to start out with a lovely video featuring both of them. So it's coming right up.
People are starting to understand that there's a direct correlation between what you eat and your health outcomes. We're committed to bringing the most nutrient-dense, chemical pesticide-free vegetables to the communities that we serve. Buffalo Go Green is an urban agriculture organization that focuses on wellness. We are growers, distributors, and educators, and we try to bring awareness about how food is medicine, specifically in underserved communities. Before we were here, that was just an open field with litter, lots of traffic, nothing there. So the neighborhood has been wonderful. I absolutely love it. It is the hardest I've ever worked in my career, and it's the most satisfying and most fulfilling work that I've ever done. Hi, Patty.
Welcome to my kitchen.
Thank you so much. I'm so excited to have brought you all these beautiful vegetables. So what are you going to make?
Today, I'm making you a soup.
Oh.
My favorite, which is Italian wedding soup.
I love Italian wedding soup.
Now, the thing is, and this is what I really want to stress to people, is that when you buy canned soup, just know that you need to look at the sodium level, okay? Even though it might say low sodium, there's still salt in there. And people that have issues, like diabetes and heart issues, you really have to watch. High blood pressure. Especially. Right. This has 1,500 milligrams of salt.
That's a lot.
It's a lot. And this can is good till 2023. Does that tell you something?
Yeah.
So what we like to do is start with a no salt or low sodium broth. This one has 75 milligrams.
What a difference.
What a difference. And then you cut it with some water. You use your sort of like your flavor bomb, like your onion, carrot, and celery, and garlic. Okay. So you use these to kind of flavor the broth even more so. So today we're making a kale Swiss chard Italian wedding soup.
And we know that kale and Swiss chard together, that's a total superfood. So you're overloaded in nutrients just right here, right, Patty?
Oh my God, absolutely. Yeah. And the nice thing about eating in season is that you know that you get the best nutrient-dense foods. So when you buy, let's say, a pepper, and it's December in Buffalo, that might be coming all the way from, let's say, California.
Absolutely.
They pick them prior to them being ripe. They ripen in transit.
In packed in ice.
Yes, if so.
And that ice depletes the nutrient value and content in every single vegetable.
Exactly. So what I tell people in this, like in Buffalo especially, in the winter, buy frozen. They have to freeze the ripe vegetable and or fruit within 24 hours. So that maintains the nutrients. I always say fresh is best, frozen is next.
And we know that the shorter the shelf life of an item is the healthier it is for you. And that requires planning, which we'll talk about a little later on.
You know, food is medicine, like we keep saying. And if you know what to eat and what nutrients you might be depleted in, you can supplement by eating in season.
Locally, we have 15 urban farmers and a plethora of rural farmers that do amazing growing. So it's here. The bounty is here for all of us to partake.
Let's eat.
Talk about a flavor bomb.
Isn't that amazing?
Absolutely delicious.
Fantastic. Okay, ladies, take it away. Oops, Allison, I think you're on mute.
Turn up your volume.
Here we go.
Okay. Oh, Allison, I still can't hear you.
Try raising your volume.
Patty, can I hear you?
Yes, I hope so.
Yeah, I can hear you. So let's just get Allison.
Okay.
Allison, you may want to come off and reboot.
Okay, so she's connecting.
Yeah, Patty, do you want to talk a little bit about?
How about now? Can you hear me?
Yeah.
Yes.
Okay. So sorry. What I was saying is that, Patty, I'm a little overwhelmed, and I am so excited and pleasantly surprised and hopeful about your individual work, my individual work, and our collaborations. But mostly I'm excited for the community.
Allison is going in and out.
By all of the amazing doctors and individuals and community have spoken to us on, and it looks like we have a clear path to the future of how we can integrate healthy eating, medically tailored meals, nutrition education, education about where our food comes from, how it's grown, and what all that means for our health outcomes. So, you know, we heard a lot about how the community integrates with physicians and clinics and healthcare providers. And in our fruits and vegetables program that is now ending its 4th year and will begin its 5th year in 2022, we have so much to look forward to. So Patty, what are your thoughts?
Well, I think this has been an amazing symposium, and I've heard a lot of amazing viewpoints from the medical professionals in our area and beyond. And what I can say is that there is a need, but I will say that people want to live healthy. People want to eat healthier. It's access, it's the knowledge of how to prepare. And I started doing virtual cooking programs in light of COVID of last year. I am on the board of the Police Athletic League, and they called all the board members and said, listen, we are scrambling. We've got 5,000 kids and we need virtual programming. And in my previous life, I did have a cooking school for kids, and I repurposed all of the educational materials and took on 85 kids and did a 6-week virtual cooking program. And Allison, based on me doing that one program for the 85 kids over 6 or 8 weeks, I could see the window of these families, the family engagement, the lack of really knowledge of how to prepare. A lot of kitchens weren't equipped with the equipment that was needed, but everyone was just dying to know how to prepare, a kale or carrots and things of that nature. And so my work has continued. We're in 3 different cities and 9 different Buffalo Public Schools. And I'm excited to know that the medical professionals want to partner with people like you and I to expand and educate families, children, and adults to understand that food is medicine.
Yeah, exactly. And, same with being in the community for all these years and in all of the programming that we do, I hear so many things about, I don't know how to cook, or I don't have a stove. So, and they all play on how a person feels and their availability.
Yeah, there's been a lot of issues with the lack thereof as far as kitchen equipment and basically a measuring cup, measuring spoon. I remember one class we were making quiche, and the family didn't have a baking pan. So I said, well, do you have any sort of baking vessel? And we made it work. But, the key is sort of adapting to what people don't have and what they do have. But the nice thing about it is to see these families that really, really, really want to learn. Sadly, many of them don't have the access to fresh fruits and vegetables and rely on these local bodegas for prepared foods that are so high in salt and things of that nature.
Right. And so we heard earlier from one of the physicians who talked about when patients had a conversation with their physician about nutrition and the impacts of their diet on their health outcomes, 78% of them change their eating habits. So what we have to do is let the community know, which I'm so excited for our community, that programs like yours, mine, and ours, we're your advocate. We are your support system. So if you're having issues, you can, and over the years, the relationship that I've built within the community, folks really talk to me now about some of these issues, and they can come to us and we can be your support, your sounding board, and help you with those conversations around what should I be asking my doctor for? I have a lot of patients, and we heard this in one of the earlier panels, a lot of participants in our programming who say, oh, my doctor told me not to eat any fruit. And while I'm not a physician, I do have a certification in food as medicine. And that is a conversation that we can start. We can start there with our physicians. So when you tell a patient, don't eat any fruit that is natural from the ground, packed with nutrients, what signal does that send? And how does the patient interpret that message? Because they're stepping out of your office as a physician, and they're looking at the beautiful bounty of fruit that surrounds us and that is so good for us. And they're saying, I can't eat any of that. So that is one place where I'm feeling like we can start to open up that dialogue between nutritionists, dietitians, physicians, and community organizations like yours and mine, Patty, where we are face-to-face with the individuals who are struggling with diet-related diseases, with the obesity, hypertension, and cardiovascular.
I mentioned that, you know, a lot of families, especially living in the inner city and beyond, they go into the doctor's office and they get this thing called white coat syndrome. So they're just like, it's going in one ear and out the other because they're just freaked out that they're in the doctor's office. And I did have one woman call me who has been taking classes from me for quite a bit. And I didn't realize her daughter was quite ill, but her daughter's 10 years old and weighs 250 pounds. And they wanted to give her bypass surgery. And I had to immediately say, I know a pediatrician and together we can probably help. We're going to get, you know, your urban fruits and veggies prescription program on her list of, you know, places to go to get her fresh fruits and vegetables because they relied on the free food from the schools. And I asked her to take a picture of what she's getting free from the school. And it was 4 large containers of plain yogurt, 1 huge bag of chicken tenders to fry, and 4 onions. And that was her weekly drop off. So what is one to do with that if they don't have any money for the food as medicine? So there's disparity, there is help, you know, how can we bridge the gap?
Right. And also, I think I shared with you, in addition to which so many families depend on the school breakfast and lunch, but a lot of schools are serving pancakes in a bag, waffles in a bag. And when I talk to folks about this, they say to me, never heard of such a thing. And when I show them the picture of the pancakes in a bag, people are blown away. So this is what we're up against. So, you know, that's why I'm so hopeful and I'm so excited about the symposium and bringing food as medicine to our, because we are going to create a platform with solutions that a lot of times are really, and the willing and passion to make these changes happen.
Well, I'll tell you, with my program, it's been wonderful. We've had a healthcare company, Buffalo Bills Foundation. We now do programs we've done them with over 500 families over the past year, where every family gets all of the ingredients, fresh produce, grocery items in a box delivered to their school or their home. So the families cook along with me with fresh fruits, vegetables, whatever it is, the recipe that we're focusing on. And we've been doing 4 to 6 week programs, which has just been amazing. But what breaks my heart is when some child is saying, Miss Patty, what is this? And it's a peach, or a mother who said, I've never seen lettuce like this. They don't have this in my area downtown. You know, your heart is broken. So how do we bridge the gap between food as medicine and the doctor? It's kind of, we really have to work sort of synergistically, I should say. And, you know, I'd love to ask some of these doctors that are out watching this symposium, you know, what do they think about the services that we provide and how can they bridge the gap with us?
Right. And so speaking of the Buffalo Bills, which they have just been so amazing, you know, one of the things that I realized over time was that, you know, when folks see me all the time and they come to me for advice and things like that, you know, I'm an okay messenger, but I thought, what if we had the Buffalo Bills help us get out this message about healthy eating and nutrition? And so we partnered with the Buffalo Bills, and over the winter, we asked legacy and current players, like, what's your favorite fruit? What's your favorite vegetable? And they told us that. They told us what they do to stay in shape and their nutrition regimens. And we paired that with great healthy meals. And you know, we had a great grand opening where we had a legacy player come. Patty was there, BNMC was there, you supported. And every week, our customers and participants in our program get a beautiful Buffalo Bill trader card with all of that information on it. And it makes a difference. And our customers now, they look for it every week. They're like, where's the Bill's card? What's the recipe of the week? What are they saying is their favorite fruit or vegetable? So it takes all of us to come together. And just like when you and I met and we thought, how can we merge the work that we're doing? And we came up with Farm to Fork. We have the support of, like you were saying, Melina Cares, and I have the support of the Community Health Centers of Buffalo, and we have the support of Highmark. We need all of that support to combat the challenges that we're facing. So I see in the chat that we have a message saying, let us cook with you. So that is very exciting. We want to bring on as many folks who want to cook, and we want to know what your recipes are. And if there's a recipe that you love, but you feel may not be too healthy, we can easily figure out a way to make that recipe healthy. We've done it in the past, and those are the things we want to do. We don't want to food shame folks, and we do not want to break folks' cultural traditions. So there are certain fruits and vegetables and plants, for example, callaloo. That is a Trinidadian and Jamaican staple. So how do we take callaloo and make sure that we're preparing it in a healthy way? Because I feel like, and I know that, and what we've heard all morning long is that food brings us together. And we want to make sure that we encourage that. So we want your ideas, we want your recipes, we want your cultural ties to food so that we can figure out, if it's not already being done, how to enhance these recipes and how to grow what you need. We can grow anything you want, and we grow it without chemical pesticides. We don't use GMO seeds. Nothing that we do touches the ground in the city of Buffalo, because we know that this is a historically industrial city. So we bring in our soil from outside of the city. We get our fertilizer from Eden, from an organic dairy farm, and we order our seeds from outside of even New York State. So these are all the things that we do on the growing end to make sure that what winds up on your plate is healthy and nutritious. So Patty, maybe we should stop talking and let folks chime in.
Well, I'd like to also sort of touch upon the fact that, you know, with the traditional dishes that you're speaking of, that maybe, let's say the classic macaroni and cheese and greens and sort of ethnic meals, we try to create recipes that are healthier swaps. And so we never want to discourage anybody from eating things that they've been eating in the past, but maybe as opposed to a typical macaroni and cheese, we're going to call it a cauliflower mac and cheese and have not as many noodles, not as much cheese, or not as much milk, but we'll supplement and make it a little bit a healthier dish. So I've been doing a lot of eat this, not that, but I've also done a lot of healthy swaps just to make things taste the same, but a little bit on a healthier swing. So we want everyone to eat in season, but we also want to make sure that people don't lose sight of dishes that they've grown up on. We want to make sure that we can maybe make them a little bit healthier. Any questions? Does anyone want to work with us?
Yeah, so I just put into the chat, I wanted to hear from the doctors out there. Do you know of these programs like Allison's and Patty's? Like, I just feel this bridge is just so important. And also at this time, I think that if you would like to talk, you can put your hand up or you can just unmute yourself. This is the time to have a little interaction if you'd like to talk with Allison and Patty about their program or just in general about getting to people. I see Saria Lofton, if you want to unmute yourself.
Sure, thank you. I really enjoyed learning about the program, but one thing caught my ear, and it was this term food shaming. I hadn't heard that before. Wait, what? I'm on the phone. Hold on. And I wanted to I wanted to understand that a bit more, because I value everyone's food, and I think like she just said, ways to make it healthier, but food shaming was a term I just wasn't familiar with, and I wanted to just get an understanding of it.
Sure. So food shaming is when someone says, I eat fried chicken 2 or 3 times a week. So, the response shouldn't be, you should not be eating fried chicken. The response should be, fried chicken. I mean, I've yet to a dish of honesty. And then we just say, you know what? The oil we use to fry our chicken can sometimes make it an unhealthy dish. You might want to consider baking. So if you're frying 3 times, try to bake 1 out of those 3 times. And then maybe have it in a salad. You can grill some chicken breast and cut it up and put it in a salad. So there are ways to make a person say, oh, you know what? I never thought about that. That's a good idea. And what that does is it starts to cleanse the palate. It starts to take away that desire for that fried taste, that satisfaction that you get from oils and sugar and fat and salt.
That answers the question.
There's a great book called Sugar, Salt and Fat on Sugar. And so it talks about those things. So that's kind of what we mean when we say food.
Oops, Allison. Allison, I would suggest, could you call in as well? Because sometimes you're coming in and out and you've got so many great things to say.
I will try to call.
Okay, cool. And so in the chat here, I have here from Dr. Chatterjee, in my experience, food shaming also has a cultural racist overtone. White healthcare providers communicating verbally and non-verbally that food from different cultures, example, Southern comfort food, ethnic food, is inherently unhealthy. Patty, do you want to speak to that? That's kind of, I know that I used to, the way I met Patty was through a restaurant that I owned that was Cajun Creole. And, that had like a lot of soul food. And what I always thought about it was that when I was talking to people from Southern comfort food or whatever, was you guys love flavor. You can, as long as it's flavorful. But Patty, can you speak to this overtones of the white community, the white versus this?
Yeah, I mean, I never want to say that it's a white thing. I would say it's maybe it's sort of an insensitivity. Clearly, we know that broiled chicken, it might be better than fried chicken. People know that. But I feel that sometimes when a doctor or an RD or a professional presents their viewpoint, they really only have a certain amount of time. And I don't think it's meant to be hurtful, but it's a difficult, it's a difficult thing for me to answer. I would just say that people need to be more sensitive to others. And that's basically what I feel. How you present yourself.
Okay, great. I see the cat is up, and Allison, I think we have you now on a call, which is better because we can hear everything, I think, for you. So Kat, you had a question?
Oh, I wanted to say that I'm Polish. And does anybody know what pierogi is? It's
yes.
a little breaded dish with potatoes in it, fried in oil and butter.
Yeah.
It's the most unhealthy thing. It's the most unhealthy food. I'm Polish, and I'll put out there, it's terribly unhealthy food. There's no vegetables in it. It's, I think in all cultures, there are dishes that are just very rich and have a lot of bad things in them. And like I said, I'm
right.
Polish. And
yeah, I wouldn't use the terminology that it's bad. I would say that I would say that a lot of ethnic food is it can be unhealthy, but there are certainly ways of enjoying that food. I mean, honestly, I think everything is great in moderation. I also think, hey, there might be another way of preparing a pierogi. And I love pierogis. Who doesn't love pierogis? Maybe not making them as big, maybe making them into smaller bite-sized pieces as opposed to like the big ravioli size. I think there's a lot of ways of doing and creating recipes. And I've been doing that for the last probably 10 years. But I do a great baked fried chicken, and it's you wouldn't even know it's not fried, but it's baked in a skillet. But I think that there's so many different ways, and it's really about educating yourself. Going onto the website, or not the website, the World Wide Web, working with me and Allison, and we're totally here to help educate. We'd love to do some virtual cooking classes with everybody. But there are ways of enjoying ethnic foods.
Yeah,
right.
And
I wouldn't even say it's unhealthy. I think
I wanted to mention something else. No, I think where I was going with that, I know how to cook healthy, and of course, I don't eat that traditional pierogi. But where I was going with that was the sensitivity. If somebody said to me that is unhealthy, that is just a fact. It is unhealthy. But I know how to modify it, and I don't eat that. Anyways, I don't eat pierogi, and I'm Polish. So I was going towards the sensitivity. I would not have my feelings hurt if somebody said pierogi was unhealthy. I would acknowledge, yeah, you're right. It's unhealthy. That's all.
Right. And that goes for like collard greens as well. Like collard, we take a perfectly beautiful plant and we pair it with like a ham hock and load it with salt. And so, there's a way to make collard greens taste just as good without that. So that's just another example. And you're right, a dish of honesty when we know that things are not the best for us, but with sensitivity and with a good solution or alternative. So I see there are several hands up.
Just wanted to respond quickly because I think the unhealthy, a lot of Americans eat fried chicken. I think when we're connecting race to it, that we're disconnecting the unhealthiness from it, and it gets sensitive. But a lot of American Southerns aren't just Black, they're white too. And I just wanted to just make that point, and I'm done. I think, we don't need to convolute it with race to still emphasize healthy food.
I agree. Sorry. Rita, I see your hand is up. You want to
Hi, these are my friends. Hey guys, good to see you. Thank you for such a wonderful presentation. But I think the issue around culture is really an important issue that we may not all be entering into the conversation at the same place. I think access is certainly an important element, so that if people don't have access to healthy food and they're eating unhealthily, then saying something that shames them because of what they eat, which are foods that are available to them in their communities, because of course we recognize that food apartheid exists, that there are systems in place that really make it very difficult for people to engage in a well-educated plan to eat in a healthy way. I think the other part of this too is that everyone hasn't entered into their eating habits at the same place. So African Americans were slaves, and much of the food that we eat, that we call soul food, has a historical background of being really slop, food that was left over from the slave master. And therefore we created this very lovely palette of food with seasonings and all of this to make what we could get tasty. And this is 400 years of survival that we also have to reckon with. And so I think it's important so that, when we talk about shaming and culture and, that this has been my experiences versus someone else's experience, We have to bear in mind that there are historical contexts and constructs and systems that also drive the condition in which people actually live, and their history, their traditions, and their actual palate, their actual taste buds. So just kind of circling the square here, I ran a farmer's market, and at this farmer's market, I learned so much on the black tarp, on the black asphalt, waiting for people to come to the farmer's market. Just because you build it, they may not come because there's a palate involved, and that people's palates have been hijacked. Food has been created to make it addictive. If you open up a bag of chips and you eat the whole bag, it's because there's something in that food that is not natural, and it's been meant for you to eat that bag and buy another. So our whole food system has been broken. I don't want to give up all what we're going to talk about in our workshop, but suffice it to say it's relevant here, because we can't say just because I wouldn't be shamed, and I have bad foods in my historical space, my grandparents make it, what have you. It's not always the same for every cultural group, because we all have not entered into this United States at the same place, experiencing the same things in the same way. So just understanding the space in which food is, it is in our world, we have to do it like a couple times a day. So to just to survive, many people are just surviving. Many people are not thriving because of their own experiences. Thank you so much.
Thanks, Rita.
Totally agree, Rita. Thank you for that. I think
we have 5 more minutes. So if anyone else has any questions about, this wonderful program, or just being an urban farmer or cooking alongside, everybody, which Patty's got like kids and families. She's touching a lot of folks with her work.
Well, I will say the partnership between Allison and I has been magical. We came up with this concept called the Farm to Fork Urban Celebration, and she and I partnered with it. So Molina Healthcare is funding it, and essentially all families are receiving a 4-week program. So it's a cooking program, but in addition, Allison is going to be supplying growing boxes with seeds, soil, fertilizers, and she's going to be teaching the families how to grow, let's say, carrots or lettuces over the season. And so together we are trying to really inspire families to grow maybe their own herbs, their own carrots, their own tomatoes, no matter where they live, because they can do that at the comforts of their own home, but also how to cook with those. So it's a partnership. I mean, I've had cooking classes in the village of Williamsville where I said to kids, where does bread come from? And they say a bag. So we're trying to educate families to say, carrots grow in the ground, and this is how you cook the carrots. So make the transition from farm to fork. And that's kind of the magic of our partnership. And we'd love to share more with any of you. Obviously, please get in touch with one of us if you're interested in us doing a sort of a virtual cooking program, just to test the waters and see what we do.
Right. And then in the last 5 minutes, in addition to that, and we're doing our fresh take meals. And again, having Patty there to consult on these meals, which we're in the first stages of it. And we're so excited to take our fresh take meals that are healthy, but bring in the medically tailored meals and really work at that, like we heard about earlier today. And these meals we're starting in corner stores, and we're starting in inner city churches, but we've had requests from folks in our first and second ring suburban areas, because guess what? They're busy. They've got both parents working. They've got 3 children in activities, and cooking and planning is just not a part of the day. So I'll go back to what I said before when we started. I'm super overwhelmed. I'm super excited, and I'm so hopeful for the future of all of this work that we have, which is a lot of work. But I feel like together as a community and, you know, with the support of the NMC and the other health providers and all of the community-based organizations and all of the urban farms, that we really have something powerful going on here in Buffalo. And I feel like we're going to be able to make great change for our community. So I'm super excited and looking forward to the rest of the day, Marla and Beth.
Thank you, Marla.
Thank you, Patty. Thank you, Allison. This was wonderful. And I'm so glad of how many people got exposed to what you guys are doing. And we're going to be having a resource list that's going to be coming out after the symposium for everyone. And of course, on that resource list will be Patty and Allison's information and websites and a lot more about what they do. They're both very busy women, and I love that. So now actually it's going to be a great transition from, you know, what we were speaking of when Rita so eloquently put out that, you know, that the way that you said it, this is why I'm going to hand it off to these experts. So we have Mary Dale DeBoer, who is going to be, oh, I'm sorry. Actually, we're going to take a 5-minute break. And after that, we are going to start up, and it's going to be a great fireside chat between Rita Hubbard-Robinson, Dr. Robert Rock, Dr. Avik Chatterjee, and Mary Dale DeBoer. So we will be back at 1:20. Thanks very much, everyone.
Now we have to consider how to make our discussion
Avik, could you please put on your video so I can spotlight you? Dr. Chatterjee, could you put your video on, please?
Sorry, I was just getting some coffee during the break, but here I am.
No problem. Thank you. Okay, everyone. I hope you enjoyed a little bit of a walk around. I love how many people are sticking with us throughout the day because this is amazing. Me and Beth are just so pleased. So I am very, very happy to introduce, wow, a powerhouse of a woman. Mary Dale DeBoer has helped us so much. I can't even tell you, from the beginning, she came in and we immediately started a partnership, and she has just been this, I don't know, I can't even express my gratitude and my pleasure knowing Mary Dale DeBoer. Mary Dale is the managing director of Fresh Advantage and a lecturer at the Yale School of Medicine. She founded Fresh Advantage in 2011 after 25 years of combined professional experience as a lawyer focused on healthcare philanthropy, and then as a senior executive at a community hospital. Her company works with a wide range of organizations, including hospitals, schools, businesses, and nonprofit entities, to improve their food service operations and integrate attention to diet and food security into patient care for hospital clients and student and faculty well-being and education in the case of schools, as well as the employees of all client organizations, which is so important. She created Food is Primary Care for the company tagline to emphasize the profound impact that a diet of fresh, nutritious, and affordable food produced by sustainable methods plays in creating and maintaining health, preventing and or managing chronic diseases, and providing the energy essential for an active, productive life. Mary Dale is a lecturer in the School of Medicine at Yale University, where she teaches students and trainees across several health professional graduate schools about the critical nexus of diet and health. Her company's team includes physicians, nutritionists, chefs, and farmers who join together to provide food learning programs and systems to improve food service and dining operations of a given institution and organization. Welcome, Mary Dale, and I'll have you introduce the rest of these panelists.
Thank you, Marla. My pleasure to be a part of this. First, I want to briefly introduce our panelists, whose full bios are in the materials already distributed. They have deep and complementary expertise and experience in medicine, law, public health, and social policy directed to promoting social justice, health equity, and eliminating what are referred to as social determinants of health, including food security. Rita Hubbard Robinson is well known for her leadership at the Buffalo Center for Health Equity and Community Health Equity Research. She works across a wide spectrum of initiatives tackling food insecurity, including a food production social enterprise, farmers markets, a food pantry, and community gardens. Her work in the healthcare sector includes hospital engagement with communities and Medicaid and Medicare reform. She and our two physician panelists share a commitment to improving medical school education and professional training through teaching and curriculum development that emphasizes greater interdisciplinary approaches, disease prevention, and structural competency. In other words, sorry, keeping track of the time. Disease prevention and structural competency, and you might want to say a few words about that Dr. Rockglader. In other words, the profound impacts that the context of patient lives and upstream factors, such as food security, have especially on people of color and low income who face a multitude of barriers to a healthy and productive life. In his teaching and research at Boston University and Harvard Medical Schools, Dr. Avik Chatterjee brings deep insights into the lives of homeless individuals and families gained from his work as a physician with Boston Healthcare for the Homeless, including the art of listening and an understanding of how good intentions must be accompanied by critical analysis and practicality in the design of food insecurity interventions. Throughout his medical school and clinical training as a family medicine physician, Dr. Robert Rock has distinguished himself as a change leader. While a medical student at Yale School of Medicine, he and another student created the now nationally recognized U.S. Health Justice Curriculum, which includes the course entitled Making the Invisible Visible, that all first-year med students take. Our discussion will focus on food as preventive medicine throughout the life cycle as a means to health equity. To give the panelists the maximum amount of time to share their comments and stories, we crafted 3 critical questions to which they will respond based upon recommendations sent to us by the conference organizers and to complement information presented by others today. Our first question is, why is context key in pursuit of health and food equity? Or as I have heard Dr. Rock state, why is this person, or for that matter, this community in the situation they or it are in? So let's start with Rita, followed by Avik, and then Robert.
Thank you so much. Really good to be here with everyone today. I just want to make sure you can hear me. Yes? Yeah, thank you. So the thing that occurs to me in this space and asking the question about context is that zip code should not determine your health status. It should not determine how long you will live. It should not determine your ability to access healthful food. It should not determine whether you can take a walk in your neighborhood. However, unfortunately, it does. So context is really, really critical when you're speaking to a patient or interacting with a person that might be a customer of yours in the space of healthful living. And that, you know, and then even terms that we might use, like, well, you know, you're hypertensive or you're pre-hypertensive. And what does that mean? How does the body work when or not work properly? And what does that mean? And if you say things in a doctor's office in that, you know, sacred 20 minutes that, oh, you need to reduce sodium in your diet, and people are not really familiar with as to exactly what that means, sodium. And then if you break it down and say, oh, you need to reduce salt in your diet. So, oh, they think, oh, I won't add salt, but they don't really think about that. Oh, there is a panel on the side of a box that gives you the actual salt content. And even then you don't understand exactly what is the amount that you should eat or you shouldn't eat. And so there's all these hidden pieces to nutrition that are not necessarily learned anywhere. You either have to learn it on your own or someone teaches it to you. If there's a nutritionist associated with your practice, then that gives an opportunity for a person to perhaps learn in a one-on-one situation. But then there is the issue of access. And so we have this food apartheid going on. And I want to, you know, often we talk about it as food deserts, and deserts imply that it's something that kind of creeped up naturally, but these are systems that have been intentionally created where people have no or low access to healthful foods and knowledge around food. So when you look at your television and you see these foods that are supposed to, you know, be quick and in a hurry and be, you know, perhaps tasty, and you see the little child with her eyes all in the air because she's enjoying this lovely fake macaroni and cheese, and you're thinking, oh my goodness, I'm going to buy that because my kid will eat it. Well, you're setting your child up, you know, for a very unhealthful lifestyle. And but they're going to eat this these foods that have a couple of molecules close to that of plastic. So context is really, really important. Understanding where your patient panel is from, looking at the population health of that patient panel, you know, their neighbors, there's the people in their neighborhood and in the building that they perhaps are living in, and perhaps they're in public housing. If you look at the data, it will show you that this is not a situation that is an individual situation, it's a community situation, and that you're going to have to dig a little bit deeper if you're really interested in improving the health and the condition of that individual.
Avik?
Thank you, Mary Dale, for the introduction, and Rita, thank you so much for your wise words. I'm going to give two stories based on projects I've participated in that that get at this point of context. So when I came to Boston, I started working at Boston Healthcare for the Homeless program, and I'm trained in adult medicine and pediatrics. So I asked to spend some time on the family team. Massachusetts has a large proportion of folks who are experiencing homelessness as part of a family. Typically, it's a young mom with kids under 6 actually is a more common situation. And what was really, well, there are a couple alarming things, but the first clinic I was in was in a motel shelter where we would go door to door with a little suitcase and give out, you know, whatever folks needed, do more than anything else, a lot of case management, but also medical visits with the laptop and things like that. Unlike in my work in the adult shelter, where I spent the other half of my clinical time, where 3 meals a day were provided, and then snacks at night. In the motel shelters for families, there was zero provision of food. The family shelters were run by a completely different system. And every day in the family shelters, I would hear families complain about food insecurity, and not only food insecurity, but when they could get access to food, it would be unhealthful food. And families and adults who had managed their high blood pressure, their diabetes, and all that before weren't able to in the family shelter, motel shelter setting. A lot of these motels, they weren't meant to be shelters. There are no kitchens. There's no way for families to prepare foods. But to get at the point of context, there are 2 things that came up as far as context. The families were in these motel shelters where there were no, at most they had a little like a micro fridge and a little microwave thing. But there were very well-meaning folks in the community that were doing a food pantry, and they'd come around every week and they'd bring bags of raw groceries. So I remember one day seeing a family with a bag of raw onions and raw carrots going into the room with a microwave, right? And I was like, this food pantry is great. I'm glad they're doing it. There are useful things that they bring, but there's like a lack of understanding of context, right, to this intervention. The other thing that you would see was just these nutrition education classes, like the idea that, oh, these families needed to be taught what was healthy and not, and if only we could teach them and they would know more, they would eat healthier, totally ignoring, right, the structures and systems and the physical place where these families were. So we designed, and Mary Dale knows about this, but we designed an intervention. We were like, okay, we have to skip the cooking part. We can provide, we need to, so we partnered with local universities and got food donated from their prepared food lines, where we made sure that there was a healthy protein serving of vegetables, and then a carbohydrate source. And we packaged those in partnership with a local nonprofit that does food service work, and froze them for families to have. And we deliver them 3 times a week to the shelter, so families could have a day or 2 of meals that they'd store in their mini fridge, microwave, and they'd have healthful foods. We were able to show in our study of that intervention that families on average that participated compared to families that didn't eat an extra serving of vegetables a day, and saved on the order of $20 a week on food, which was really, really nice. The context did come up there though as well, which was really something that I should have known, but now I know better, which is that one of the things that you might intuit after all this conversation that we've had about culture, but the students that are eating in college cafeterias and families in motel shelters in Boston are much different culturally. So we would often have these struggles where one week BU had like a, peanut shrimp salad or something like very not, that that people didn't like. People didn't like because they wanted something different, right? That for culturally for them, this like, you know, Asian shrimp salad with, you know, whatever noodles that they had made that the BU students found like something they would eat, that was not what the families wanted. And so we were dealing with this food supply versus like cultural difference where families were like, no, we much prefer, you know, these different types of food. So that's an example where we needed to work on improving that in order to reach the families better. But context is important there too. I don't know how much time I have, Mayor Dale, but
No, you're good. 3.5 minutes, go.
Great. The other place where context came up for me was Mary Dale and I worked together on a school food program evaluation. And one of the title of the paper, we did a qualitative assessment of the, but we looked at a school food program in a school in Dorchester in a neighborhood that was heavily Caribbean. So a lot of folks from Jamaica, Trinidad, and from Central and Latin America as well. And the title of the paper ended up being, can't we just have some sazon? Like the family, they just wanted flavorful food because the healthy food that was being served was, you know, steamed, boiled, low sodium, but from like a very, I don't know, like 1950s, like home ec, you know, healthy food sort of perspective. And there was no sense of, and so one of the interventions that came out of this qualitative study was literally just having these big containers of like chili flakes, red pepper flakes, right? That in and of itself was helpful to bring the food along closer to what people wanted. The other thing that we found that I thought was important with the paper and the intervention and the evaluation was that a lot of the students, because the sodium content of the food was so low, they were actually eating super high sodium foods, even more so after school and outside of the school day. So I actually suggested increasing the sodium content a little bit during the school day. So the food wasn't so unflavorful that kids were just like not eating it at all, right? So to the sazon piece, right? That give them some seasoned salt and that will be much better because they'll eat the vegetables than if you take everything from them, all the flavor from the food in a culturally insensitive way ultimately, and then they don't eat the healthy food that you made for them. So anyway, context is important. Knowing and listening to your audience is really important in terms of interventions.
These specifics are so great, Avik, as a doc who I've known for a long time and really takes a deep dive into how to really help people feel better. It's great. So Robert Rock, you're up.
Thank you so much for having me. Pardon the fire alarm. In terms of what everyone said, I'm just reflecting on my training and the gaps that existed as it relates to understanding, conceptualizing context. I think what Rita and Avik described is, or for the most part, glaringly missing in a meaningful way within health professional education. And you alluded to structural competency, and I really want to like give the audience a definition for that, because I think it's a key bridge between the historical expectation of what like biomedical education is and how we can use it, how we can bridge that with the real world issues that patients, populations, and oppressed communities are otherwise dealing with, like giving people the language to understand and conceptualize that. So structural competency was created by Helena Hansen and Jonathan Metzl, and it basically is a challenge for healthcare providers to really understand the social, historical, and political structures or determinants that influence the options that an individual can make when they're confronted with a health decision, in terms of the resources that are available to them, the time they have to make the decision, the time they have to, all of those other things. And unfortunately, we live and work with a medical system that really isn't a system. I think our payer model has reduced medical care to a sick marketplace, a sick care marketplace. And for that reason, there is no priority given to prevention because there is no money, no reimbursement in prevention. And unfortunately, we're being trained in that way. And there is a line of generation after generation of health professional trainee who's going to be like disadvantaged when put in situations that Avik was put in terms of stepping back, thinking structurally, being humble, listening to people in terms of what their real world experiences are and why it leads them to make the decisions and prioritize the things that they do. And I really think that that is a fundamental flaw that is informing how we're taught to work with each other, how we're taught to conceptualize what are the drivers of the poor diets, the obesity epidemics, the food apartheid states that we exist in.
You have some more time, Robert. Would you like to add a few other comments?
Yeah, so I guess I can give some examples. So in relation to the concept of the food apartheid, Rita was very explicit in saying that these food systems did not just happen to be this way and develop over time. They were intentionally designed by people in positions of power, political authority that, you know, we are very familiar with redlining in like the 1930s when small groups of people decided which communities were worthy of investment in terms of resources, infrastructure, and which were not. And how that became a self-fulfilling prophecy in that the same communities that were marked as redlined in the 1930s are still the same ones that we're constantly fighting for grants for, sending in various philanthropic efforts to try to correct what we think is something that just happened. And if we don't think about how policy inform that and aren't intentional about that, and how the decisions that created this reality were not race neutral and race blind, we won't get to an actual solution. And so I think something that I've been thinking about a lot, you know, somebody who went to NYU for undergrad and went to Yale for medical school, is how my privilege is connected to someone else's oppression, particularly in how a lot of the large medical centers are non-for-profit, and how their non-for-profit status directly relates to resource deprivation in terms of what a municipality has in reserve to take care of those with the least. And I think that there is a lack of criticality among learners that I think is reinforced by the way that we're taught. And unfortunately, we figure out the gap when we're confronted with it in the real world. And unfortunately, do a lot of people a disservice when they have to teach us how to be better when they're still struggling to survive.
Thank you, Rob. Thank you, all of you. So now let's turn to our second question that we had crafted. And I know the two prior speakers dealt a lot with this question of culture and ethnicity in diet and, quote, nutrition education. I'm especially interested in the nutrition education piece, referring back to what Avik said, because in a lot of my experience, and as he expressed, this savior mentality that takes us in, that we're going to teach people how to eat, and we're going to do that being totally insensitive until what their reference points are, where they live, what's their situation. And so I'm looking for all of you to expand upon what the prior speaker said and add to it again by your grounded lived experience in working to deal with some of the adversity that results from structural racism and redlining, situations where the past is prologue, unfortunately, and that we really need to change. So on this one, Avik, I know you have thought a lot about what constitutes a health promoting diet and for whom. So can you kick off this discussion for us, followed by Rita and then Robert?
Yeah, thank you, Maridel. So I don't think I can do justice any better than Rita's words, because Rita, in the last discussion, I think you gave such a nuanced but powerful, summary of this point. But I will say two things. One, this is not isolated to the South, so I don't want to, sort of just point fingers in that direction. But I do remember growing up, I went to medical school at UNC, and like the point I made in the comments was really at UNC, which is a predominantly white as far as the physician sort of institution, in the middle of a set of states. I think we're slightly like further north in the Black Belt, but an area where there's a high rate of strokes, in particular in Black communities, in densely Black populated areas in the South. And there was this sense of condescension toward the soul food diet that was completely divorced from the history that Rita gave, right? That this diet didn't emerge from nowhere yesterday. So, and there was a sense of, oh, if only, that from above, right? The white doctor saying, if only these people didn't eat this way that they eat, then, they would be fine. And so that's sort of what I was getting at in terms of the way that in my experience, a lot of doctors in particular will look at people who are different than them, completely eliding the fact, and other, folks in the conference here have mentioned this, that every type of diet has healthy and unhealthy foods. In a lot of ways, when I go travel to different places, if you're eating the traditional American diet, and you go out to a restaurant, it's like burgers and fries and all this stuff, I actually will try to purposefully find the Jamaican restaurant that might be in town, because at a Jamaican place, I can get, curry chicken with lean meat. I can get rice, and then callaloo or some sort of greens, right? So I'm having a much more healthful diet. But I think the attitude from healthcare and from doctors often is, well, the sort of American diet is healthy, and ethnic people eat unhealthfully. And as in my experience too, as someone who comes from a South Asian background and Indian background, I think there's a lot of like, you'll often get this, and there's an article about this recently, but Indian food is so unhealthy. But what you don't realize is that the way my parents cook at home, the way my family cooks at home, is much, much different than what you get in an Indian restaurant. And so this idea that, Indian food is so unhealthy, if you only ate differently like this, that you'd be more healthy, is like really tough. So I strongly feel like the last speaker who was talking about ways to partner with communities, potentially adapt recipes or find the recipes, right, that reflect what we know now about what's more helpful, is the way to go. And I just feel like we don't do enough of that. So kudos to the folks who spoke before me about that work. But I think the healthy food is there. I think you just have to work harder to understand what communities are eating and how to plug into that.
Thank you. Rita?
Well, thank you. I'm glad that what I shared earlier was helpful in this space. A couple of things also, as I was trying to be brief, I can illuminate a little bit further. I think one of the things that really is important is community engagement or patient engagement, depending upon whether you're working with community or whether you're working in an individual setting. And just ask about the type of foods that a person might enjoy. And as I think Patty was sharing, that there are a number of ways that you can cut the fat, or cut the starch, or cut the sugar, or cut the salt with other seasonings, or a different type of sugar, or different a vegetable instead of so much starch, or just finding a different way to fix the food. So I think community engagement is really important, and even in setting a garden. We're doing a lot of gardening projects. My dear friend Allison has talked a little bit about how many gardens are in the city of Buffalo, and there are gardens popping up everywhere, community gardens. Let's talk to the community and ask the community what they want to see grown. And also include ornamentals You know, the insect population is attracted to flowers just like we are. And we need all of the flora, and including the food, to be in these garden spaces, and so that they are beautiful places where people can have meditative space, because I think that's another cultural and ethnic component where race matters, and that people are undergoing enormous stresses related to their ethnic backgrounds in workspaces and in life, and even at the grocery store, that you're experiencing all of this trauma, all this drama, all this stress, all the strife in your life, and that you need spaces in which to have peace. So peace and food together also important. And as our lovely chef Patty, she's just wonderful. She's wonderful with kids. She's wonderful with adults. She's been on my radio show. She's phenomenal in this space as well. And the whole idea of cooking classes, virtual or in person, with culturally competent people who are from your community, that will actually be able to say, hey, I know you like a hog maw, but let's go ahead and try this little smoked seasoning, and this a little bit of onion, a little garlic, a little fennel, let's put that in there and let's try it. Let's try it together. I've tried it, and it tastes really good to me. And I got to tell you, when my grandmother made it, I could rival her greens. I mean, so this is really, I think, really connecting the dots. And then I'll say this, and because I don't know how my time is going, but Mary Gail, I know you're queuing on the time.
Yeah, that's good. Please.
Yeah, so I think also in this space is, we supported a cooking show. It was virtual. Chef Alexa, some of you know who she is on this group, and she's wonderful. Her class was called Soul Food is Food for the Soul. So just really even deconstructing soul food, the words soul food, as being a thing, and breaking it up so that now it's a concept, that the soul food is food for the soul. So the foods that make you feel good, the foods that empower you, that give you energy. Someone put in the chat about energy, that make you think of home, that make you to bring family together, these are the kind of conversations that she was actually having during the cooking class. And she's a natural talent in this space, much like Patty is as well. And just the kindness that is portrayed even in the class, is the way that you interact with the public is just such an important aspect because cooking can also be therapeutic, and it's a cultural space, it's a therapeutic space, it's a space where you can create an atmosphere of peace. It's a space in which you can actually, be creative. So these are some of the pieces that I think are important when you think about culture and ethnicity. And then not to leave out that the culture of America is an important piece to this whole dynamic, and that we have a long history in this country. And I think that Dr. Robert Rock shared, that we have to come in grips with. We have to recognize, I think that our public education system has done a major disservice is to not just tell the truth. And so we've got this crazy stuff going on in our country, but it does relate to even our food and ethnic, the way that we eat our food, the way that we think about our food. And it's sort of has filtered into medical practice. And it's part of even the medical history. How has research been done in this country? I don't want to get into all that, but suffice it to say that many of the people that we're talking about have been harmed as a result of medical research and experimentation. So this the whole construct of America and the way that we interrelate with one another around food versus pharma, I think is another the culture of America, Our gross national product being driven by healthcare, I think is another really important concept that we need to grasp and grapple with when we think about the impact of culture and ethnicity on food and food systems. I'll stop there.
Thanks, Rita. Robert?
I completely agree with everything that Rita and Avik said. The thing that they made me reflect on in terms of the cultural humility required to be able to bridge those gaps, and the really like the love that's required to put down roots in a community and be a part of it and understand people's context and what they want and why, is something that I feel the system is actively working against. The healthcare system is predominantly transactional. And you describe, that's how I work in 20-minute increments, and you can't do this kind of meaningful relationship building in that amount of time. And I think that something else that we need to think about on top of it is like the training process for healthcare professionals in the United States requires often that people are uprooted repeatedly, like from college to med school to going into practice. And if you're in academia, shifting around, like you go from like city to city to state to coast to coast. And how can you possibly become connected and see someone as something other than a patient? How can you see them as a fully fledged human being who has things to teach you? I think that is a major barrier to the relationships and the outcomes that Rita and Avik described being more of the standard within our hopefully healthcare interactions. And it's something that I'm pushing against as I'm in training, to take more time, to actually be present, to not clock out both physically and mentally when my shift is done, to conceptualize myself as citizen rather than just clinician or doctor or researcher. I think that's when the interdisciplinary relationships happen. That's when the change happens. And unfortunately, that is not at all the priority. I think we're getting somewhere in terms of people recognizing the power of interdisciplinary training, the power of community engagement. I think there are some funding incentives that are pushing health systems in that direction. But unfortunately, I think it's still being gamed. And a lot of people are still operating under a business as usual mindset. And that's not going to get us out of the situation that we're in.
Thank you. I cannot.
Oh, sorry. I was going to just make one more.
Yeah, please, Avik. Yeah.
To Rita and Robert's point, one thing I want to add is that a lot of these systems and structures are obviously historical, but this idea of not teaching it, which I think was sort of passive for a while, it's become active again. When you hear about whole states saying we don't want to teach critical race theory, when you think about the federal government under the last administration putting forth an executive order saying we don't want to teach about racism because America isn't a racist country, what they're saying is we don't want to teach about these things. We don't want to teach about, among other things, racism in food history and food systems, right? That's historical and ongoing to this day. So anyway, just to say that we can't let up because it's an active thing that's still going on that this is trying to be suppressed for us to know about. So.
Yeah, I gotta jump on in here as well, because I think one of the other things, and this is something that we are dealing with in the whole gardening space and community gardens and getting gardens on the east side of Buffalo, which is your primarily African-American side of town. And that is that there are harms done at the land, at the level of the soil. And I love the name of the woman who wrote the book, it's all escaping me, but suffice it to say that this is where the harm happened at the soil. It's not the fault of the soil. So, you know, just helping people to connect back to understanding food systems, ways that food can be grown, and understand and reckon with the evils of the past to get to a better place in the future, I think is another piece of that cultural ethnic component that we might not really be aware of. Even the idea of cooking food, you know, the idea that we had to cook food for others, that our own bodies were not our own, they were not our bodies. And that now, you know, that's recent history, like our bodies were not our bodies and recently. And now you want us to take care of our bodies and you want us to mind what we eat and all this kind of thing. Like that is really another aspect of the sort of psychological impacts that have occurred to peoples, whole groups of peoples of color primarily, that is part of the idea that now we have to take back our lives, we have to take back our power and do the things that are going to be necessary to improve our overall health.
So I can't resist but provide one short little story of my own from my days at Yale with the Department of Psychiatry. I have a very dear colleague among the audience, and this story will resonate with him, but I was deeply involved in transforming food service in a public health, mental health center in New Haven that the Yale Department of Psychiatry runs. And we did a lot of different things. But one thing that was so profound to me now that I've stepped away from it is really understanding what this is, this white privilege. I mean, even my hair is white now. I'm like, oh no. And the imperative for people like me, and most situations that I work in, most people don't look like me, but to make yourself vulnerable, to understand that you have things to learn from the patient. And one prime example of that I learned was we were able to embed a nutritionist in this center where everybody is indigent. The food insecure, everybody is food insecure, and then some. And that's not their biggest problem. They're living with serious mental illness. And so to have this remarkably talented nutritionist there, she like me, except she doesn't have white hair too, came to me one day and there were tears in her eyes. And I said, what's going on? She said, I was working with so-and-so, and I was explaining what he could eat, small things that he could eat, like nuts for protein and other things that would be accessible. And he said, I can't eat that. And this is another question, not culture and ethnicity, but situational awareness. And he went like this. He said, I don't have any teeth. So it taught me a big lesson. And thank you, Robert, for pointing out that we learn from the patients as well. Our final question, and I think this could be very stimulating conversation. All of our panelists have considerable experience and credentials in developing systems and strong advocacy for institutional accountability and authentic and effective community engagement to promote health justice in the US, with food security being part of that paradigm. Robert, could you begin this discussion, perhaps first touching upon what faculty, trainees, and employees can do to promote structural competency and change within a hospital, a clinic, a healthcare organization? How do we incentivize and emphasize an emphasis on prevention and changing the culture of medicine? You're doing a lot of work on this now in your clinical scholars program too, I know. So take the lead, and then we'll turn to Rita and Avik.
Okay, so I think, you know, earlier in the discussion, we identified what, you know, trailblazers are doing in terms of swimming against a very strong current. I think we can't stress enough that health professionals in our country aren't trained to think at a population level, and neither are hospitals. I think COVID has definitely like shown that we don't have a public health infrastructure. And we really don't have like a social contract much anymore. And I think that what the trailblazers in medicine and in healthcare and in health equity are doing primarily is breaking down the barriers between silos and sensitizing people who are the staff and at these hospitals and medical centers to context. I talked about structural competency, and there are like 5 major tenets. One is, recognizing the structures that shape clinical interactions. Another is developing an extra clinical language of structure, which is basically like conceptualizing yourself as citizen and understanding all of the history that has brought us to this point in terms of your interaction with an individual person or a community, to step away from thinking about cultural competency and thinking about culture as like thinking culture in like a structural context, so that we can get away from ethnic essentialism, which is kind of like, there are a couple of bullet points of knowledge tidbits that I need to know about a particular group, and then all of a sudden, like, I'm good, I'm culturally competent, check the box, it's fine. And that just doesn't work, because we are so much more than any individual identity that we carry. And so I think that the work and the innovation is happening at the intersections, where we're creating that connectivity, behaving as citizens, not just as health workers, and really highlighting the intentional decisions that inform the resource deprivation in Black and Brown communities as they exist. I think right now, the thing that I'm most interested in is understanding not only individuals as citizens, but organizations as citizens within a society, particularly how hospitals and other, non-for-profit entities, universities, et cetera, that can often be considered anchor institutions, like whether or not they're holding their weight, doing their fair share in terms of benefiting the public good. And so I think that the amazing things that are happening is when clinicians and different people on the healthcare team and patients and communities are working together to collectively advocate for things like the expansion of SNAP, or highlighting the benefit that the expanded child tax credit has had in our society since it was instated during the pandemic, and why we shouldn't take it back. I think their collective efforts stand to push anchor institutions like hospitals and universities to invest in long-term sustainable resources that can immediately change the material realities of people who are forced to choose between bad and worse when it comes to what they put in their body. So I think that those are some of the starting points in terms of the major themes that I see happening across the country. And I think that that's where we need to go, to start thinking of ourselves as citizens and really start holding each other and institutions accountable to intentionally combat the history that got us here, that is actively happening right now.
Thank you. So one of the things that I think is really important that we might want to lift is that in this country, we have maybe 3% of its population in the medical field. 3% of the population are African American, Latino, Latinx, Hispanic, or Indian, Native American, and all of the other diversity comes from really other countries. So if you're looking for a kind of a culturally competent workforce that will relate to the African American, Latino, Latinx, Hispanic community, Native American community, we're going to have to come up with a different solution. So I see community health workers really being an important tool, an important element in healthcare provision, where you can have someone who has content, expertise, context expertise in the communities in which we know we've got to turn the corner on in terms of the health model. Otherwise, I mean, in Buffalo, we're looking at, on average, a 12-year loss of life, preventable loss of life. And so just being able to bridge that gap. I know a lot of the qualified health homes, the qualified health practices and other urban practices are integrating community health workers into their model. But this should be a model that both the physician and administrators adopt in a way that's meaningful, that there is high levels of communication and respect between a physician group, a physician and a community health worker. And we know that we want the physician to work at the highest level of his or her credential, and that's important. But there's got to be a relationship between the community health worker who knows and understands the context in which the patient is living, and that they are trained to understand disease states, particular disease states that are embedded in the community that they're serving, so that there is a real understanding about what's going on, so that the doctor can be really more successful in the practice of improving the health of the patient. And so, that we're not just, saying, okay, well, you're going to die. And so here's some things that you can do to stay here a little bit longer. I want to see us start at a much younger age. I saw in the chat earlier, someone said daycare. Yeah, let's start before you're sick because we can see using the data what's going to happen. As I said earlier, it's the zip code that will tell you exactly what's going to happen to the baby, to the infant. I mean, Avec is shaking his head. He works in these spaces with children. He already knows exactly what's going to happen health-wise to this child if there are not interventions around food and lifestyle and other things. So having a community health worker embedded, I think it is an important part of the model. Also, incentivizing through healthcare wellness incentives, I think ways in which people can get gift cards for food, ways in which they can get food that's already prepared brought to their home if they have a diabetic condition or pre-diabetic condition. I think that embedding that in the health care insurance model is the actual payer is incentivized by improving the health of the recipient of insurance, because that's going to decrease the overall cost of healthcare in the long run. And that we need advocates to help that happen, and that could come from the physician community, from the medical community. And then the last thing that I'll say around this space is that the food system is broken. I mentioned that earlier. It's very broken. It's so broken that you go to, and I've worked with this corner store project. One of my colleagues, and she's leading this work, the Healthy Corner Store Initiative, where we started with 2 stores in 2015, and now we've got 13 stores at the end of October, where we're taking what would be considered a bodega or a corner store, flipping the model to create spaces in which in that store where people can get healthy food. We're partnered even with the project called Double Up Food Bucks with I'm forgetting the name of the group, but
Wholesome
you guys.
Wave. Wholesome Wave.
No, it's
Fair Food.
Fair Food. Yes. Field and Fork. Thank you so much. Yes. Field and Fork. There's so many out there. Field and Fork has several stores that they are supported through the Double Up Food Buck project. And so it's a great little project because you can buy food that is SNAP eligible, and those dollars that you would buy for those foods translate into free fruits and vegetables that you can get as a result of that. So there are ways in which we can help with sort of the transactional things that happen every day, like eating. And then there are things that we need to do to transform the way in which the medical practice relates to the patient and the various access points that they have for nutrition. I'll stop there.
Avik?
Sure. To Robert's point, you know, when I was a resident in New Haven at Yale, I was very interested in this work, and I asked to be on the Food Policy Council, which is a New Haven-wide, group of stakeholders that are working to improve and doing actually really great stuff. New Haven's actually kind of a model place as far as some of the work, at least, but they didn't want me because I was a resident, which meant that I was a transient person, right, in New Haven, likely I'd only be there for a few years, which was difficult at the time because I thought, well, first of all, my program is 4 years, which is a pretty decent amount of time too. This could be a way to recruit and retain and have someone who's interested in food systems, who's a doctor, be here and continue this work on after residency, but they did not want to do that. So I think Marydale talks about this, but I don't think there's been a position on that Food Policy Council, at least for a long time. And so that makes it difficult, right? It's almost a separation for a bunch of structural reasons that we've been talking about between food and medicine and healthcare, which causes these sort of problems. But as far as how to make change, I'm going to paste. So there's an article that well, now he's a resident, I think, but a medical student at the time, Leo Eisenstein, wrote. It's called To Fight Burnout, Organize. But one of the challenges, I think, with any of these problems that are of this scope is that it's really overwhelming if you think about it on your own, and if you try to challenge it and overturn these things on your own. And I think the key is to find other like-minded people and work together to organize for change, because you can never do it alone. And systems will want you to try to take on things alone and try to break your spirit that way. So don't let them do that. Find your community in this work. One other thing I'll say is that, so the project that I worked on with Marydale was funded through community benefit. So Boston Children's Hospital at the time, there's this program called Community Benefit. I think many of you probably know about it, but basically these nonprofits that Robert talked about, or Boston Children's and the Harvard hospitals, at their nonprofits is like mind-blowing given the amount of money that they make for folks. But anyway, they're nonprofits, so they have to give a certain amount of money out to the community in this form of community benefit. One, they don't do that. They just do not obey the law. Like, first of all, they don't, and Marydale knows about this, they don't even meet the amounts they're supposed to give. But two, when they do it in these bizarre ways. Like, I'm very thankful to have gotten a research grant to look at school food programs, but that's not the way to give back to your community. If you're getting protected nonprofit status to not pay taxes, and the way you're offsetting that is by giving a researcher a few $1,000s to study a school food program, that's not right. You know what I'm saying? Like, so anyway, what it gets at is, obviously you want to take advantage, and I think Marydale and other folks do a really good job of this. You have to hold these places accountable. Like, if you have to give this community benefit out, this is the way you should do it. And I think really take advantage of the law and then just sort of social and moral pressure to make that better. But what it got me thinking about that Children's was giving out its community benefit money to me was that it really is a manifestation of this Audre Lorde quote, right? That the master's tools will never dismantle the master's house, right? That Children's Hospital isn't interested in better, community investment and doing the things it needs to make the community healthier. They're not interested in that, right? They make money in a certain way, in the way that Rita and Robert have talked about in terms of systems and financing of hospitals. So anyway, their goal is never to do that work in the right way. So getting back to Leo's piece about organizing, you have to take advantage of the systems that are there. So community benefit, take advantage of it, figure out how to get that money. But you also then have to be like, okay, you're not going to do the right thing. We have to find other ways to change systems and hold people accountable.
Thank you, Avik. And I hope you'll put the link to Leo's article. It's really a beautiful article. I mean, it synthesizes so much of what has been said here today. I'm wondering, Marla, if you have any chat question you want to pose to the group, or if it's time to close.
Yeah, actually, I was going to say that we have a few minutes for questions, and I did see that Dr. Vasquez has had his hand up politely for a while. So I'm going to let him unmic himself and ask.
Yeah, this is Dr. Vasquez. I'm the CEO of GBON. We do a lot of different things. I think we have to start, especially in the Black and Brown and Native communities, to I echo Rita's concept in terms of really getting people that look like the community to have more of an impact. I think the only way that you're going to change things within these communities are what my father-in-law always talked about is three things: jobs, jobs, and jobs. And I think that's a great way to really change the environment. We talk about the food and everything else, but it has to be a package. I think we have to get people to kind of work together. Providers coming out are, the way we train doctors today is the wrong way. I mean, I put videos together is, you're training them in sick care. You're training in the fee for service world. And that's all you see. And you glamorize specialties. So, it's if you're going to be a heart surgeon, if you're going to do this, this is the right place, hospital structures, not about primary care. Primary care is the last thing you think about, and behavioral, and which is what's plagued our communities for so long. Hospitals serve as non-for-profit engines that are draining economies out of those areas. So in the Black and Brown community, dollars are only going to be there for 6 hours. They're going to go into these health systems and then fade away. And so unfortunately, these communities are cash cows for sickness. We're not really focusing in on the foods and how to really address. So, one of the things that urban, my practice, we're silver status with the American Heart Association, gold standard with diabetics is because food, we look at food as an important thing, not just food, but how to give people the right types of food, teaching nutrition, teaching health literacy, teaching exercise, teaching prevention and wellness, because primary care is public health. That's what we do. But we're also trying to develop models that really reach out and touch a lot of individuals. So as an accountable care organization, an ACO, we're going to be taking full risk this year. And what that means is the cost drivers, which are social determinants of health, they matter to us. They matter to us because we're going to basically, the populations that we take risk on, and we're hoping at one point we can take all of 14215 to just demonstrate the impact of really touching people in a different way. So we're designing these homes. So the homes that are either, from green to orange and red, and season homes or senior homes, to really go out and really deliver care where we should have done it for a long time ago. In the 1930s, 40% of all care was done in the community with house calls. So we're going to design the model to really go there and really have the right teams. So not community health workers by themselves, but really blending them in with social work, because they need to have that skill set. And it's really important, having pharmacists, doctors, that depending on the scale of individuals, we really support systems out there, providing Wi-Fi, providing echoes and Alexa and things that we can really draw from these individuals so they're integrated into some sort of a healthcare system. The pandemic has taught us that COVID has not been the way to really manage population, because they didn't want to go to hospitals, and they still don't want to go to hospitals. So we have to go to them. We purchased 3 more mobile units to really go out and hit zip codes that really matter to really make the impact change. But it's going to have to take the dollars. And since you take full risk and now you become the insurer hybrid, those dollars can be really allocated. There's enough money in the system to really provide services. So food is just one component of what we do, but housing is a major component in this area. And while everybody's saying, yeah, we're doing housing, it's still somewhere that we really need to focus on. So I think for me, it's just modeling it in such a way that we really base everything on our outcomes, not just doing things. Everybody wants to do the right thing, but we're not measuring the right outcomes. Our hospital systems, we love them, but they don't really do a good job. If we look at the 14215, we have 2 hospital systems, Sisters and ECMC. And I've been here for at least 35 years. Those outcomes in those areas have never changed. And so how do we begin to really truly look at how capital is being used in those areas, but really getting back to primary care, behavioral, and other entities that can really help these communities get to the next level. But the biggest thing, as I said before, is jobs, jobs, jobs. That's all.
I'd love to take that comment, question, historical review from Dr. Vasquez. Thank you so much, Doctor. We know that the greatest thing, an indicator around health outcomes is wealth. Wealth and health are first cousins. If you're impoverished, you will have a poor health. So agreed 100%, we do need jobs, jobs, jobs. We need better education that's going to drive better jobs. Education is the one factor we know that can make the difference in the overall ability for people to navigate and improve their overall health, the health outcomes, that of their families. By educating women in particular, will mean that you can begin to break the cycle of poverty for their children. And not just in Black and brown communities here in the United States, but all over the world. So education that will drive, that will open up opportunities and better jobs. And even education where an understanding of, information around food and eating and all of that. All of those pieces are important aspects of what would be necessary to change, to transform the impact of or the lack of access to food and food apartheid. I'll stop.
And Rita, that's an excellent way to finish this this panel that is going to reverberate, and honestly, like I'm going to have to really process all of the major just profoundness that you guys have brought into this Food as Medicine Symposium. It has to be based in the context of what you've all just said. So thank you all for taking part. We're just so excited that we had this. I'm sure everybody is going to go away and want the transcript to this to be able to read at night, to be able to go back and think it through even more. So thank you so much, Mary Dale and Dr. Rock, Dr. Chatterjee and Rita. Very excited that we had this and can't express my appreciation. We are going to go right into the next panel, which is actually perfect because we have Dr. Vasquez, who kind of was talking about his program, and a couple of other community health centers, as well as some partnerships with nonprofits. So we're going to kind of get into that nitty gritty a little bit. We also have Jeanette Konzakowski, and she's from Grassroots Gardens, and she is going to be moderating. So we're going to go right into that. I ask everybody that's on the panel to please put your video up so I can spotlight you. So we're starting our next panel called The Importance of Collaboration Among Healthcare and Community Organizations. We are going to be moderated by Jeanette Konzakowski, and I hope I'm not hurting your last name. So Jeanette is, let's see here, I have her, oh shoot. Sorry about that. I'm kind of falling apart at the end of this, this day. Just one second, please, I'm sorry. Here we go. Okay, so Jeanette joined Grassroots Gardens of Western New York in 2018. She's a longtime community educator and activist, bringing almost 20 years of experience with nonprofit organizations such as the Center for Development of Human Services, Crisis Services of Buffalo and Erie County, and the Boston Area Rape Crisis Center. Jeanette has spent 5 years as the Western New York Community Leader for Change for Breast Cancer Action, and she's thrilled to be combining her personal passion for gardening with community development. She's focused on building grassroots garden organizational capacity and sustainability. So welcome, Jeanette, and I'll have you introduce the rest of our wonderful panelists.
Great. Thank you so much for having me, Marla. Hi, everyone. What a fantastic conversation today. I've been at another event, so I've been popping in and out this morning, and I've just been so happy to be able to catch the last piece of this. Very happy to be participating with this particular panel today. Grassroots Gardens, for those of you that don't know us, are supporting the community gardens in the cities of Buffalo and Niagara Falls. 90% of our member gardens are growing fresh food, herbs, and vegetables, all available at no cost to city residents to participate in. Really wanting to think about the way that the pandemic has not only highlighted the ways in which people are reliant on places like community gardens to get fresh food that otherwise they might not have access to. But this food apartheid was here before the pandemic, and it will be here after. It's only increased more. So we're looking at ways that what we're going to be talking about today is ways that we can develop community collaborations focused on growing food justice and food as medicine in our region. I've been especially excited for the work happening that we've been doing at Grassroots. Dr. Sarah Ventry, who I saw is here, and Dr. Melinda Cameron. They are hosting our first indoor demonstration community garden at Niagara Street Pediatrics. And for the last year, we've been deepening our relationship with the medical campus, both through our therapeutic garden task force and through their health equity work. So today we are going to hear from 4 local practitioners in the food as medicine movement about the how and the why to deepen community partnerships. First up, wanted to mention that unfortunately Dr. Levan Anasari from the Buffalo Community Health Center was unable to join us. We are grateful that Carla Thomas is here. Carla is the Director of Outreach and Marketing for the Community Health Center, Buffalo, and she was able to step in instead. Carla holds a Bachelor of Science in Human Resource Development with a minor in training and a Master's of Arts in Organizational Leadership with an emphasis on emotional intelligence, both of which are from Medaille College. She is the former chair and political operative of Grassroots Incorporated, not to be confused with Grassroots Gardens, and has over 20 years private and public experience in human resources, including having acted as the former Director of Human Resources for the Erie County Water Authority and the former City of Buffalo Commissioner of Human Resources. Welcome to you, Carla. I will also add that she is a board member of UGMA and a proud graduate of Leadership Buffalo and the Women's Campaign School at Yale. Her daily mantra is, if you are blessed to see the ceiling in the morning, be a blessing to someone else by nightfall. Also welcome to the panel, Dr. Raul Vasquez. He is the president and CEO of G Health Enterprises and a recognized leader in the healthcare innovation and delivery. Dr. Vasquez is a graduate of the University at Buffalo School of Medicine and Biomedical Science, as well as Fordham University. He founded Urban Family Practice and G Health Enterprises with his wife, Mrs. Tony Vasquez, understanding something dramatic had to be done to confront the challenges presented by the healthcare system rooted in reactionary care. He posits that reactionary care is as problematic as it is unsustainable when the outcomes prevent economically distressed communities and communities of color from receiving coordinated health management delivered in a cost-effective and cohesive manner. G Health Enterprises has created a paradigm shift affecting real change in Western New York. Next up, we have James Thompson, who is the Health and Wellness Program Manager at Evergreen Health. James received his Master's of Public Health at the University of Buffalo School of Public Health and Health Professions and has been working at Evergreen Health since 2012 in many different frontline roles in the agency's wellness department before becoming the program manager of the Thrive Wellness Program in 2018. Since leading the Thrive Wellness team, James and the team have grown their program to include over 150 patients who engage in health promoting programming, delivering results for their patients, including lower A1C cholesterol and PHQ-9 measurements. And finally, we have with us Jen Regan, who is one of my colleagues on many of our Niagara Falls projects. Jen Regan is with the Cornell Cooperative Extension of Niagara County and has worked for them since 2013. She is the program manager of the Veggie Van Mobile Farmers Market, which serves Niagara County, and is also the manager for the Western New York Food Incubator, a commercial kitchen and food entrepreneur space housed in Lockport, New York. Currently, the Veggie Van is piloting Pharmacy, a veggie prescription program with SNAP-Ed of Western New York and Niagara County healthcare providers. Jen is a lifelong resident of Western New York and an advocate of locally grown foods, food equity and access, and home and community gardening. So welcome to everyone. And the first thing I wanted to start with is kind of a follow-up to what we were just talking about. And I'm going to start with Dr. Vasquez. What benefit would increased multi-stakeholder collaboration have on the food as medicine movement?
It's in terms of the benefit, it does make you see things differently. I think for us and being more than just a medical practice, we built the medical neighborhood model. So, you know, going into people's homes and seeing what's there, it really, it's an eye opener. Where how people are either cooking foods or eating foods, not knowing what substitutes. And I think the only measure that offices, medical offices, and primary care and behavioral entities it's just on the outcomes, the chronic diseases. You know, you were talking about, you know, hypertension, diabetes. You know, you can't control those without really doing the other pieces. So at least with us, you know, having nutritional classes really eye opens the patients in terms of what they do, learning the health literacy of how to really talk to people, having a chef, having a dietitian, having someone that does exercise. The remarkable thing is that, you know, it's only 10 to 15% of that population that's accounting for 80% of these problems. So if we start working there, at least a point to work, then you work your way down to the rest of the community. And what we found was, and I mentioned earlier, is, you know, we're silver for American Heart, we're gold for diabetes management. And what it's done is having people exercise and provide vouchers. We gave little vouchers for fresh fruits that they can pick up and show them what substitutes are in terms of salt substitutes and things like that. Really simple things that have really transformed people and really reduced their, you know, weight, you know, hemoglobin A1Cs and blood pressure with an engagement. You know, we had, before the pandemic, we had about 200 people to 250 people that use our gym and basically went through these classes on a weekly basis. And then after, you know, after the pandemic, we had to really reverse some of that, but we were able to virtualize some of it, which is interesting. And we're going right back to that now that we were able to get everyone vaccinated. But food is a really, not only one point of the situation, but at least, and the communities where they have access to foods, they'll find that the cheaper foods are often the ones that they have access to. So orientation, I wish we had ways to gauge some of the data that the supermarkets have. And that data we haven't been able to touch, because, you know, if you can profile, you know, in terms of people coming in and figure out what they're eating, and you sit with a dietitian, nutrition, that'll help you really decide what you should be eating, what you shouldn't be eating. So I think as data gets bigger and we really start to get a better idea what people are doing, we can guide them and educate them. Because, you know, you'll be surprised. I mean, and not everyone in the community understands how important food and access to the right foods are. So those are just my comments.
Thank you. Carla, is there anything you wanted to add on this in terms of multi-stakeholder collaboration? I know you're doing so much with the community health centers.
Really, no. Dr. Ansari caught me at the last minute. And so I answered question 7 and question 9.
And I will take you in those ones and come back to you. Thank you. Okay. Jen and James, is there anything you wanted to add on this before we move into talking a little bit more about produce prescriptions?
I'm sure. I would definitely add that having more partners involved could mean we could do more. I like to think I can do everything by myself, and I'm sure others here feel the same. So just considering like what we're doing, making sure we're not, you know, overlapping, but having those partners is absolutely necessary in order to succeed with these the food prescription program.
Thank you. How about you, James? Anything
And
else?
I agree on that as well. You know, we'll be talking about my Thrive Wellness program and other questions, but yes, definitely, you know, community partnerships and, you know, the stores that our patients go to in the real world, corner stores. Like I know there's been a movement around the city to change the layout of different corner stores so that, you know, fruits and vegetables are more in season, more in date, and just right up there instead of buried somewhere in the back. So it is definitely, you know, a community effort in order to get people to be able to walk a little bit more, do more exercise, and have those options available to them outside of programs that we run.
Great.
You know, can I say one more thing just to follow up on that? So, you know, we have a CBO, community-based organization that we have with connections. So one of the things that's real important is the social determined screenings that we do on over 20,000 lives that we manage, you know, we're trying to connect. And I think, like you're saying, it's how do we get all these entities to really connect through a system so that we know the supply and the demand in terms of how to connect people. Not all these not-for-profits and churches have access to connections. And we're creating, you know, we have Holon that allows us with that entity to connect. So we know when people need food, we know what zip codes are there and who's providing the services. And I think that's the disconnect that we have, that we're trying to at least bring everyone together. So while I'm saying me, I've got 220 people that work for me. So, you know, and we're all over the place. So how do we start to connect all these different agencies that are doing great work so that not only the referral gets made, but there's follow-up to that referral. Yeah. You know, and I think that's real important. And not all of us are doing a great job out there. So how do we get everybody to really step in and really do the best we can so that the efforts actually go to what, you know, we get good outcomes.
Yeah, I mean, we at Grassroots, you know, as a nonprofit, we were really looking at ways that we can connect more to food as health, food as medicine, right? Because we've been working on providing the community fresh, free food for 26 years, and yet we're not connected on the health outcome side. And yet here we are growing food and talking to people about how to grow food for their families. And so that's why we were particularly excited for Ventry and Buffalo or Niagara Street Pediatrics. Now, when people walk into the waiting room, families walk in, there's an indoor garden in the waiting room, and they leave with, you know, fresh greens. And they also can scan a little map that tells them where their nearest community garden is to them, so that if we can't be there, you know, there's a way to connect them to our organization. And we're already brainstorming ways to bring this to other offices in the coming years. So thank you for that. Jen Regan, I wanted to ask about what role do you think produce prescription, fresh food pharmacies, and the medically tailored meals play in the success of food as medicine, influencing those health outcomes?
Can I say we have the fun part? I think, so I mean, I know, anytime you get to bring food to people, it's a good time. Absolutely. People obviously respond to delicious food. It's all about getting the right food to the people, right? To everybody. It's in the case of Vegivan in our pharmacy program, pharmacy prescription program, it means getting locally grown vitamin packed produce directly to our program participants. The produce is paired with our, we have registered dietitians with SNAP-Ed who bring the educational piece along to classes. And I mean, it's the marriage of those three things: the community, the education, and the food. So.
Thank you. Open question for anyone on the panel. How should clinicians and or organizations who haven't dipped into this space yet get started? Where do you recommend we start? I know for Grassroots, it came from a call from Dr. Cameron, who I didn't know. I got a request to show up at her office the next day, and I looked her up and realized she was someone very important in the community. Not that I wouldn't probably respond to anyone calling, but I was like, I need to go meet with Dr. Cameron, and I dropped everything to do that, and our partnership came out of that. So, you know, where should people start with these kinds of partnerships?
I think at Evergreen Health, we already have a primary care practice. We already have a pharmacy. And so we have a number of patients, you know, actually the agency has over 5,000 patients under its medical care. And so where we started for a program like our Thrive Wellness program is some of the funding sources already available in there. So, you know, we started up our wellness program from a collaboration with our primary care to have a wellness program so that, you know, we could focus a little bit more on preventive care. As some other speakers have alluded to, you know, preventive care is only, the doctor's visit is one part of that. It's also what their housing is like. It's also how they manage their mental health. It's how they manage their substance use, how they manage their physical health and diet and nutrition. So, so like in my program, we have staff on board who are geared towards doing these health education classes. So we have a health educator who does classes on nutrition, diabetes, heart disease management, the nuts and bolts of how to read your lab values. We have an art therapist who does mental health programming. So using art as the vector of being able to facilitate these sessions, it gives people the ability to express themselves and the ability to work through some of their mental health or substance use challenges. And then we've also partnered with several community partners in the community. So we have a yoga instructor, we have an acupuncture specialist, we have cooking classes, chair massage, Reiki meditation. So we've found community partners to come in on a weekly basis to do these sessions for our patients, to give them the tools that they need, to give them experiences that they can take with them in their daily lives, so that they can live better lives, so that they can improve their health, and on our end, reduce their healthcare costs.
And this is Dr. Vasquez. I echoed the same in terms of, so, within the health home itself, and we've been doing this for like almost 8 years now, is we do assessment. So all our people that are out in the field, and we have about 100 people that are out in the field managing 8,000 lives out in the community, doing assessments and really training them to begin a few steps in terms of the food, so they can do an assessment, find out who needs the food. And we partner with African Heritage. So they would bring all those veggies there. And then we would also, check off what people are getting and taking, so that we could teach them if some of the things that they took based on their medical conditions with the dietitian nutrition made sense. And we kept diaries. So there's a database. When events come up like, Thanksgiving, this year we're going to give about 2,000 turkeys, but we went to the families that don't have access. And I think that's the one thing. We want to do it for everyone, but I think you got to start with the entities that are in most need, and then you work your way down. So that's what we've been able to do, and keep track of all that data. I think the data is really important to find out what's working and what's not. But African Heritage, for the time period that we've implemented on the health home side for the last 8 years, we've had a reduction of ER of 64% and maintained for the last 8 years, and a reduction in inpatient of 84% and maintained over the time period. So it does work when you're trying to coordinate the care, and including making sure that food and other real social determinants of health are being addressed.
And what kind of budget, Doctor or James, do you need to do a program like that? And where do you kind of start with the funding?
Sure. So I can tell you for Thrive Wellness in particular. Before I answer that, though, Dr. Vasquez made a good point about data and how to capture it. And we do that here in my wellness program. So part of the program when a patient enrolls is that they are a patient of our primary care, and therefore we have access to the same electronic health records chart that the providers do. So we can see lab results, we can track outcomes over time, their A1C, PHQ-9 for mental health, their cholesterol, their blood pressure, their weight, and we can help establish goals for each patient with this relevant information. If they have any new healthcare concerns, we can also triage the provider and get quicker response to them. So I can't say that, for a budget, it is going to depend on what you want to do. Certainly, this program has applied for grants and had different grants in the past, but we are operating on a budget that includes 6 staff and all of our vendors and other program costs. So it is, running in the $600,000 range for a fully funded program like this. And even then, we are looking, we just applied for a couple of other grants. We're really trying to look and keep the sustainability of something like this. But Evergreen does believe in a program like this.
Thank you, James. Doctor, did you want to say anything else about the budget?
Yeah, for us is, so next year it's a really big change for my system in terms of G-Health. We actually are taking full risk on contracts. So we're managing $140 million of the Aries dollars. So it's a cost driver within my model. I manage 95% of those dollars. So we'll put as much money as we need to, because it's so important in terms of helping us reduce the costs overall. So I metamorph into a hybrid insurance company now. which is so important so that you know where to really direct these dollars. So
Awesome.
million, 5 million, 8 million, whatever it takes to really do it. But we want to take it right into the communities. So it'll be the homes and things like that. So we'll be talking to some of these other players that are around the table on whether they want to be able to kind of come in and really provide the services that we feel are going to be really change the way these communities are. Because it's who manages the money is that makes the changes. So I think what we're trying to do is make sure that who's doing that looks like the people in the community. And I think, so yeah, you'll see some dramatic changes in the next 2 or 3 years, because that's the only way that we're going to redirect, care to primary and wellness when you manage the dollars and move it away from hospitals and sick care.
Great, thank you, Doctor. And Jen, I wanted to ask you, because I'm assuming CCE's budget is probably around the same size as Grassroots. As a smaller nonprofit with probably less access to that typical healthcare funding, what is your budget? What are you looking at? Where are you getting your funding from to do what you're doing?
Sure. We just started with our SNAP budget and our very tiny veggie van budget, and then we went looking for more money to pursue the pharmacy, the pharmacy program. So the veggie van's been around as basically there to combat like food apartheid and food. I can't say the word. Why can't I say the word? Food access in Niagara County. And then at one point we were also in Erie County as well. So it was a natural fit for us to combine our efforts with the SNAP Ed Education Department here in Western New York to, go into a place where it's not really been concentrated on. So we started a very small pilot in June, and then we were lucky to have just received the Blue Fund grant to pursue a bigger program, robust program for both the veggie van and the pharmacy program in Niagara County. And very exciting. We're so very excited. So
congratulations on that. That's a huge accomplishment. If I could, as a follow-up, Jen, and then we'll open it to anyone else on the panel, what roadblocks do you face around funding? Whether that's, kind of at the systemic level with individual hospitals, with, programmatic issues. What are some of the things that people might need to be thinking about as they're thinking about how to scale up a program like this?
I would definitely look to other collaborators for help with this, because sometimes the right grants are not necessarily there for a nonprofit like a little nonprofit like us. So, but other collaborators might have an in with something else or know of something where they could, help support it. I think that's collaboration. Get out of your silo. Go talk to your friends, basically. Come, anyone, feel free to give me a call. Find people in the whole area of Western New York. We have a huge depth of talent here. So there's a lot of very knowledgeable people to help you.
Anyone else like to chime in on roadblocks that you might face or have faced?
I think one of the roadblocks that you often run into is where it falls as a priority on the decision makers table and what their priorities are. And it really takes a lot of advocacy to either change their minds or get them to move that issue up the priority list.
Thank you for that, Carla. Anything else before we move on to the next question?
Jeanette, we have a hand up with Allison Dahoney, who actually runs the program alongside Community Health Center of Buffalo with Carla. So I think she wants to pop up.
Sure. Hi, Allison. I know Allison well. Please jump in.
Hi, Jeanette. And thanks so much, Carla, for being here. I just have to, and I tell this story all the time about CHCB. I went all over the city trying to get my fruits and vegetables prescription program up and running. And when Dr. Ansari and I sat down for about 5 minutes, she said, she stopped me mid-sentence and went and brought in her finance team and said, you know what, we have to figure out a way to make this happen, whatever we need to do. And that was 5 years ago. Mm-hmm. And, this year we were able to get the Buffalo Bills to even support that program. But initially Dr. Ansari scraped together money from, I really don't know where. She didn't burden me with, she did not burden me with those issues. She allowed me to do what I needed to do and what was best for her patients. And it goes back to what Carla said, the desire was there, because Dr. Ansari really, she wants all of her patients to be healthy. She really, really does. And it shows in all of her programming. So, you know, when you talk about resources, if you're partnering with a physician or a clinic that really believes in food as medicine, they're going to scrape that money together and figure it out. So I just wanted to say that. And we absolutely are so in love with our program at CHCB. And I learned so much from the participants. They tell me what they want. They tell me all the time, I want this, I want that, bring this, where's the recipe? I mean, really, they're my boss. When people say, oh, you have your own business and you're, no, go to CHCB. There's all my bosses right there.
Thank you so much for sharing. Thank you for all you're doing for the community. I know we've benefited so much from your talent and skills and knowledge base that you've brought to the Food Policy Council and GBUG and all the different ways in which we've partnered together. I wanted to toss a question back to those of you that are doing clinical work. As clinicians, have you found that interventions in the clinic were more effective than what might be like a traditional community partnership, or does the setting matter so much as the work? And anybody that wants to chime in on that, feel free to take it.
Sure. So at, again, with our Thrive Wellness program, it's not in the doctor's office, but it is certainly in the same building where patients get their clinical care. So, you know, we have a direct relationship with our primary care. So the doctors refer patients to our wellness program for their physical, mental health. And then people can come as frequently as they like. You know, they can come once a month for different programming. They can come every day. As I said, we have access to their medical charts, their lab values. We can add to that chart ourselves by taking blood pressure. All of our session notes are in there. And, you know, all of the things that we offer. So for stress management, art therapy, yoga, acupuncture, etc. A new thing that we've started this year is this summer is our diabetes initiative. So Evergreen identified a number of patients that had very high A1Cs or were newly diagnosed with their diabetes. And so we were able to show that we have success with these patients. So we've been able to bring on in the last month a registered dietitian to our team, as well as a peer navigator to help enroll people and keep them connected. So they meet once a month with our nutrition educator, and they learn about different aspects of nutrition, you know, fruits and vegetables, whole grains, how to establish better shopping patterns. And they also, as part of the incentive, they get a gift card each month to buy supplemental groceries at a local grocery store. And we have like a foods list that they can choose from. It's very expansive, but it not only do they learn about what they should be doing for their health, and they learn about nutrition from our registered dietitian, but then they can put those new skills into practice by getting some supplemental income each month from our program so that they can buy healthy foods. So we hope that, you know, when someone's enrolled for a year in our program, they've met every month, that they can develop hopefully those healthy shopping habits for life. Great. So ours is definitely a clinical setting, just not directly with the doctors.
Yeah. You know, this is Dr. Vester. So, you know, urban family practice, I started 25 years ago. I'm the oldest practice on the West Side, and probably the oldest Black and brown physician probably on the West Side in terms of how we've done that. So it's always been important to me to integrate, you know, the box, because I think too many facilities are a box. And I always say, if you're a box, they put nails and bury you. You really have to extend out of that model. And I think for us, is by moving to a financial model where you're managing all the lives, it's one thing to say that you do things, The second thing is you got to prove it. It's got to be outcomes. And I think if you're going to partner with these entities, I don't like the grant concept, you know, because you're always going back to the well. When you're doing something well, we have to figure a way to create sustainability. And when you're managing a contract, as part of that contract and a full risk contract, you have to have, you know, social determinants of health factors. So that's why food becomes a real important, how we fund it. But I think overall, if you look at our data, this is state data. It goes right to the state. And we have 27,000 lives. We, in the last year, generated $6.4 million in share savings within 4 contracts. And we were in a level 2 contract. Those dollars go back to these provider groups. And we're more, so I'm talking more in the private sector. So we're all private physicians, private practice, inner city. We're not, you know, hospital clinics. We're not FQACs, a little bit different. So for us, we were able to show that at the state level, and the impact of those dollars will be that you can grow and do other things. And I think that's the key, but you don't want to be attached to grants. I mean, they're a good thing, but if that's all that does to sustain your models, you won't survive. And I think as healthcare evolves, those things are going to dry up more. You know, hospitals, the way you see them today, in the next 5 years won't exist. Most of the people around the table may not be who they are today. It's going to be evolved. But if you don't kind of attach all these things and look at long-term outcomes of what you're doing, it becomes, you know, you won't, you know, it's going to change. The economy of this country is changing in front of you. If you're not looking at supply chain, if we don't start doing something to collaborate with systems that are really having an impact, we're in big trouble.
Thank you, Doctor. Thinking about the interventions, because both Dr. Vasquez and James, you've mentioned nutritionists, gyms, the food itself, alternative complementary therapies. Is there any one of those interventions more than another that shows more evidence-based as being the most significant in the food as medicine movement? Are they all equally important? You know, if somebody's looking to start new, what is the greater return on investment? Is there one intervention in particular that is really the best to start with?
I would say that both of those components, nutrition, exercise, both are very important. Also, the built environment that people live in and the kind of default options that are available to them. If you were to pick one, you know, intervention to start with, I probably would go with nutrition education and the ability to get people to start establishing better eating and shopping habits because of the old saying, you can't out-exercise a bad diet. So both are important, but you know, if there's one to start with, it would probably be on the nutrition side, as well as, of course, in a bigger, grander scale, the people's environment that they're living in.
Great, thank you. Yeah, anyone else care to weigh in on that one?
Yeah, Dr. Vasquez, prevention. I think prevention, you know, we've done a needs analysis in this area, and unfortunately in some zip codes, there's no sidewalks, people can't get to work, you know, crime makes things very difficult. Some have deserts, they don't have access to those foods. So I think we have to really try to do both. I don't think just the food is going to do it. You got to get people to exercise, because obesity, if you don't get that down, I don't care how well you do it, it affects diabetes and the resistance to insulin. So I think it's important to teach those habits early on, especially in kids, because if you look at the kids and the parents, they will become their parents. So how do we begin to do this at an earlier stage? Because I mean, right now you can pretty much predict how many jails to build based on the Black and brown that live in certain zip codes. The same formula has to be flipped, but I believe both have to be real important in this whole process.
Thank you. James, I'd like to bring it back to you with a question on sustainability and engagement. How do you, as you're working with different community partnerships, what are you doing to deepen those relationships and to really be able to sustain them over time?
Right. So with our, you know, we keep our patients engaged in a number of ways. You know, we try to make wellness fun for them. So, you know, it's not just coming for health classes. It's also, they can come for the acupuncture. They can come for our yoga class. They can come for our Reiki meditation or chair massage. We also do a lot of challenges for our patients. So we have like walking challenges, step challenges. We have, you know, incentives for attending a certain number of programs per month. So on the patient side of things, you know, we keep them engaged with that. We by making a environment that they want to come to. On the provider side of things, we keep them engaged by the fact that we see their patients probably more than they do, because let's say many of our patients see their providers roughly every 3 months or so, some of them longer, some of them less, but we see them even more than that. So we can pick up on things earlier on that the provider should know about. We can, so we have a lot of two-way dialogue with the providers. And in terms of more community collaborations and other organizations that do similar work, although Evergreen doesn't have an official partnership with Mom's Meals, that is a service that our providers and our care coordinators know a lot about. And so we can help patients get enrolled in that service if they have, diabetes that needs to be better managed, or they have, limited ability to cook, or any other reason why they would qualify for a program like that can deliver meals to their home on a weekly basis that are proven to have high nutrition. So, we also reach out into the community so that our patients can get good wraparound services.
Great, thank you. I have a question for Carla. Carla, I'm wondering if you can elaborate on how we prove the value of food as medicine. So we talked a little bit about the outcomes that we're looking to measure in clinical trials and studies, but what is that thing that you think is most important for that proof of, or that evidence basis?
Well, I think by just looking at the facts, that food has been used as medicine since the beginning of time, and whether Big Pharma wants to admit it, sometimes food and herbs can have rival medicinal success and work just as good and sometimes even better than expensive pills, because foods work proactively and prescriptions work reactively. Mm-hmm. And so medicine oftentimes runs the possibility of harmful side effects with long-term use, while food is a natural medicine. It is life-sustaining. Its properties work in conjunction with our very makeup because it comes from the same dirt or soil that we as humans come from and will eventually return to. And so the outcomes, we've been discussing them right along, reduced A1C, stabilized and normal blood pressures, weight loss, cholesterol numbers. But one of the things that we see is patient complaints of pain due to inflammation. When a lot of times there's medications that cause inflammation, or you take something to address inflammation and it sets something else off. And so when patients who have been chronic complainers of pain that was due to inflammation, when those things begin to subside, and it's because that they're taking advantage of different programs, education, and increasing foods in their healthy foods in their diet, that also is an outcome that's measurable. Increased energy and physical activity, mental acuity. Another thing is the types of appointment requests outside of your annuals. Mm-hmm. When you have patients who are, every month they're calling with something, and it's not your annual, it's something. And all of a sudden those calls begin to diminish. That is a measurable outcome. And if doctors are looking at what they're prescribing, reduced milligrams on blood pressure and diabetes and other chronic disease medicines. And another thing is patients' participation and higher accountability for their health. When they start to ask for or seek information about what to eat, they've gotten into the mode of eating healthier, and they're participating in classes, as well as how many stuck with the changes that they implemented for how long. And so, of course, Dr. Vasquez talked about reduced hospital admissions. But one of the other things that I think organizations or people such as those on this Zoom meeting have to kind of put somewhere on their radar is to start visiting corner stores to ensure that the quality of food that is being sold there is good quality food. that the environment that the food is being sold in is clean, and just those type of things, because there's a lot of corner stores where that's not the case. The environment where the food is being kept, you know, how long it's been there, you know, is it ripe and they're still selling it, you know? So, I mean, those are the kind of things, that's something that's kind of off the beaten path of outcomes, but it's one that is responsible for outcomes, because sometimes those corner stores are where they have the most access to fresh fruits and vegetables.
Thank you so much for that, Carl. I mean, even that, I was thinking, you know, one of the things that we often see people so surprised by when they come to visit the gardens is that there are more than orange carrots, right? And more than red potatoes. And people forget that the food that's in the convenience stores or even a full service grocery store are there because they can be stored easily, you know, and there are thousands of varieties of fruits and vegetables and so many different kinds of tomatoes. And people don't have that education, that knowledge, because they don't know where their food comes from. Unless they're growing it themselves or they're living on a farm, there's a disconnect from, you know, that piece you talked about with food coming from the earth and us coming from the earth and going back to the earth. And we're so disconnected from that, I think, in our current society, that we really lose sight of that. So thank you for sharing all of that. So important. I think we're going to kind of come to, I guess, the final question here so that we have a moment or two for questions. So I'm just going to ask this to the full panel. Anyone feel free to chime in here. If have you assessed with your patients, what are their barriers to good health and nutrition? What are the things you hear about predominantly? I know, you know, Dr. Vasquez, you talked about the social determinants of health. How do we start addressing some of these other issues that go hand in hand with access to good nutrition?
Yeah, I could start with that. You know, so we do assessments on the population. We did 8,000 assessments on the social determinants of health, pull the data, and then just figure out what people are asking. Because, you know, and what we found was, you know, out of the data, a good portion of people were still talking about transportation. You know, so not so much transportation to get to the office, but other things they have to get to the Department of Social Services and to get to food sometimes too. So you know, that is another piece that really needs to be attached to what we talk about. I think housing was still a red flag that popped up in transitional housing is very difficult. You have people that are in hospitals that should be within home structures. And I think that to be the biggest thing. Food, as we talked about, became a major issue. Others also legal with regards to a lot of the things that are involved in the community. So how do we get them? They may be in a house that's not being managed well. They want to be evicted and you know, things like that are real important. The things so those things kind of shoot out at me based on the data, but it's real important to ask them in their language too, you know, so, you know, we speak 18 languages, you know, how do we get, because different communities are all encountering different things, at least in the Buffalo area. And so, you know, we partner with Jericho and so we were able to kind of really do a lot of the informational, but those are the things that we found based on screening from individuals that was need in the community still for.
Thank you so much, Doctor. Carla, would you like to have any final thoughts on other barriers that you might see, anything different than what Dr. Vasquez shared?
Well, one thing I do want to do is to take this opportunity to publicly thank Allison for the work that she's doing with the Community Health Center. It has made a tremendous difference. The employees, the patients, and the community look forward to that truck coming on Thursday. They're waiting with bated breath. But I don't think I have any other comments other than just to say this was really a good hour of conversation. I'm so sorry I wasn't able to get on earlier, but I had to do my other job. And so I just want to say I've enjoyed being a part of the panel, and I'll make sure I let Dr. Ansari know what a wonderful event it was.
Thank you, Carlin. You know, I think those the urban farmers in Buffalo are such a treasure. So, you know, we have Allison, we have Alex at African Heritage Food Co-op that has a community garden with grassroots, and they're using that as a market garden model to teach other people. And I know that they've been working to bring their food into the community in all kinds of different ways. I feel like we partner like with Buffalo Freedom Gardens, and Alex is going to be providing food boxes, food subscriptions for the holiday season so that Freedom Gardeners have fresh produce even on the off garden season. So we're just so grateful for our farm partners. James and Jen, anything that you wanted to add around those, thinking about the bigger issues that connect to food as medicine, and where there's still obstacles that we can address as a community? Anything not been mentioned that came to your minds?
Yeah, absolutely.
James, go ahead. Sorry.
Yeah, so I mean, you know, patients of Evergreen as a whole do come from underserved populations. There are many barriers. Money, transportation, as Dr. Vasquez says, that is a big one for our patients. Living in a food desert, managing many different types of comorbidities, physical and mental health conditions, making it harder priority to get to the grocery store, health literacy and knowledge around having a healthy diet, family commitments, work commitments, childcare. So we assess patients, and try to make patient-centered solutions for them. So questions on all different types of program assessment forms on what are their barriers to programming. For enrolling people in our diabetes program, we gauge their health literacy coming into the program so that we can really tailor smart goals for them. And then, we want to work on their goals, where they're able to shop, what their, we try to gauge, what their neighborhood looks like, safety, walkability, what kinds of stores they have access to. And then Evergreen has many types of partners within our Evergreen umbrella to help with this. So we have our community access services. They're located on Bailey Avenue in 14215, and they serve primarily communities of color. The Pride Center of Western New York is part of the Evergreen Association, and a major force in our LGBTQ population. And so at our community access services, they also have a food pantry on site, as does our Elmwood site. So we try to provide that one-stop shop for them, and really gauge how we can best help them and what each patient brings to the table.
Great, thank you, James. Jen, anything you wanted to add in conclusion?
Sure. I know we've mentioned it before today, but I think a very important part of any food prescription program is education. People, if they don't know how to make a food or use a red potato or a rutabaga, they're not going to eat it. So getting people like in cooking classes together, making sure they have the right things to cook with, the right education, making sure you have the right kind of food. Maybe not everybody wants to eat leeks, so yes, they might grow well here, but not, you know what I mean? You've got to have the education, and starting off with kids is definitely something everyone's been saying today. If you get kids to make food, they're going to try it, whether or not, it's green, purple, or some other broccoli-based thing they don't like. So make sure,
kale, that smoothie bucket is like the best money grassroots ever spent, because we have
smoothie, but right, you could put anything in that smoothie.
They're not going to touch kale if you just show them what it is, but you put it in a smoothie that they get to make on the back of a bicycle with their pedal power, and they will line up blocks to make smoothies with kale.
Just put some blueberries in there, they're all set. But yeah, and just trying to make it attractive to people, and not so much like you have to do this, like you want to do this, you want to eat this delicious food, let's make these awesome sweet potatoes, like let's do this. So
yeah, I mean, that's one of the things that, at Grassroots, we've really been focused on. Even just in the vegetables that we order, we try to make sure we're providing culturally specific seeds and crops to many of our community growers. We have 6 gardens that are fully led by refugee and New American immigrant community members. And so we're looking to make sure that if it can grow in Buffalo, we can get the seeds for it. And we partner with groups like Baker Creek Seed to provide those seeds. We find that collards, tomatoes, peppers, and cucumbers are still our top 4 crops every season in Buffalo, and that has not changed much in the last 10 years, I don't think. But you have to have what people want to eat, and so that it is something that I heard Dr. did Dr. Chef Mike talk about earlier this morning, right? Is that it has to be something people want to do, not feel forced into doing. So Marla, I don't know if we have time for any questions from the community or not.
If anybody wants to, we have time for probably one more question.
Feel free to unmute yourself if you have a question for the panel.
Well, I answered number 9. So I
would you like to go ahead, Carla? Go ahead.
What was number 9?
Yes. It's how can doctor or physician groups advocate for change? And Dr. Vasquez talked a lot about data. And what I was thinking about was one way is by pooling and sharing data that is directly linked to the reduction of Medicaid costs. Because reducing costs is always the best tool, you know, no matter how you look at it, for securing change, you are going to be looking for, barring none, what is the bottom line? How much is this going to cost, and how much money can we save? And so the scope of advocacy, it has to reach into those silos where the decisions are made and get to the table. So the best way to do that is to build coalitions. And so, you know, there's different kinds of relationships that you may never think of to attain that, like partnering with block clubs and supporting community projects. Block clubs are really powerful advocates. They really are the voice and lifeblood of some communities, especially communities of color. And their leadership is often connected to local, state, and federal elected officials, who gives them a voice at decision-making tables. Doctors have their own local and national groups that possess tremendous power, especially since here of late, they all seem to be going into little groups together, or I guess to expand their respective practices. Unions are extremely powerful and united if you tap into their leadership. And, you know, unlikely places like the barbershop in communities of color and beauticians and small businesses, there really is no entity that is too small to help make a difference. And so lastly, I said the Black church is like a haven for advocacy. The bottom line is there's strength in numbers, and advocacy is the mother of change. And by coming together and creating movements with widespread strongholds, the work is seldom done in vain.
Thank you, Carla.
Wow, I think that that's a wonderful way to wrap up this. Carla, I'm glad you answered number 9, because that was the one that really hit on a lot of the points that we're talking about. You know, we're talking about the fact that we have this symposium, and hopefully coalitions can come out of this, and partnerships and joining together. Now, one thing I just have to say is that I love how there's basically three van mobile market programs that we've featured. The Veggie Van through Cornell Cooperative Extension, Urban Fruits and Veggies from Allison, and African Heritage Food Co-op that has their mobile vans. How amazing that we have mobile food markets now, you know, I mean, the last like 7 years, and let's make these sustainable. Let's not have them always dependent on grants. Like, let's put some money into this, because getting out into the community and gaining that trust of the community, seeing what they want our farmers to grow, because we have Providence Farm Collective, they're growing crops that they had in Africa. So we can actually have crops that are culturally appropriate to the new, you know, refugee populations that are coming into the West Side. And, you know, so we can do this. It's just all about trust, communication, and coalition and partnership. And so I hope, I really appreciate this group coming together and sharing what you guys are doing. You're on the ground, you're doing that bootstrap stuff, and thank you for all of your work. Always scrapping together a couple pennies to get great stuff going. So thank you, we really appreciate it. And we're gonna step right into this great way of ending this. Basically, we're gonna have 2 breakout sessions where you can go in and you can start talking this out, okay? So the first one that we have is called Transforming Food Systems for Health and Equity. So we've actually, there's the conversation with Rita and Marydale and Avec and Robert was talking about how the food system was broken. So food as medicine strategies can connect to emerging initiatives to efforts to build greater sustainability, equity, and resilience in the food system. Join this session to learn about value-based purchasing strategy, such as the Good Food Purchasing Standards and Anchors in Action Coalition, and how food is medicine initiatives can align with these efforts to create new opportunities for community health and wealth. It's going to be a great session run by Betsy Skoda from Healthcare Without Harm. And then we have a future directions, next steps in collaboration and building coalition. I think this is going to be a fabulous group because we have Dr. Ken Snyder from Kaleida Health, so a health institution. Allison Dehoney, who you've seen is an activist and she's got a nonprofit and she's, you know, right on the ground. She knows her stuff. And then you have Michael Ball from Highmark, who's a part of the healthcare payer. These three different, you know, groups have to start working together to make these changes. So they're going to really like dig into that. So basically what we're going to do is we're going to put out, you self-choose what group you want to go into. And this is the time for lots of talking. The Transforming Food Systems for Health and Equity has a bit of a presentation to give everybody a basic on what the, you know, what the food system is all about right now, but we've got a great expert in there. So thank you all. And we're going to come back. We really want to finish up. So please stay with us through the breakout session and we'll see you in a little bit. And enjoy. Hello, everyone. We're all back from our breakout rooms, and I'm sure that our breakout rooms were amazing. I know that I loved hearing Betsy Skoda talk, and we had, you know, actually it finished up too fast. We just started to get into our discussion, which is always a shame. But I just would like to just wrap this up, because I think we've had such a really nice day together. I hope there's been a lot of aha moments. I hope that we are going to continue the discussion. I hope that the breakout room for future, I can't wait to hear what our future plans are that you guys all develop together. So what I want to wrap up with is just a tremendous thanks. First, I want to say that we're going to be putting out a survey to everybody, and please take a second to do that. It'll be on SurveyMonkey. We are going to have a resource list that's going to go out to all participants. So, you know, if you have any questions, please reach out to Beth or I, and our emails are right there. And I'd like to go to the thank you slide. So first off, this was a work of love. Like, this was an amazing experience to make this this symposium and gather all these people. And I just have so many thanks for our symposium planning committee, Allison Dehoney, Shannon Philbrick, Dr. Susan Orange, Marydale DeBoer, Dr. Catherine Levine Major, Dr. Kenneth Snyder, Dr. Roseanne Berger, Dr. Sarah Venture, and Matthew Zahn. Thank you, thank you, thank you, thank you. We also have to give great thanks to Betsy Skoda and Healthcare Without Harm. They've been such great consultants for us from the beginning. Dr. Ken Snyder, I got to thank you again. You've just been the ultimate champion for BNMC and our work, and you know, you really put that up. And also the Great Lakes Quality Institute, which I hope that you had a good chance to introduce at the breakout session, but you will see that with our resource list to get a little bit more information on that. We want to thank Annette Pender from Buffalo Healthy Living. She had a wonderful article and did a lot of work to, you know, bring out our symposium to the masses. And then our moderators who did an amazing job, Jeanette Konikowski. Gosh, I'm so sorry, Jeanette, if you're still on, I kill your name every single time. Dr. Roseanne Berger, Dr. Michael Morales, Dr. Lisa Jane Jacobson, and Dr. Gary Giovino. All of them are really pivotal to making the connections and the introductions that were needed. So thank you very much. We really look forward to the second annual Food is Medicine Symposium. So I hope you all have a lovely Saturday night. And if you're in Buffalo, it looks like the sun's coming out. Thank you.
Congratulations, everybody. Thank you.
Great job. Congratulations.
Thanks. I wish we could, I don't know, go out like Saturday Night Live where we're all together and, you know, but we can't. So we'll just pretend. Next year it's going to be in person. Okay. Take care. Thanks, everybody. Bye.